In this talk, I want to give you guys a solid introduction to prostate MRI and briefly discuss PI-RADS. We won't have time to discuss the finer details of PI-RADS, but I've included a link to the PI-RADS document in the description below the video that you can read if you're interested. But in this video, the focus is going to be to give you what you need to start reading prostate MRI. And to do that, we're going to have to go through a bit of background, including what a typical prostate MRI protocol includes, and then we'll look at MRI images together to go over basic anatomy, some common benign findings so you know what normal looks like. We'll talk about what cancer typically looks like, and then we'll review PI-RADS scoring. At the end, we'll go through an approach to prostate MRI, and then we'll apply what we've learned in a couple of cases. Before watching, I strongly suggest you watch the Introduction to Abdominal MRI video, which covers some clinically relevant MRI principles that you need to know. So why is this topic important? Well, prostate cancer, as you know, is very common. It's one of the most common cancers in men. But a good proportion of prostate cancers are considered clinically insignificant. These are cancers that have very low metastatic potential and are cancers that men will often die with rather than die of. And then, of course, there are prostate cancers that are more aggressive or considered clinically significant, and these need to be treated. So our goal is to improve detection of clinically significant prostate cancers before they spread so that they can be treated. So how do we define which lesions are clinically significant? One of the things that we can look at is the Gleason grade. Put simply, remember, as most of you know, when we use the word staging, we're talking about where the tumor has spread. And when we use the word grade or grading, we're talking about how abnormal the cells actually look. And an important concept for prostate cancer is the most common tumor grading system that we call the Gleason score. This is a score based on the microscopic appearance of the glands in the tumor, where 5 is the most aggressive or highest score. And the overall Gleason score is the sum of the two most common grade patterns, expressed as the most common pattern first. So the maximum is a 5+5 or Gleason 10 lesion. Also, since the most common pattern is expressed first, a 4+3 lesion is more aggressive than a 3+4 cancer, even though both have a total Gleason score of 7. And so how do we define clinically significant prostate cancer? Well, unfortunately, there's really no standard definition, but the definition used in PI-RADS is up here on the slide. An easy but definitely oversimplified way to think about it is Gleason 7 or higher is going to be clinically significant, and Gleason 6 is highly unlikely to be clinically significant. And what is interesting is that prostate MRI is actually pretty good at identifying clinically significant prostate cancer with sensitivities and specificities around 80% in the literature. So that brings us to prostate MRI. And I don't want to go through a whole history lesson here, but essentially prostate MRI used to really only be used for staging in patients with known cancer. With advances in technology, there has been improvement in detection of clinically significant prostate cancer with MRI. So now, it's not only used for staging, but also used to detect clinically significant prostate cancer, characterize it, and provide image guidance for biopsy or focal therapy. And then, to standardize all of this, we have PI-RADS, which stands for the Prostate Imaging Reporting and Data System. And this first came out in 2012 and then was subsequently updated with version 2 in 2015 and then recently version 2.1 in 2019. Ultimately, this is designed to standardize all things prostate MRI, mainly the acquisition, interpretation, and reporting of prostate MRI studies. Although we're briefly going to talk about some of this today, we're going to mainly focus on the interpretation piece. It's important to know that PI-RADS version 2 first introduced a simple algorithmic approach to interpreting prostate MRI, essentially simplified rules that included specifying the dominant sequence in each zone, namely diffusion-weighted imaging in the PZ or peripheral zone and T2-weighted imaging in the TZ or transition zone. Version 2.1 made further updates and attempts to make further improvements to this, mainly based on some of the shortcomings in version 2. And once we go through some of the basics, we're going to review the version 2.1 algorithm. But first, what does a typical prostate MRI protocol look like? What images do we acquire, and what images are we looking at when we look at a study? Well, first of all, prostate MRI can be performed on a 1.5 or 3 Tesla magnet, though 3T is preferred in most situations. At minimum, a multiparametric prostate MRI examination should include the following sequences. A T2 weighted axial sequence, generally a small field of view to cover the prostate and seminal vesicles only, like this one we have over here, where you can nicely see the zonal anatomy with the TZ and the PZ, and we'll get to that later. And then a T2 weighted sequence in at least one orthogonal plane, so coronal or sagittal, or both. Next, very importantly, we need to acquire diffusion weighted images, and specifically with a high B value. So PI-RADS specifies a B value of 1400 or higher. ADC maps are also calculated based on 2 lower B value acquisitions. If some of this isn't making sense, again, I suggest watching the Intro to Abdominal MRI video to understand some key basic MRI concepts. You also want to acquire a T1 weighted pre-contrast image, mainly to look for hemorrhage, and then dynamic post-contrast acquisitions or DCE images. These are usually rapid T1 weighted gradient echo sequences that are acquired before, during, and after gadolinium is given, with a temporal resolution of less than 15 seconds for at least 2 minutes. And lastly, at least one sequence should cover a larger field of view to the level of the aortic bifurcation. For example, at our institution, we perform a delayed post-contrast acquisition of the pelvis to look for lymph nodes, but other institutions may acquire a wider field of view T2 weighted sequence. If this is complicated, take a step back and think of it like this. Essentially, you have your T2 weighted sequences. This is a T2 weighted axial sequence here. You have your diffusion weighted images. Here you have a high B value DWI sequence on the left and the ADC map on the right. You have your T1 pre and then dynamic post-contrast images with the DCE image shown here, and then at least one wider field of view image to look for nodes. Okay, so now let's look at a real prostate MRI study, look at the sequences, and then look at some basic anatomy. Okay, so this is a prostate MRI. So again, a protocol will include our T2 weighted images, so our axial T2 weighted image here of the prostate. You can see how you can see the zonal anatomy quite nicely. Here's an example of a coronal T2 weighted image, so we want at least one orthogonal plane. So then we have our diffusion weighted images, so we have our high B value DWI acquisition here, and our ADC map down here. Okay, and then we want our T1 pre-contrast study. So you can see the prostate here, generally looking for hemorrhage. And then we have our dynamic post-contrast study before, during, and after gadolinium administration. Then we have one wide field of view acquisition. So this is from at least above the aortic bifurcation and of the entire pelvis to look for lymph nodes as well as other abnormalities, including looking at the bones. And so those are the core sequences that we need to acquire when we're doing a prostate MRI. So let's now talk a little bit more about the anatomy, and we'll start with the prostate itself. So first, we separate the gland into 3 levels. So we have from superior to inferior the base of the prostate, the midgland or mid-prostate, and then the apex at the bottom or inferiorly. And you'll notice that again on these T2-weighted images you can see the zonal anatomy quite well. So we have our TZ or transition zone here with these BPH changes, and we have our peripheral zone or PZ out here. So generally the peripheral zone on T2-weighted images is pretty homogeneously T2 hyperintense, okay? And the vast majority of prostate cancers, about 75%, are going to happen in the PZ or peripheral zone. In the transition zone or TZ, about 25% of the cancers are going to happen here. And so again, the TZ is the site of all of these BPH changes or benign prostatic hyperplasia changes, and we'll talk about what that looks like a little bit more later. So all of these changes here are BPH changes. Anteriorly, although it's compressed here, we have the anterior fibromuscular stroma. Okay, and the anterior fibromuscular stroma has no glandular tissue, so it's going to be completely T2 hypointense. And posteriorly, we have the central zone, or CZ, which are these paired wedged-shaped T2 hypointense areas that are posterior and surrounding the ejaculatory ducts. If I show you the coronal images here, this here is central zone. Okay, and you can really appreciate the wedge-shaped nature. When there are less BPH changes, it may come more inferiorly like this, but again, it should be pretty well defined and wedge-shaped rather than have any convex borders here as well. And so this is important to know because one could easily, at least on these T2-weighted images, think that there is something here in the PZ. But if you know your normal anatomy, you know that this is just compressed CZ or central zone. And then each of these zones, so the TZ, PZ, CZ, and anterior fibromuscular stroma, so the 4 of them, can be separated into sectors. And we'll talk about the sector map a little bit more, but very briefly, the most important are that the transition zone can be split into anterior and posterior TZ at each of the base, mid, and apex for both the right and the left gland. And the peripheral zone can be separated into the anterior, posterior lateral, and posterior medial gland on each side, again at the base, mid gland, and apex. One thing that's important to know about the prostate is that it's actually not surrounded by a true capsule. Although people will often refer to cancer spreading out of the prostate as extracapsular extension, there's really no actual true capsule here. Instead, there is a condensation of pelvic fascia along the periphery, and you can see this T2 hypointense band here. Another structure that people like to refer to is this hypointense line between the TZ and the PZ, and that is referred to as the surgical capsule or pseudocapsule. Again, that's just compressed tissue. Other anatomy that I want to point out on the sequence includes the seminal vesicles here. So we have the right seminal vesicle here and the left seminal vesicle over here. The neurovascular bundles run at the 5 and 7 o'clock position along the prostate and enter the prostate at the base and the apex. So those are potential areas of extraprostatic extension. This here is the bladder. So this is urine here, and this is the bladder wall. That's pretty T2 hypointense. Back here is the rectum. And then, of course, we have our nodal stations if we look at our wide field of view images. So we have our retroperitoneal nodes up here. We have our common iliac nodes that would be around the common iliac artery or common iliac vasculature. After the bifurcation, we have our external iliac nodes that run along the external iliac vessels, as well as the internal iliac nodes that are along the internal iliac vessels. We have our obturator nodes here. Other important nodes to note are the mesorectal nodes, which are going to be around the rectum, and we might see on our T2-weighted sequences, as well as our inguinal nodes here in the inguinal regions. And we'll talk about staging later, but the common iliac and retroperitoneal nodes are considered metastatic, as well as the inguinal nodes. And the internal and external iliac nodes, the presacral mesorectal nodes, obturator nodes, and periprostatic nodes are considered to be regional nodes. One important thing to understand about prostate anatomy is the sector map. This is important to understand to be able to communicate the location of an abnormality that you spot in the prostate. And so the prostate sector map is included here with the sectors described here on the left. But if you're going to remember anything, try to simplify it. The TZ is split into an anterior and posterior sector at each level, namely the base, the mid, and the apex. And the PZ is split into the anterior, posterior lateral, and posterior medial at each level of the base, the mid, and the apex. And of course, you're going to have these on each side, so on the right and on the left. You also have your anterior fibromuscular stroma here in blue at each of the base, the mid, and the apex. And then you have your CZ or central zone here as well on each side. If these numbers and this sector map looks too confusing, again, just simplify it. For the vast majority of lesions, you're just going to need to know how to split up the TZ and PZ. Again, the TZ into two with the anterior and posterior at each level, and then the PZ with the anterior, posterior lateral, and posterior medial at each level. A very basic principle that you need to understand is what most prostate cancer looks like. What are we looking for when we're looking at prostate imaging? Well, most of the tumors that we image are going to, one, restrict diffusion, so they're going to be bright on high B-value DWI, and they're going to be dark on ADC maps. They're generally going to be homogeneously T2 hypointense, and with gadolinium, they're going to enhance. So this is an example of a cancer. So you have your T2-weighted image here, you have your ADC map and your DWI, and we have a cancer here that is hyperintense on the high B-value DWI and hypointense on the ADC map. It's in the posterior lateral peripheral zone here, and it's homogeneously T2 hypointense. Of course, it's not always that simple, and that's why we have PI-RADS. And PI-RADS has specific ways to describe lesions on each of the sequences, and a simplified algorithm that helps us assign a PI-RADS assessment category indicating how likely clinically significant prostate cancer is for that particular lesion. And these PI-RADS scores from 1 to 5 again indicate the likelihood that the findings on MRI correlate with the presence of clinically significant prostate cancer for any particular prostatic lesion. Again, from 1, which is very low likelihood, to 5, which is very high likelihood. So now that we know some basic anatomy and what tumors might look like, it's important that we get a good feel for what normal looks like. More specifically, understanding what the common benign findings are, and that will help us better see cancer when it's there. So let's discuss some common benign findings by looking at some pictures. Firstly, and most importantly, let's talk about BPH changes, or benign prostatic hyperplasia. So BPH changes happen in response to testosterone, and the changes themselves arise in the transition zone, or TZ, though occasionally you can get extruded nodules into the PZ. BPH changes themselves consist of stromal and glandular hyperplasia, and they can look like well-circumscribed nodules, encapsulated nodules, and band-like areas. And what they look like is going to depend on what they're made of. So glandular BPH changes and areas of cystic atrophy, of course, are going to be pretty T2 hyperintense or bright. And stromal BPH changes are going to be pretty T2 hypointense, but typically are very circumscribed. So here, for example, we have BPH changes that are glandular, that's completely encapsulated. Here's an example of a stromal nodule. It's T2 hypointense, but it's quite circumscribed. And we have another one here on the left. So all of this here in this patient, these are all BPH changes, and it's pretty heterogeneous. So it can sometimes be hard to pick out cancers. And later we'll talk a little bit more in detail about what you're actually looking for amongst these BPH changes. It is worth noting that with contrast, BPH changes are quite variable, and that's why DCE is not part of the algorithm for the TZ, and we'll talk about that later. And they can also be pretty variable with respect to their DWI signal as well. Next, we have hemorrhage, and hemorrhage is commonly seen in the prostate, especially if the patient had a recent biopsy. Usually we're going to see that as T1 hyperintensity, like this here. So this is a T1 pre-contrast image, and you can see there's hemorrhage here in the gland. Next, we'll talk a little bit about prostatitis, or inflammation in the prostate gland itself. So prostatitis is actually pretty common, but often subclinical. And this can range from mild changes with kind of diffusely decreased T2 signal in the normal PZ, and it can occasionally demonstrate enhancement on the post-contrast images and some diffusion-weighted changes, and this can result in false positives and can be confusing and mimic cancer. But the key is that most prostatitis changes in the PZ are usually band-like, linear, or wedged shaped. So prostatitis is less often focal, round, oval, or markedly restricting. And although certain types of prostatitis can do this, if you see anything in the PZ that's focal, round, oval, or markedly restricting, you should never call it prostatitis. But we're going to go through the algorithm in a bit and take you through some cases, and this will all become very clear. For now, just think of prostatitis as linear or wedge-shaped T2 hypointensity and mild changes on other sequences. More chronic changes of prostatitis can lead to areas of atrophy with volume loss and bands of low T2 signal as well. Other clearly benign changes include cystic changes like this cystic lesion here. And like elsewhere in the body, they're going to be generally T2 pretty hyperintense and T1 hypointense, non-enhancing and non-restricting, and calcifications, which are much more obvious on CT and generally dark on all sequences. Calcifications and cysts don't look like cancer at all, so are less frequently commented on MRI. Okay, now that we have a better idea of what normal and benign look like, let's talk about the PI-RADS scoring algorithm to help us pick out the lesions that we think are cancer. So there are two different algorithms depending on where the lesion is located. One for the PZ lesions or peripheral zone lesions on the left here, and another for TZ lesions or transition zones here on the right. And we're going to go through each of them in detail. But just looking at the diagram here first, you'll notice that here in red we have the final PI-RADS categories. As we mentioned, 1 being very unlikely to have clinically significant prostate cancer and 5 being very likely. In practice, a 4 or 5 is considered positive and generally biopsied. A 1 or 2 is generally considered negative and often ignored. And how 3s are dealt with is dependent on the institution. It is quite variable. But for now, it's good to think of PI-RADS 3 lesions as suspicious as well, and often biopsied. You'll immediately notice that for PZ lesions here, the DWI score is the main thing that determines the final PI-RADS score. So essentially, the main determining sequence in the PZ is the DWI score, and the main sequences you're going to look at are the high B-value DWI sequence as well as the ADC maps. For TZ lesions, you'll notice that the final scores are predominantly determined by the T2 weighted image score. So the T2 weighted images are the most important sequence in the TZ. Let's talk about these in a little bit more depth, starting with the PZ lesions. So first of all, as we said earlier, in the PZ, the primary determining sequences are the diffusion weighted sequences. Okay, and so we need to look at the DWI score. So the DWI score ranges from 1 to 5. A score of 1 is normal or no abnormality. A score of 2 refers to linear or wedge-shaped diffusion abnormality, and this is meant to capture cases of prostatitis, which is benign. And then from 3 to 5, we have focal diffusion signal abnormality. It's important to first focus on scores 4 and 5, which correspond to markedly high signal on high B-value diffusion weighted images and markedly low signal on ADC maps. A score of 5 is reserved for marked diffusion restriction that's over 1.5 centimeters in size. Also, if there's definite EPE or extra prostatic extension, that automatically makes it a 5 regardless of the size. It's important to note that PI-RADS defines markedly restricting a signal abnormality that is more pronounced than any other focus in the same zone. Okay, so some people have tried to quantitate this in the past with cutoff ADC values ranging from 750 to 900. Obviously, the lower the ADC value, the more restricting. So ADC values lower than a cutoff would correspond to a markedly restricting lesion. So if you remember one thing from this, the takeaway is that you're going to be looking for focal, markedly low signal on ADC, and focal, markedly high signal on high B-value DWI images in the PZ to get that score 4 or 5. The other sequence that matters in the PZ, for scoring at least, is DCE, or the dynamic post-contrast sequences. And DCE is dichotomous, so it's scored as either positive or negative. A positive score is focal enhancement that's either early or contemporaneous with the rest of the glands. So an enhancing focal lesion at the same location as diffusion abnormality that enhances either early or at the same time as the rest of the gland. So if we go back to our algorithm here, you can pause the video at this point if you want to review the descriptions here on the right that we just covered. But you're going to see again that the DWI score determines the final PI-RADS score, and for a DWI score of 3, a positive DCE can upgrade the final category to a category of 4. So this is the PZ algorithm that you need to know, and we're going to revisit this when we go through our approach and when we go through a couple cases. Okay, so now let's talk about the TZ, which can be a little bit more complex and a little bit more challenging. Again, the primary sequences in the TZ are the T2 weighted sequences. So a score of 1 refers to a normal TZ, which is pretty rare in older patients that we're imaging because most people have BPH changes or benign prostatic hyperplasia changes in the TZ. Okay, so in PI-RADS version 2.1, typical BPH nodules are also included as lesions that are scored as a T2 weighted score of 1. Okay, and this is specifically referring to BPH nodules or nodules in the TZ that are encapsulated or completely encapsulated. And so this is a T2 dark rim that you're going to see all the way around the nodule, and it's going to look something like this schematic over here. A score of 2 refers to atypical BPH nodules, namely things that are mostly encapsulated, like this image up here, or homogeneous and circumscribed, like this nodule over here, but without encapsulation. Again, these are considered to be BPH changes and are benign and are assigned a score of 2. The last descriptor here in this family is homogeneous, mildly hypointense signal that are between 2 BPH nodules. as shown here in this schematic. When it comes to the higher scores, the most important thing to know is what we're looking for when we're looking for cancer, or what cancer looks like in the TZ. So again, I'm going to get you to focus on the 4 and 5 scores. So a typical clinically significant cancer in the TZ is going to look homogeneously T2, moderately hypointense. They're often non-circumscribed or lenticular in shape. Lenticular just meaning shaped like a lens. And those descriptors are what we talk about when we talk about a score of 4. So lenticular or non-circumscribed, homogeneous, and moderately hypointense on T2 weighted images. And this is an example of that here. A score of 5 is going to be similar to 4, but again, greater than 1.5 centimeters or definite extraprostatic extension. And this, again, is an example of our classic TZ cancer. It's homogeneous, it's lenticular, it's non-circumscribed, and it's moderately hypointense. Okay, so these are the BPH changes back here, and this clearly looks very different, and this is a classic TZ cancer, and that's the takeaway here. So the classic description or colloquial way to refer to this is an erased charcoal appearance or a smudgy fingerprint appearance. So burn this into your brain, an erased charcoal appearance or smudgy fingerprint appearance. This is the type of thing you're looking for amongst the BPH changes that we've talked about already, and we'll show you some examples of this again later. Now, the difficulty again is that clearly BPH changes are heterogeneous, so we need to be able to pick these out amongst the BPH changes, but again, we'll show you examples of this later. Lastly, a score of 3 refers to heterogeneous signal intensity with obscured margins, and also includes other things that don't meet the other criteria that are 2, 4, and 5. The other sequences that matter in the TZ are the diffusion-weighted sequences, and these are scored similar to the way they are in the PZ, but really all that's important is the score of 4 and 5. Again, marked restriction, so markedly hypointense on ADC maps and markedly hyperintense on high B-value DWI images. And again, this is the TZ algorithm, and you can pause the video if you'd like to review all of these descriptors here and the algorithm here. But again, the T2 score is what is primarily determining the final PI-RADS score, or final PI-RADS assessment category here in red. Very importantly, a T2 weighted score of 2 in the TZ, so that refers to those atypical BPH nodules that we described, can be upgraded to a final assessment category of 3 if they have marked diffusion restriction, so DWI score of 4 or 5. And a T2 weighted score of 3 can be upgraded to a final category of 4 if it's markedly restricting and over 1.5 in centimeters or with extraprostatic extension, aka a DWI score of 5. When it comes to staging prostate cancer, some of the information is going to be here on the slide, but I just want to touch on what's most important when you're looking at an MRI study. So the first thing is determining if tumor is confined to the gland or if there's extraprostatic extension or EPE. So what do we look for when we're looking for EPE? So essentially when we say that there is something with frank extraprostatic extension, we're referring to clear cancer outside of the prostate. So there's direct tumor extension. There's direct tumor extension that's obviously outside of the prostate. If there's seminal vesicle invasion, that's clearly extraprostatic extension. If there's neurovascular bundle involvement, that's clearly extraprostatic extension. And then there are a bunch of softer signs that are predictive of EPE, but are not enough to say there is definite or frank EPE. And those things we still describe when we're describing the prostatic lesion. And those things include a broad capsular interface, so over 1 centimeter of contact with the capsule, or a focal bulge of the prostate contour at the location of the lesion. And then for lymph nodes, we're generally looking for enlarged or morphologically abnormal nodes, so round, heterogeneous nodes, etc. And if they're obviously involved, we're going to see that But unfortunately, even some smaller nodes that look morphologically normal on an MRI may be involved. So our job as radiologists are to point out the nodes that are obviously involved, aka enlarged or morphologically abnormal. In prostate cancer, it's important to know that the regional nodes include the periprostatic nodes, internal and external iliac nodes, presacral nodes as well. It's important to know that aggressive prostate cancers often spread to the mesorectal nodes posteriorly, and this is something that's expected. So it's not something that necessarily suggests that there's a rectal cancer or something else going on. We often will see aggressive prostate cancers spread posteriorly to the mesorectal nodes. And then we have our non-regional nodes that are actually considered metastatic, and that includes the common iliac nodes, the inguinal nodes, as well as retroperitoneal nodes higher up like para-aortic nodes. And then of course on every study we're also going to be looking at the nodes, specifically T1 weighted images or fat only images are going to be great for looking for marrow replacing lesions or looking for suspicious lesions in the bones. Okay, in this part of the video, I'm going to take you through my approach to prostate MRI. Okay, so we're going to start by looking at this image in the bottom left corner here. And this is the pre-contrast T1 weighted image, clearly fat saturated. And generally we're looking for hemorrhage in the gland, so we're looking for T1 hyperintensity here, which we do not see, as well as in the seminal vesicles. Again, we don't see any hemorrhage here. Next, I generally measure or contour the gland depending on your institution to get the prostate volume and look at the PSA and then calculate the PSA density, but again, we're not going to talk about that much more here. Then I generally look at the T2 weighted images for anatomy of the prostate, looking at the TZ and PZ. So starting with the TZ, I'm looking at these BPH changes on either side and looking for anything that stands out and anything that looks like cancer. Okay? So these are all BPH changes here, including glandular BPH changes and stromal BPH changes, but there are no suspicious lesions here that would match the category 4 or 5 T2 weighted score in the TZ that are suspicious at this time at least. I then look at the PZ from apex to base on either side. We see some linear T2 weighted hypointensity here that looks like prostatitis, but I don't see any focal abnormalities. I'm also correlating any findings on the axial images with the coronal images over here. Okay, then I'm looking at the high B-value DWI images, looking for anything restricting, starting with the peripheral zone on either side. And we don't see anything that's markedly hyperintense there, as well as the TZ, which is again more variable. And then I look at the ADC map down here, again, starting with the PZ, looking for anything that's markedly hypointense. You can see that the gland here is quite hyperintense with some band-like signal that is not suspicious. You'll notice again, if you were to not know your anatomy, you might say, oh, what is this? Is this something that's restricting? Right, oh, it's a little bit bright here on the DWI, it's a little bit dark here. Then you notice, oh yeah, this correlates to normal CZ or central zone compressed up here. So again, the benefits of knowing your anatomy, this is not cancer, this is a normal structure. Lastly, with the prostate, I'm looking at the dynamic post-contrast images. Usually the DCE images will only modify the score if you have a DWI score of 3 that you can upgrade to a 4 based on the DCE being positive. But if you have the sequences, it's good to look for anything that might be enhancing early or enhancing focally, and then correspond it with the other sequences to see if you might have missed something at first glance there as well. And then I look at other things that I can see on the images, starting with the T2 weighted images, looking at the bladder. Okay, so often when there's BPH changes, you're going to see the bladder look thick and trabeculated like this, which is indicative of an element of chronic outlet obstruction, but looking for any incidental bladder lesions or abnormalities. I'm looking at the rectum to make sure we don't see any incidental rectal cancers, for example. I'm looking closely at the seminal vesicles bilaterally, especially if there's a lesion. I want to see if there's any invasion, for example, into the seminal vesicles, and then any nodes that I can see in the low pelvis. Then I'm looking at the wide field of view study to look for any nodes elsewhere, the vasculature, and any incidental findings on the images elsewhere. Lastly, I will also look at any wide field of view T1 weighted images that are non-fat-satted, or in this case, this is a fat-only image acquired by the Dixon method, and I'm looking at the bones to see if there are any marrow-replacing lesions. So this is all fatty marrow, as we'd expect. And we want to see if in any of the bones there are lesions that might be suspicious for a marrow-replacing lesion. In the setting of a prostate cancer, of course, looking for metastases. And that's pretty much it for an abbreviated approach to prostate MRI. Okay, let's apply an abbreviated approach on a couple of cases. We're not going to go through it again in detail, but we're just going to show you a couple of cases to help apply what we've learned so far. So again, I generally start with the T1 weighted image, looking for any hemorrhage. I don't see any significant hemorrhage in the gland or the seminal vesicles. Then I'm looking at the T2 weighted images, specifically focusing on the prostate itself, the PZ, which is quite small in this patient, and the TZ. Okay, and immediately you'll see that there is a clear T2 hypointense abnormality in the PZ here. And you may also notice that there is something here as well. But again, the T2 weighted sequence is not the primary sequence in the PZ. I'm just looking at the anatomy first and looking for anything that I see that's obvious. You can see the anterior fibromuscular stroma nicely here. Then I'm looking at my high B-value DWI images. Okay, and right away, you'll notice that there's something quite bright here. And when I cross-correlate, it corresponds to the T2 signal abnormality I saw earlier. And if I look at my ADC map, right, normal prostate is pretty bright, and this is pretty dark, okay? So we have a markedly restricting lesion in the apex of the peripheral zone, spanning from the anterior peripheral zone, involving the posterior lateral and posterior medial peripheral zone at the apex. It's T2 homogeneously hypointense. It's markedly restricting. I won't measure it, but it's over 1.5 centimeters. So right away, this is just based on the marked diffusion restriction in size, a PI-RADS 5 lesion. This is very likely clinically significant prostate cancer, and it was. Okay, and then higher up in the gland, we saw that other lesion, and again, we have marked hyperintensity here on diffusion, markedly hypointense signal here on the ADC map, and this is also over 1.5 centimeters. This is a PI-RADS 5 lesion as well. Then on the T2 weighted study, you're also going to look for things like frank extraprostatic extension. Here we have broad-based abutment, okay, but no frank extraprostatic extension. Here we also have broad-based abutment, but you'll also notice that there's a slight bulge here. In this patient, however, there is actually likely some neurovascular bundle involvement, but this is a finer point that I wouldn't worry about at this point. I'd also look at the dynamic post-contrast images here, and you'll also notice that both the lesion here at the right apex, as shown here, as well as at the left base in the peripheral zone, as shown here, demonstrate a positive score on the DCE images. Of course, then you also want to look at the bones for any suspicious lesions, as well as the post-contrast images with a wider field of view to look for abnormal nodes. Okay, another case. So again, starting by looking at the T1 image, you'll notice that there's T1 hyperintensity here. So there is some hemorrhage in the anterior transition zone on the left. I then look at the T2 weighted images here, and we're just going to focus on the TZ for now. But you'll notice that there isn't a lot of BPH changes, but clearly some BPH nodules here that look quite typical of BPH changes. Here on the left as well, BPH changes. But then you'll notice that there is kind of this quite homogeneous T2 hypointense region that's ill-defined. One might describe this as an erased charcoal appearance or a smudgy fingerprint. Okay, if I look at my diffusion weighted images, the high B-value DWI shows there's some marked restriction here. Okay, it's markedly high signal here and markedly low signal here. And so this corresponds to slightly higher than the hemorrhage. The hemorrhage is way down here, and the lesion is higher up over here. So this is kind of a classic TZ cancer. If you look at the coronal images here as well, you'll notice again, we have this homogeneous T2 hypointense ill-defined lesion here, here in the left TZ. And so if I were describing the location here, this is the left anterior TZ involving the base to midgland. Okay, and then I'd look at the rest of the study as well. There are no lesions here in the PZ or elsewhere. And this was a PI-RADS 5 lesion, again, based on the size and appearance. This is over 1.5 centimeters. And there's likely extraprostatic extension here as well. So this is a PI-RADS 5 lesion. This is very likely to be clinically significant prostate cancer. Okay, thank you for tuning in. Hopefully you got something out of this video. There will be another video on PI-RADS comparing version 2 and 2.1, which will really help you understand PI-RADS a little bit better, so I suggest tuning into that as well. Thank you.
All right, hello and welcome to the fifth of many live stream noon conferences hosted by MRI Online. It is just now 12 o'clock and I see the number is still rising, so I want to give it a few more seconds really. Just wanted to say welcome, and in response to the changes happening around the world right now and the shutting down of in-person events, we have decided to provide free daily noon lectures to all radiologists worldwide. Today we are joined by Dr. Mukesh Harisinghani. He is a professor of radiology at Harvard Medical School and director of abdominal MRI at the Massachusetts General Hospital in Boston, Massachusetts. In addition, he serves as director of the Clinical Discovery Program Center for Molecular Imaging Research at MassGen and has been the section editor of GU Radiology for the AJR. He has been practicing in the field of abdominal radiology for over 20 years, has published over 100 peer-reviewed papers, and has edited 5 textbooks in the field of radiology. A reminder that there will be time at the end of this hour for a Q&A session. Please use the Q&A feature and we will get to as many of these questions as we can before our time is up. That being said, thank you so much for joining us today, Dr. Harisinghani. I'll let you take it from here.
Thank you, Ashley, and welcome everyone. I hope everybody's staying safe and taking the due precautions so that we can overcome this crisis in a healthy manner. So having said that, the topic of discussion today is going to be looking at how MR can be helpful in patients with rectal cancer. And if you look at the indications for MR, specifically in the abdomen and pelvis, there are a couple of indications like prostate and rectum where MR has certainly become front and center in terms of what information is gathered prior to therapy and the modality of choice. So MR is certainly becoming the modality of choice. And what we are going to do today is talk about these or cover these specific points. The first is why MR? Why do we need to do MR in rectal cancer? The second is how do we do the MR? Talk a little bit about technique and kind of give you some pointers in terms of what the ideal protocol ought to be. And then the most important thing is once you do the MR, the question is what do you look for and how do you put that in a comprehensive report? And while we are discussing the content of our report, we're going to talk about a few anatomical concepts which are key to remember when one is looking at rectal MR, and talk about standardized reporting, why that is very important. And I'll show you or provide you with resources that you can use to download free templates for the rectal MR. And then talk about imaging pointers for that predict worse prognosis in these patients. So the first question is why, and if you look at this is a year old in 2018, rectal cancer gets clumped with colonic tumors. So if you look at colorectal, they are the 4th most common type of cancer, and about 1/3 of these patients are rectal cancers. So it's not a trivial number. It certainly is a significant number of cancer cases that we see in a year. And if you look at this particular distribution of what the 5-year survival is, it shows you that when the tumor is localized to the lumen and that patient gets appropriate therapy, there is a very good chance of a 5-year disease-free survival. But as the disease progresses and becomes regional or distant, then the 5-year survival drops. And that's the reason why we have to be very diligent in accurately staging these patients. So from a very simplistic perspective, if the tumor is confined to the lumen, which means it stays inside the lumen of the rectum and doesn't extend out, the treatments are primarily surgical. And the standard is what we refer to as transmesorectal excision or TME surgery. Whereas if it extends beyond the confines of the wall and extends into the surrounding fat or adjacent pelvic parenchymal organs, then those patients typically get neoadjuvant chemoradiation therapy, and then they get subsequently followed up. And if things seem to be progressing in the right direction and looks like the tumor is regressing and shrinking away, then those patients ultimately go for surgery. So again, this is a simplified grid. It's just to kind of highlight what some of the mechanisms of how the tumor is treated. Irrespective of what or how you treat the disease, the goal, both for the folks that treat the patient and for us, is to prevent recurrence. And here is a patient who had a mucinous type of adenocarcinoma in the pelvis and came back after surgery with a local pelvic recurrence, as you're seeing in this particular instance in the presacral region. And when the disease comes back or the patient gets local recurrence, that is a very difficult disease to get a handle on. These patients typically have bad prognosis. They have very poor quality of life. And so we have to do whatever is in our, whatever is available to us, use that to the best of our ability to prevent this specific scenario from happening. And so accurate staging and appropriate treatment are the key things that will end up preventing local recurrence. And so with that said in mind, what we are trying to do, why we are doing MR, is basically to try and distinguish those patients into those that have early lumen confined disease, which means the disease is not extended beyond the wall, and those can, as I said, get surgical modes of therapy, and distinguish those from local spread and those with distant pelvic spread, because those require more aggressive modes of therapy prior to surgery. And then this is another important point of imaging is, when you look at the primary tumor, you have to find those specific imaging markers that can predict that this patient is going to do worse or going to have adverse prognostic outcome. And we will be discussing what these points are. But this is sort of more or less in a nutshell what the role of MR is in rectal cancer. So then comes the question of how do we do the MR? And, I think like most other MRs in the abdomen and pelvis, attention to detail in terms of technique is very critical. If you use a generic protocol that you use all the pelvises, it's not going to suffice for accurate staging. You have to spend some time in optimizing the protocol so that you get the necessary information that is required. And so you use this, again, you can use a 1.5 or 3T, use the phased array coils that are available with your system to the best of your ability. And so let's look at what the protocol is. The first thing you do is you do what is referred to as the localizers or the scout images. And this basically gives the technologist an idea of what is the area of anatomy that needs to be covered. Generally, you want to be covering an anatomy that extends from the L5-S1 junction down to the level of the anal verge, or perhaps a little bit lower than that, because that will give you an entire coverage for where the rectum and the anal canal lie, and will give you all the necessary information that you desire. So that's in terms of coverage. Then the next sequence the technologists ought to run is the sagittal T2 weighted sequence, and typically you like it to be a fast spin echo or a turbo spin echo T2. And this goes from one pelvic side wall to the other so that you cover the entire breadth of the viscera containing pelvis, and the rectum more or less resides in the center, as you're seeing in this instance. The reason for doing a sagittal first is so that you get a lay of the land of where where the rectum is, what defines the rectum, where is the cancer, because based on where the tumor lies, you are going to be prescribing some other planes. And that's why it's important and critical to do the sagittal sequence first. After you do the sagittal, you do a true axial. And again, the extent is from the level of a little below the level of the anal verge up to the level of L5S1 or the aortic bifurcation. And the reason for doing the true axial is you're trying to take a look at the anatomy, and there are anatomical features in the anal canal that are nicely laid out on the axial images that can help you in staging low rectal cancers. And this is just showing you, if you take an axial slice at the level of the puborectalis muscle, which is this U-shaped muscle, that's where traditionally, the columnar epithelium of the rectum becomes the squamous epithelium of the anal canal, and that's where anatomically or histologically you would locate the transition of the anal canal to the rectum, the rectum to the anal canal. Now, once you're below this level, in the level of the anal canal, there are two essential sphincters. You're looking for internal sphincter and you're looking for external sphincter. And so if you look here on this image, the green color is the internal sphincter. The internal sphincter is an involuntary muscle, and it's the continuation of the circular smooth muscle of the rectum. So it is has relatively T2 bright signal compared to the external sphincter, which you see right here. The external sphincter is darker. It has similar signal intensity as the skeletal muscle because this is a striated muscle which is different from the internal sphincter. And so, whenever you look at a pelvis, whether it's for rectum, prostate, keep sort of emphasizing this anatomy because it helps. One other way that you can distinguish the internal from the external sphincter is that the internal sphincter will show earlier enhancement after gadolinium compared to the external sphincter. So that's in terms of anatomy axially. Now, after axial, we do what is referred to as this is sort of the money sequence. It is the high resolution 10 T2-weighted oblique axial images. These are the key money sequences in terms of staging. And what do you mean by that? So remember, you acquired your sagittal, and in this instance, there is a very long segment of tumor. And what you're doing is scanning perpendicular to the plane or axis of the cancer, as you see in this particular instance. And that is the reason why, you sort of angulate to the axis of the tumor. So these are the key sequences for staging. And why do we pay such close attention and pay a lot of emphasis on this is because of this. If you look at this particular case, there is a tumor right here on the sag, and here is a true axial image without any angulation. And when you look at the true axial image, if you look at from 6 o'clock to about 9 o'clock in position, there appears to be relatively unsharpness. And if someone asks you, is the tumor confined to the lumen, or do you think the tumor is extending out? It can be very difficult and challenging to know if that's the case. Whereas if you look at the perpendicular oblique axial, you can see the tumor is confined to the lumen and it's not extending beyond. So it could mean, a difference in accurate staging. And that's why I cannot emphasize enough, you have to spend some time in terms of making sure that these sequences are adequately performed. And they are higher in resolution than the conventional axial T2-weighted sequence. So they have more detail that you can look for in terms of anatomic delineation and staging of the tumor. After you do the oblique axial, you do the coronal T2-weighted. And again, the coronal sequence is to emphasize the anatomy, particularly for the low rectal cancers where you're looking for involvement of the sphincter complex. And so this is what the coronal looks like. And just to kind of blow it up a little bit, you see the levator muscle on either side. The levator muscles that form the pelvic floor are like hammocks on either side. These levator muscles come down and insert into the puborectalis, which is this muscle that is shown by the turquoise arrows. And then below the puborectalis, you have the external sphincter. The external sphincter typically has three fascicles, which you are seeing right here. We have the upper, the mid, and the lower fascicle. And then you have the green arrows, which are pointing to the internal sphincter. That's this. Between the internal and the external sphincter is this bright fat-containing space, and that is referred to as the intersphincteric space. Again, you need to kind of keep looking at this and reinforcing the anatomy when you're looking at images where patients don't have cancers in other pelvic, so that when you do have a patient with low rectal cancer, you're accurately depicting the anatomy and trying to figure out what's involved or not. So pay attention to the anatomy in terms of in the coronal images. Then we do DWI. Now, the money sequence is truly, in terms of staging, are the T2-weighted sequence. There is a school of thought that the diffusions and the gadolinium enhanced images are really not required. I can tell you in our practice, they can be extremely helpful and beneficial, and they can complement the information that you get from the T2-weighted sequence. So typically you do a low B value, a high B value around 800 to 1000, and then calculate an ADC from that. And then we also do gadolinium enhanced images. And more so than the primary staging, these can be very critical when you're looking at post-treatment scans. And so here is an example of a patient who has a tumor on the right wall, and you can see that there is restricted diffusion and abnormal enhancement. And after therapy, on the T2, it's very difficult to know whether there is any residual cancer, but on the ADC of the DWI, and based on the enhancement, you can see that there is some residual cancer in that location. So certainly of benefit in terms of follow-up. And like I said, it doesn't hurt to do that in the regular staging protocol as well, because you certainly end up getting useful information. So that is the how we do it. Now we come to what do we look for. Now, before we talk about looking at the specific features for the rectal cancer, we need to re-emphasize some anatomic facts and also go through some of the terms that are critical for you to know before you actually start looking at rectal cancer patients. So the first is anatomy, and the question is, how do we define the rectum on MR? And what are the boundaries that we use on MR to truly say, where the rectum begins and ends? And so on MR, excuse me, we follow the perspective of the endoscopist. And from an endoscopist perspective, the rectum is the most distal part of the GI tract that extends 15 centimeters from the anal verge. So this is what the endoscopist looks for and characterizes as the rectum. So here is the anal verge, and they go 15 centimeters from there. And then they break it up into upper rectum, which is upper 5 centimeters, mid rectum, mid 5 centimeters, and lower rectum, that is the lower 5 centimeters. And this is what we follow. And here is a sagittal T2-weighted MR showing you how you go along the lumen of the rectum and draw 15 centimeters, and that's what is classified as a rectum. Now, you will see here that based on this definition, you are actually including the most distal part, which is the anal canal within the rectum. That's what the endoscopists do, and that's what we follow. So that's something for you to keep in the back of your mind. Now, the question is, what defines the anal verge? Typically, it's where the external sphincter ends. So the external sphincter is extends a little bit lower than the internal sphincter. There are some institutions that take the most distal part of the internal sphincter as the anal verge. There are some institutions that take the most distal part of the anal canal, which is where the external sphincter is, as the anal verge. I mean, the difference between those two is about 0.5 centimeters, so you really are not accounting for a lot of difference, but the key is to talk to the surgical colleagues and oncologists in your respective institutions and see which definition of the anal verge they would like to use. But irrespective of that, make sure that it's the 15 centimeter counting from the anal verge as the definition of the rectum. Now, because this definition of the rectum includes the anal canal, it means that if there are tumors primarily arising in the anal canal, which are primarily squamous cell carcinomas, are also included in this supposed definition. And so the question that begs the question is, if you're looking at a pelvic MR, are you trying to distinguish an anal cancer from rectal cancer? And so if I show you these two coronal images, one of them is a rectal cancer and one of them is an anal cancer, and ask you, what is the, which one is which, it's very difficult to predict. If you look on histopathology, it's the one on the left was rectal, and one on the right was anal cancer. So as radiologists, we are not in the business of distinguishing anal from rectal cancer. So even before you sit down and open the MR and apply everything I tell you today, it is very, very, very important, I can't emphasize that enough, that you look and make sure that from a histopathologic perspective, what you're looking at has been biopsy proven to be a rectal cancer. Because if what you are doing or what you're looking at is a biopsy proven anal cancer, then none of what I tell you is going to apply to anal cancer, because the staging and the treatment is totally different. And so, again, the take home point here is, do not try and distinguish rectum from anal based on imaging. You need to know that a priori before you look at the exam to apply whatever I tell you. You need to be sure that what you're looking for is rectal cancer and not anal cancer before you start applying the rules that we talk about today. One more anatomic fact that you need to keep in mind is that not the entire part of the rectum is extraperitoneum. The peritoneum inserts in the upper part of the mid-rectum. And so in men, it's typically here, you can see the tip of the seminal vesicle. This black line that you see going towards the rectum is a peritoneal reflection. And in women who have their uteruses, it's typically at the junction of the uterus and cervix, you see this thin black line extending onto the anterior part of the rectum. So that is the peritoneal insertion. Above this level, the anterior part of the rectum is lined by peritoneum. And why is that an important point? It becomes important from a staging perspective, and it also becomes important from a few of the imaging features that we will be talking on. On axial, if you take an axial slice at this level, this is what it looks like. It has this sort of a gull-wing pattern of thin black line that is inserted anteriorly onto the rectum. So when you're looking at your MRs, please make sure that you identify this landmark, because this is going to be a key landmark for not only for staging, but also for assessing some of the other features that we'll be talking about. This is what the specimen looks like. So here is the anterior part of the TME specimen, where you can see this glistening surface of the rectum. That's what is lined by peritoneum, whereas posteriorly there is no peritoneal lining. So, just keep in mind that. Now, the next point is the appearance of the rectal wall on T2 weighted sequence, because that's what governs a lot of the staging information that we will be talking about. So here is an anatomic depiction of the wall of the rectum. And this is what we see on an axial T2 weighted sequence. So we look at two bands essentially. The inner bright or hyper intense ring comprises of the mucosa and submucosa that you're seeing right here. And then the outer ring, which is the dark ring, which is the most important part that we look for, is the muscularis propria. So you see this dark line that extends all along, that's the muscularis propria, and that is one very important structure that we pay attention to when we are looking at the MRs. So here is a coronal and an oblique image. You can see this is the dark line of the muscularis going all the way around, and this is sort of the relatively brighter mucosa and submucosa. Now there is another structure that you see on this T2 weighted sequence. That's this black line that extends all along in a circumferential manner surrounding the rectum. And that's the other important landmark that we need to pay attention to, and that is the mesorectal fascia. It's a connective tissue sheath that encloses the rectum, also encloses the perirectal fat, perirectal vessels, and small nodes that are in that location. And so the reason why this is an important landmark, because as we will see from a staging perspective, as well as from a surgical perspective, because typically when the surgeon does their surgery and does the mesorectal excision, they try and go along the plane of this mesorectal fascia. Now, it may not be very precise. It could be a little bit to the inside, a little bit to the outside, but this is more or less the defined surgical plane, if you will, laterally for the TME. And when the specimen thus comes out, this is the plane of resection that is, that is defined by the mesorectal fascia. Now, there are two points to remember about the mesorectal fascia. One is it is most generous or capacious in the mid part of the rectum. As you come to the lower part of the rectum, it becomes very closely applied to the wall of the rectum. In fact, below the level of the levator muscle, the mesorectal fascia is practically in close attachment to the wall of the rectum. And so that's important because, if you have low rectal cancers, then there is a chance that it's directly involving the mesorectal fascia, and we'll be talking about that in a bit. But this is an important anatomic point to keep in mind. And so that brings us to the next point. What is total mesorectal excision? We have been talking about, and this is the surgery that really revolutionized the treatment of rectal cancer. And what was found is, instead of just taking out the rectum along with the cancer, if you dissect along the plane of the mesorectal fascia and not only remove the rectum, but also the fat and the lymph nodes and structures that are present in the mesorectal fascia, the outcome of patients is much better in terms of reduced chance of local recurrence. So these are diagrams showing you what essentially you are doing when you're doing a TME. You are dissecting along the plane of the mesorectal fascia, and that's what defines the lateral extent. So then you'll ask me, if TME excision is defined laterally by the mesorectal fascia, how high does the surgeon go and how low does the surgeon go? So in terms of, so this is what the specimen looks like. Here is the rectal lumen with the cancer. You can see right here, you can see all the fat that comes out, and this is the plane of dissection laterally along the mesorectal fascia. Now, superiorly, they go up to the takeoff of the inferior mesenteric artery. So you can see this is a CT scan of a patient who has undergone TME surgery, and this is where the surgeon has left clips of how superiorly they were. Now, inferiorly depends on whether the cancer involves the sphincter muscle in the anal canal or not. If the cancer does not involve the anal canal, then the surgeon does what is referred to as a LAR, where they basically, the inferior margin is at the level of the levators or the puborectalis, and they spare the sphincter muscle. Whereas if the tumor involves the sphincter mechanism, then they do what is referred to as an APR, or abdominoperineal resection, where they have to sacrifice the sphincter mechanism, and these patients get left with a permanent colostomy. So that's sort of, in a nutshell, the what we are looking for, the couple of anatomic facts. Now, in terms of standardized reporting, I'm not going to go through the template, but I will point you to this website. It's the Society of Abdominal Radiology website, and anybody can go to this website. Is www.abdominalradiology.org. When you go to the website, there is a tab for DFPs, which stands for disease-focused panels. And if you click on the rectal and anal cancer panel, it brings you to the various templates that are there. So you don't have to kind of create these on your own. You can just take the templates. If you click on any one of these, for instance, if you click on the rectal cancer staging template, it brings the, for some reason the link is not active, but it'll bring the template that is available in a PDF format that you can then import into your respective reporting software. So you don't have to sort of reinvent the template. So keep an eye. I mean, use this as a resource, and it gets continuously updated. And the DFT panel in SAR has done an excellent job at providing the most up-to-date recommendations, as well as a lot of other resources that one can use when looking at these templates. So having said that, let's talk about now on the imaging side of things. Yes, you will use a template, but you have to pay particular attention to those imaging features that predict that the rectal cancer is going to behave in a adverse prognostic way. In other words, the prognosis of the tumor is worse than when these factors are not present. And the key factors that we are looking for in terms of adverse prognostic indicators are mucinous pathology. And when you do have mucinous pathology, you have very specific imaging appearance. We talk about the T stage and the CRM, which stands for the circumferential resection margin positivity, and we'll go into what that means. You need to know the presence or absence of EMVI, or extramural venous invasion. This is, again, relatively a new addition to, I mean, it's been around, but a particular emphasis is being paid to this because this is considered to be a harbinger for worse prognosis. Patients who have EMVI typically behave in a worse manner, with having larger number of nodal mets and also being predisposed to distant metastases. And then looking at close proximity to the anal sphincter complex, obviously if the anal sphincter complex is involved, then as I said, the surgeon has to do an APR, and these patients are also difficult to get a surgically clear margin, especially if the tumor is well beyond the confines of the sphincter complex. So let's look at each one of these 5 adverse prognostic indicators. And the reason I'm doing this so that I'm showing you the worst things that you need to pay attention to when you're looking at that standardized reporting format. And so if you look at the mucinous pathology, as the name implies, if you have mucinous adenocarcinoma, mucin in the adenocarcinoma can be extremely bright on T2, and that's what it looks like. So here is an example of a large mucinous tumor in the pelvis, and you can see it's extremely bright. When you do have this kind of signature of the tumor on the T2 weighted images, it usually means the tumors have a higher pathologic grade. They have a greater tendency for metastases, both in the lymph nodes and beyond, and they typically have an unfavorable prognosis. And so here's another example. You can see this is a bright lesion inside the lumen, and it seems to be confined to the wall, but there is a lymph node that has near total replacement by the mucinous deposit within it. So, despite being a small lesion, it does have a large nodal metastases in the mesorectal space. So if you do see features suggestive of mucinous composition of the adenocarcinoma, you make sure you put that in the report. Then the next point is looking at the T stage and looking at the circumferential resection margin positivity. And so let's look at what this means. So if you look at the local staging, the T staging, basically the T1 is confined to the mucosa. T2 disease is confined to by the muscularis. It doesn't extend beyond the muscularis. T3 disease is when the disease has spread beyond the muscularis into the surrounding mesorectal fat. And then T4 is when the disease invades adjacent pelvic organs, or it invades into the peritoneal cavity. So that's sort of in a nutshell the T staging of rectal cancer. Now, detection of locally advanced, which means T3, that is, the tumor has gone beyond the muscularis and extends into the mesorectal fat. Typically, those patients are treated with pre-surgical chemoradiation therapy. So that is the first point to remember, that essentially, our goal is to identify the T3 and above. With MR, we don't do a good job of distinguishing T1 from T2, and you shouldn't even make an attempt to, because you will be wrong most of the time. And so, one way would be is just to sort of say that the tumor appears to be confined to the wall or by the muscularis, not extending beyond. And once it does, then you call it a T3. Now let's look at T3 disease in a little bit more detail. So as I said, T3 disease is when the tumor extends beyond the muscularis into the adjacent mesorectal fat. So here is an anatomic depiction where you see the outline of the mesorectal fascia. These are small normal sized nodes. Here is the rectum, and this is the tumor that is extending through the muscularis into the adjacent mesorectal fat. Now T3 is divided into 4 distinct categories. The first is T3A, where the tumor is extending beyond the muscularis into the fat, but that extension is less than 1 millimeter. And in this case, you can see the dark line here, but as you come to this part, you can see that there is relative lack of that black line of the muscularis, and there is a very subtle, less than a millimeter, or practically, the tumor is sort of invading the muscularis and just stops right there, and it's less than a millimeter of extension into the mesorectal fat. Now T3B is when it is between 1 and 5 millimeters, and in this case you can see here is a deposit right here that is going to less than 5 millimeters into the adjacent mesorectal fat. T3C is when the tumor is greater than 5 but less than 15 millimeters, and then finally T3D is when the tumor is greater than 15 millimeters extending into the mesorectal fat. And so the question is, why are we taking the T3 and breaking it up into A, B, C, and D? The first fundamental reason why we do that is the 5 millimeter cutoff, which means that tumors, once they extend beyond the muscularis into the adjacent fat, if they are 5 millimeters or less, their overall survival is pretty good. But it drops precipitously if it extends beyond 5 millimeters. And so you can see that, essentially the goal of the ABCD is to try and find those that are less than 5 millimeters, where there is a good 5-year survival, versus those that are greater than 5 millimeters, and then the survival drops to under 50%. So then you'll ask me, well, if it's 5 millimeters, why don't you just have A and B, where it's less than 5 and greater than 5 millimeters? The whole purpose of having A and B, that is less than a millimeter or between 1 and 5 millimeters, is because there are certain institutions that still treat early T3 disease as T2, which means they go for surgical resection. And that's the reason why you have that subtle distinction of T3A and T3B. But the take-home point for you guys, in terms of T3 disease is, remember, if it is less than 5 millimeter extension beyond into the fat, it usually is good prognosis, whereas if it is beyond 5 millimeters into the mesorectal fat, the prognosis is very bad. Then comes the next point, which is the circumferential resection margin. Now, this is a CRM, in short, is actually a pathologic term, which means once the surgeon dissects along the plane of the mesorectal fascia and gives the specimen over to the pathologist then looks at the extent of the tumor in terms of involvement of this resection margin or circumferential resection margin. So it's essentially a pathologic term. The other important point to remember is, although it is referred to as a circumferential resection margin, it's not circumferential in the sense that it portrays circumferential resection only below the level of the peritoneal reflection. Above the level of the peritoneal reflection, it is non-circumferential because you cannot assign a CRM status to that part of the rectum that is anteriorly covered by peritoneum. So please keep those 2 points in mind when you're reading and staging these tumors. So let's look at the equivalent of CRM that we need to put in our reports. And the equivalent is you measure the shortest distance from the tumor to the non-peritonealized part of the mesorectal fascia. So in this case, you are below the level of the peritoneal insertion, and you're going to measure this distance, which is the shortest distance. Now, the earlier descriptors actually included not only the shortest distance from the primary tumor, but also to positive nodes. But in the current consensus and going forward, it's recommended that you only put the shortest distance to the primary tumor. If you do have nodes and you are pretty sure the nodes are positive, you can mention it in the report and let the let the oncologist and the surgeon decide what they would like to do with that information. And so what are the criteria? If the tumor reaches and touches the mesorectal fascia, or within 1 millimeters of the mesorectal fascia, the CRM is considered to be positive. If it is very close, but between 1 and 2 millimeters, CRM is considered threatened. And if it is more than 2 millimeters, CRM is considered to be negative. Again, why are we doing this exercise? We are doing this exercise because if there is involvement of the circumferential resection margin, that usually means there is a higher likelihood that patient is going to locally recur and do worse. And that is the whole reason why we are trying, we are taking an extra effort to do and measure this distance. So in this particular example, you're seeing, I've outlined the mesorectal fascia, and you can see that there is a large tumor extension that is involving, it's less than 1 millimeter. So in this case, it is reaching, and in this case, the CRM is positive. And so that's what you will put in your report. Now, in terms of CRM positivity, as I mentioned, we do not consider the involvement of the peritoneal lining. That is a separate category in terms of descriptor and a separate category in terms of assessing prognosis. So remember, it was a thin black line that we saw extending from the uterocervical junction posteriorly into the rectum. In these two different patients, you can see that the tumor is clearly extending to involve that peritoneal reflection. And when you see that, you need to put that in the report, and that indicates T4A disease. So it's no longer T3, it's T4A disease. And again, it requires pre-surgical radiation therapy, and also it indicates worse prognosis, because what it tells the referring oncologist is that the tumor has involved the peritoneum and has shed cells into the peritoneal space, and thus there is a higher risk of local recurrence. So make sure that you mention that. Again, the pitfall alert is the peritoneum involvement is not equivalent to the CRM involvement. Remember, the CRM corresponds to the cut surgical resection margin and does not cover the anterior aspect of the upper rectum. The surgeon cannot influence the free peritoneal surface. The surgical resection margin will be negative since the whole rectum will be excised. So that's an important point to distinguish. When you do have peritoneum involvement, it is T4A, and it is reported as CRM negative, but you will mention that there is peritoneal involvement. I hope that point is clear, so that that's one potential source of confusion and error, and when reading these cases. Moving on to the next adverse prognostic indicator, and that is the extramural venous invasion. And what it essentially means is, you have these perirectal veins that arise from the rectal wall and extend into the adjacent fat. If you have tumor that extends into these veins, then that is considered to be an independent predictor of worse prognosis. These patients typically develop local and distant recurrences, nodal disease, and the overall survival is worse. MR is extremely good at detecting EMVI and also stratifying patients. So here are two examples. You can clearly see that there is a bifurcating vessel where there is similar signal intensity as a tumor extending into the vein. And here is another example where you can clearly see that there is tumor extension into the venous radical, similar in signal intensity as the primary cancer. One word of caution and also to look for is, sometimes the extent of involvement in the vein may not be similar in terms of size. In other words, you can have a vein take off from the wall, and you can have a larger tumor deposit distally compared to proximally. And just to show you the example, here is a patient where you can see this is the rectal wall right here, and here is a vein that is emanating from the posterior wall of the rectum. And as we scroll, you can see that there is clearly tumor involvement here, but as you go further, there is a larger deposit somewhere in the mid portion of the lumen. So keep in mind that you can have this nodular deposits along the course of the vessel, and that's something you need to pay attention to and call it appropriately EMVI. So lastly is looking at close proximity to the anal sphincter complex. And as I mentioned, you have to pay close attention to the anatomy. The anatomy is what is going to help you in terms of, defining whether there is extension into the sphincter complex or not. And so if you have involvement of the levator muscle, that is considered T4 disease. And again, it is treated as such. And then once it extends lower down into the anal canal, what you're doing is you're trying to look for involvement of three distinct structures. The first is the internal sphincter, the second is the intersphincteric space, and third is the external sphincter. And so you have to be descriptive in your outline and need to let the surgeons know if the intersphincteric space or the external sphincter is involved, because these two factors are what will sway them towards doing a APR versus doing an LAR. And so here is an example of a low rectal tumor with the involvement of the intersphincteric space. So you can see here is a circumferential lesion. On the left, the fat in the is maintained in the left intersphincteric space. As you scan through the coronal on the right side, there is clearly tumor involving the intersphincteric space, and it kind of abuts the external sphincter, which appears to be relatively well maintained in this case. So here there is involvement of the internal sphincter and extending into the intersphincteric space with relative sparing of the external sphincter. And again, one useful caveat is when the contralateral anatomy is spared, it's good to compare and show what's going on. And here is another example of a patient where there is external sphincter involvement, two different patients. So here is a mucinous lesion. Clearly there is extension into the external sphincter on the left side and beyond. And here is another patient where you can clearly see there is involvement of the external sphincter on the left and extending beyond the external sphincter complex. And in this case, these patients clearly will have to undergo, depending on what the features are, after neoadjuvant, they may still have to get their sphincters sacrificed and get a permanent colostomy. So I think that was in a nutshell, covering more or less the pertinent points for rectal cancer MR. A couple of take-home messages that I would like to re-emphasize. Do not skimp on the oblique axial plane. Please pay attention to your technique to ensure that the oblique axial plane is performed properly. If your techs don't have the ability to identify, which in most cases, it's very difficult for them to know where the cancer is. It requires active participation from the radiologist to ensure that the plane is correctly selected. Then you have to pay close attention to those factors that contribute to local recurrence. Follow the template, but within the template framework, these are the key elements that you need to pay particular attention to, looking for the T stage, presence or absence of peritoneum involvement, and then also looking at the CRM status in terms of extension to the mesorectal fascial margin. You are looking for the presence or absence of EMVI, and with low rectal cancers, you're looking for extension into the sphincter complex vis-a-vis, going into the internal sphincter, intersphincteric space, or involving the external sphincter. And then, standardized reporting, I can emphasize how important it is to have a standardized template so that everybody in your practice follows the same reporting guidelines and follows the same pattern of dictation. With that, I'm going to stop and say thanks again for listening, and I will see if there are any questions that the audience would like to pose. So there are a couple of questions that have already popped up. I'm going to read through them and see about the rectum being divided into three portions. Each one measures about 5 centimeters. The low rectum extends from the anal verge or from the anorectal junction. I think we have gone through that. It's extension from the anal verge, and not not from the level of the puborectalis. Can we please see the reporting template? I think I have given, if you go to the Society of Abdominal Radiology website, you don't need a login. You can pull it up without login information, and it should be pretty straightforward to look at that. What if the tumor involves the anterior peritoneal rectum? Again, that is T4A disease. That does not count as CRM involvement. The next question is for T3 disease, when measuring the distance from the tumor to mesorectal fascia, and if the mass has spiculation, does one measure from the tip of the longest spicule or from the mass itself? And the answer is, I didn't cover this, but one source of error between T2 and early T3 disease can be these spicules, which are related to inflammation. And what has been described in the literature is, unless you see frank nodular extension of the tumor into the mesorectal fat, you do not call it T3 disease. Subtle spicules can be seen with inflammation, and I know in rectal cancer can be a fairly inflammatory disease. And so if you have linear lines, those don't classify as T3 disease. Again, there is a difference of opinion between that, because there are some groups which will call it a T3 disease or early T3 disease, even if there are spicules. And this is a dialogue that you need to have with your surgeon to figure out what's the best way to do that. Can you please give us an example where contrast is helpful? Again, I think like I said, in our practice, it's a useful complement. Sometimes when tumors are fairly large, or when tumors are fairly small, looking at the differential degree of enhancement between the wall and the tumor can be useful. I'm not saying that that is the primary means for staging, but it can serve as a useful complement to actual detection and staging. Should we be reporting on CRM given that this is the pathologic term? I don't think you are reporting on the CRM. What you're giving them is an indication of what they can perceive the status of the CRM to be should they operate on the patient. So that is why you give the distance. You don't call it CRM. You give them the shortest distance between the tumor and the outline of the mesorectal fascia is this. Let's see what else. Somebody has sent a link, looks like. How do you treat desmoplastic inflammatory reaction in staging as post-treatment? It is very difficult to know the inflammatory changes adjacent to the tumor versus early T3. Again, that's a very good point. I did not cover post-treatment assessment. That itself is a very detailed topic to go through. And I agree with the reviewer that it can be extremely challenging. There are certain indicators of how you could classify and describe the tumors one treatment has been given. But again, this is something that it needs to be described separately. Can the rectal MR on MR below 1.5 T? My experience is limited to 1.5 and 3 T. I'm not so sure that for the kind of resolution you need on the T2 edited images, if that will be possible on the lower field strength scanners. But again, if you're able to work with a physicist or the vendors and optimize your technique, I think that should be, you should, give it a try. And if you're getting the kind of quality that is needed, then I don't see any reason why that cannot be used. Somebody asked about lymph nodes. Again, that's something that I didn't cover today. It's given the time constraints, but if you look at the most recent, if you look at that SAR website, it gives you in that template what should be done with the lymph nodes in terms of calling them positive versus negative. Let's see. Since MRI can distinguish between rectal and anal cancer, if I get such a case, should I conclude features of anorectal cancer? As I said, I don't think you should even make an attempt to start reading unless you are absolutely certain of the pathology before you start reading, because the way rectal cancer is staged and the way anal cancer is staged is totally different. And you don't want to confuse one for the other, because it would sort of have profound differences in way the patients are managed. So please do not make an attempt to distinguish the two. Do not attempt to start reading unless you have histopathologic proof that you are reading a patient with rectal cancer. Does EMVI occur only anteriorly, posteriorly, or all around? It can occur anywhere. The vessels that arise from the rectum, they don't follow a specific anatomic pattern, so you have to pay close attention throughout the entire circumferential part to ensure that the EMVI is present or not. Should we report nodes in the mesorectal fat? Again, yes, if you think the nodes are positive. And again, there are three sets of criteria you use for nodes. Again, I would suggest you go to the SAR website to get more information. But if the nodes are above a certain size, and or if the nodes are heterogeneous in signal intensity, and or if the nodes are irregular in outline, then in those instances you try and characterize those nodes as potentially positive. And then what you need to do is say suspicious versus not, and then give the total number of suspicious nodes. The other important point with nodes is also to distinguish the nodes that are within the mesorectal fascia versus those nodes that are in the pelvic sidewall. It's important because when the surgeon does the total mesorectal excision, they do not dissect the nodes in the pelvic sidewall. So if you see pelvic adenopathy in the pelvic sidewall that you think are suspicious, then that needs to be mentioned, because that will again alter what the surgeon plans to do with the patient. DWI is not very good for distinguishing benign from malignant nodes, and I would refrain from, looking at the DWI for distinguishing or characterizing nodes as benign or malignant. Is there a large technical difference between 3T and 1.5T in terms of diagnostic capabilities? Should we only be doing them on 3T? I can tell you from our experience, we scan on both 1.5 and 3T, and as long as the protocols are optimized for the 1.5T, you get comparable diagnostic information. Clearly, the resolution can be a bit better, but there are also sort of disadvantages of scanning on the 3T, because bowel peristalsis can be accentuated on the higher field strength. And so I think it's yin and yang. You can get more resolution and time on the 3T, but you can also get some artifacts. So it's a balance. And I would say that, if protocols are optimized on each system, then you are not going to have much difference in terms of what the difference is in the field strength. Let's see what else. I think a lot of these are duplicate questions. Somebody's asked, is there a need for endorectal coil for these exams? And the answer is no, a very emphatic no, because, think about it, unlike in the prostate, with the rectal, what you're trying to do is look for cancer in the lumen. And if you use an endorectal coil and the coil pushes the tumor away from your coil, you actually end up doing more harm than good to the patient. And so, we do not use an endorectal coil for looking at rectal cancer cases, and I would really refrain from doing that. It can in fact totally mitigate the usefulness of the exam. So be very careful if you are doing that. I would discourage and ask you not to do that. Let's see. What do you think about endorectal ultrasound as a way of determining T1 from T2? That's a good question, and I think EUS or endoluminal ultrasonography has a role for distinguishing T1 from T2. They can get very high resolution images of the rectal wall and are able to tell the difference. Clearly, as I said on MR, it's not easy for us to do that. The problem with ultrasound is, it's good at looking at the wall. They can't see beyond the wall, and that sometimes poses a challenge. The other issue with ultrasound is, endorectal ultrasound, is the experience of the reviewer. So that's something also to keep in mind in terms of utility One last question: is it important to use antispasmolytic? And again, in the interest of time, we didn't go into the specific details of the protocol. But yes, if you have the ability to use antispasmodics, in US we don't have Buscopan. In European countries and in Asian countries you do have Buscopan. I would highly encourage you to use antispasmodics because it definitely helps in enhancing the quality of the images. There have also been instances where they do microenemas. It's not distension of the rectum, but sort of putting minimal amount of fluid into the rectum to enable distension to get good quality images. I think that's the last question. More or less, we have answered most of the questions as there are duplicates. Ashley, I'll hand it over back to you.
Yep. As we bring this to a close today, I just wanted to thank you so much, Dr. Harrison-Ghani, for your time today. And thanks for all of you for participating in our noon conference. Just a reminder that this conference will be made available on demand within the next 24 hours on mrionline.com. And please join us on Monday at 12 p.m. Eastern Time. Dr. Jeanette Collins will be with us for a noon conference on the CT patterns of lung disease. Please visit mrionline.com to sign up for that one and all future noon conferences. Thanks so much and have a great day.
Thank you for coming. This is the workshop on rectal cancer MRI post-treatment evaluation. I'll start us off by talking about rectal cancer restaging after chemoradiation, and then Katrina McGinty from UNC will talk about imaging of rectal cancer recurrence. I have no financial disclosures. So the outline for my talk, we'll discuss briefly rectal cancer management and why it's important to restage rectal cancer after chemoradiation with MRI. I'll mention again the rectal MRI protocol. Some of this will overlap with the lecture I gave this morning on initial staging of rectal cancer with MRI. And then we'll discuss the findings specifically in the post-chemoradiation setting. And then we'll have a specific sample report template. Just as a reminder, initial staging on MRI of rectal cancer is based on the involvement of the layers of the rectal wall. So a T1 tumor involves the mucosa and submucosa. A T2 involves the muscularis propria but does not extend past the muscularis propria into the mesorectal fat. T3 extends outside the muscularis propria into the mesorectal fat. And then T4 involves either the visceral peritoneum or adjacent organs or both. So this is kind of where we draw the line, the T2 versus T3. T2 and T1 tumors go straight to resection, while most T3 and above get chemoradiation prior to resection. And then these are the locally advanced cancers that get restaged with MRI after chemoradiation to assess for tumor response. And this gives us information about prognosis, surgical planning, and in some cases can also result in non-operative management. So let's talk about that briefly. So this morning I talked about how the management of rectal cancer is resection with or without chemoradiation. Well, in a subset of patients, and this is particularly in Europe where this is standard of care, in certain patients that achieve complete response, these patients can be managed with surveillance and what they call a watch and wait approach. Now in the US, this is not standard of care per NCCN guidelines, but is still adopted in certain patients who may be poor surgical candidates or may not want an ostomy, for example. So the data on this is mostly from Europe, and this is just 4 of the studies that I have listed here. It's a busy table. What I want you to focus on is all studies compare disease-free survival and overall survival, looking at patients that underwent the watchful wait versus the resection. And most of these did not show any significant difference. The ones that actually were significant, the watchful wait approach actually had higher disease-free and overall survival. So these patients can, at least based on these data, safely be followed. And now it has to be a subset of patients with complete response after chemoradiation, which is achieved in up to 35% of patients, depending on which author you read. And the assessment for complete response is done clinically, as well as with MRI. And MRI really plays an important role in the setting and has moderate sensitivity and high specificity in detecting complete response. So again, the rectal MRI protocol, it's very similar to the pre-radiation imaging protocol. We start with the sagittal and axial T2 weighted images. We identify the tumor here on the sagittal weighted images, and then we draw a cross-section through the tumor, which is the plane for the axial oblique imaging, like so. And then a plane that's parallel to the length of the tumor, that would be your coronal oblique plane. And then really important, especially in the post-chemoradiation setting, is the diffusion-weighted imaging. And the pre and post-contrast T1 weighted images are, again, optional, not necessarily routinely obtained at all institutions. So key here, again, is high-resolution axial and coronal oblique T2 weighted images, and especially diffusion-weighted images in the post-chemoradiation setting. Again, the protocol is available on the SABI member protocol website. So number of findings that we're going to go through, we'll go through these one by one. So the first thing you want to do is, using T2 weighted images, assess the degree of viable tumor versus fibrosis. So how do we do this? So let me show you this case here. And if I told you this patient had prior radiation, you may not be entirely sure how much of this was tumor versus scarring. Now let's pull up the pre-chemoradiation imaging on the same patient, same level. So you can see large semi-annular tumor here along the right side of the rectum. If you look on the post-CRT closely, it's this sort of crescentic dark signal intensity on T2 area, this scar that is now much smaller compared to the pre-CRT imaging. So it's really important to compare with the pre-CRT imaging in order to assess what's going on the post-chemoradiation imaging. So in general, viable tumor will be intermediate signal intensity on T2. So this is a tumor that is largely unchanged after chemoradiation. This patient came to us from the outside hospital, had been treated with chemoradiation. This is a large amount of mass-like intermediate signal intensity within the wall. This is residual viable tumor. In contrast, again, to this case that I showed you, which has shrunk from this large tumor and is now predominantly dark on T2 weighted images, this is fibrosis. So viable tumor, intermediate signal intensity, just like the primary tumor would be, and fibrosis is low signal intensity on T2 weighted images. How about this case here? So this is a semi-annular tumor on the pre-CRT. On the post-CRT, there's some low signal intensity in the periphery, but there's maintained intermediate signal intensity. This patient has mixed response. I love this case. This is from the literature. This is the best. I have some cases from our institution, but this is the best way to illustrate the example. So if I showed you this patient, this case, post-chemoradiation, and asked you, what do you think about tumor versus fibrosis? Well, you may look at this area posteriorly here and say, well, there's a large amount of intermediate signal intensity, and this is residual viable tumor. Well, now let me show you the pre-chemoradiation imaging. Posteriorly here, this is just normal mucosa, all right? The tumor is all anterior on the pre-chemoradiation imaging, which is now largely fibrotic and very, very dark on T2 and much smaller. So this actually is very good response. So this is what we call a pseudomass on the post-chemoradiation imaging. So for this reason, it's really important to always evaluate this in context of the initial pre-chemoradiation imaging. So to summarize this point, viable tumor is intermediate signal intensity on T2 weighted images, but always interpret these images in context of the pre-chemoradiation imaging, because you don't want to end up calling a pseudomass a viable tumor. A brief slide about mucinous rectal cancer. This is important because these tumors have poor prognosis. They are high signal intensity on T2 weighted images. So if you have a mucinous tumor pre-CRT, this already bodes a poor response. But now let's see the patterns of response after chemoradiation. So you can have a non-mucinous tumor that has intermediate signal intensity on T2. If that undergoes either cellular or acellular mucinous change, that is actually a good thing. These patients have low rate of local recurrence, but they do have higher rate of distant recurrence than patients that respond without mucinous change. You may have a mucinous tumor, a cellular mucinous tumor pre-chemoradiation that now is acellular, and that's a good response. That's non-viable. So cellular mucin is bright on T2 but is heterogeneous and has some intermediate signal intensity. Acellular mucin is non-viable tissue, and this is very bright, homogeneous, featureless on T2 weighted images. If you have a cellular mucinous tumor without response, that is a poor prognosis and increased risk not only for distant but also local recurrence. So here's an example here, annular tumor that's bright on T2. This is a mucinous tumor, post-radiation, largely maintained high signal intensity. This is no response pretty much. So this patient did not do well. They ended up going to hospice shortly thereafter. This is from the literature, a large mucinous tumor here. You can see the areas of high signal intensity on T2. On the post-CRT, you see there's a large amount of more homogeneous, bright signal intensity, featureless, non-cellular or acellular mucin, which is the portion that has responded, and there's some areas of maintained tumoral signal as well. So this is partial response in mucinous tumor. Just one slide about this new sign I heard about at RSNA last year. This was presented at RSNA last year, and this paper just published online in European Radiology. It's called the split scar sign on the T2 weighted images. Just briefly, basically what they're saying is on post-chemoradiation T2 weighted images, if you have a dark line along the inner margin of the tumor and along the outer margin of the tumor with very homogeneous intermediate signal intensity centrally or very bright signal intensity centrally, without disruption of the inner or outer margins, this is a good sign. This is what they call the split scar sign, and this they showed had association of, it was 97% specific for complete response compared to sustained. So they use sustained complete response, clinical and imaging based and pathologic based for their reference standard. So this is just the first paper with 67 patients. They've just defined this sign, and we are not clinically using this yet, but I think it deems mentioning here, and more studies really need to be done about this, but just so you're aware, I wanted to put a slide in here. All right, so moving on from T2 weighted images, how about diffusion weighted imaging to assess viable tumor versus fibrosis? So a multi-center trial here showed improved detection of complete response when you use diffusion-weighted images in conjunction with T2 compared to T2 alone. Here's some data from that study, 3 readers, and you can see that the area under the curve for T2 and diffusion-weighted images was higher in 2 out of the 3 readers compared to just the T2-weighted images. The sensitivity for detection of complete response was increased by 16 to 52% for the 3 readers. Two patients from that paper. The top row is patient A, bottom row is patient B. Large bulky tumor along the right side, polypoid tumor here becomes fibrotic post-chemoradiation. Semi-annular tumor here also becomes fibrotic post-chemoradiation. But if you look at the diffusion images, the top row there's an area of restricted diffusion. This is viable tumor, while the bottom row does not have any focal area of restricted diffusion. This is fibrosis. So really diffusion can help be a problem solver in this setting. Here's an example from our database. Large tumor, intermediate signal intensity on T2, and you can see areas of restricted diffusion within the tumor. Also this tumoral nodule here, T3 disease with restricted diffusion. On the post-chemoradiation, you see that this is now dark on T2, both these areas, and they have lost their signal intensity on diffusion. So these are areas of good response. How about this area here? The diffusion nicely shows maintained area of high signal intensity on the high B value, which corresponds to areas of intermediate signal intensity. This is residual viable tumor. So diffusion kind of highlights that a little bit better than the T2-weighted images. All right. So we've talked about differentiating viable tumor from fibrosis. Now we want to give the T stage of the residual tumor and give the extramural extent. So here's that tumor with a large amount of viable residual tissue. We draw where the muscularis propria would be. This is extending past the muscularis propria. This is a T3 tumor. And then we measured the extent outside the muscularis propria, which gives you the degree of or extramural invasion, and you can substage the T3 stage. And this is important because any tumors after chemoradiation that are T3A or below, meaning 1 millimeter or less extension outside the muscularis propria, have a much higher 5-year survival and disease-free survival and much lower local recurrence than the T3B or higher tumors. All right, so we talked about viable tumor, the T stage, we gave them the extramural extent. Now we want to talk about what's called the actual response to treatment. We give a tumor response grade, or the TRG. And this, again, it's very important, vital to compare with the pre-CRT imaging in order to give a tumor response grade. This is also one of the independent predictors of patient outcome. So how do we do this? So there's this five-grade scale here. 5 is no response, maintain intermediate signal intensity, same as the original pre-chemoradiation tumor. 4 is slight response, 3 is moderate response, more than 50%, 2 is good response, mainly fibrosis, and 1 basically is where there's not any evidence of ever even treated tumor. So this is important because MRTRG 4 and 5, pretty low survival, 5-year survival compared to 72% for MRTRG 1, 2, or 3. And so let's go through some examples. So here's a patient, pre-chemoradiation, large polypoid tumor, post-chemoradiation. All you have left is this little small crescentic scar. This is an MRTRG1. This patient came to us from the outside. I don't have the pre-chemoradiation imaging, but on the post, there's this very dense, dark scar on T2-weighted images. We call it a TRG2, and on path, there was no residual tumor. This semi-annular tumor along the posterior wall of the rectum, you can see it's a pretty large tumor here, and on this particular area here, it's now much smaller, more than 50%, definitely more than 50% fibrosis, maybe some residual intermediate signal intensity areas. We call it an MRTRG2, and biopsy showed no residual viable tumor, biopsy of this scar. This patient that I showed you earlier, semi-annular tumor on the initial pre-staging CRT. On the post-CRT, there's still maintained intermediate signal intensity while there's some fibrosis peripherally. This was MRTRG3, and the biopsy of this scar showed small amount of residual viable tumor. All right, so we talked about viable tumor, T-stage, we gave the MRTRG, and now we talk about the CRM status, because this is also an independent predictor of patient outcomes, and then we'll talk about lymphovascular invasion and nodal status. So this patient here, large amount of residual viable tumor. You can see it well on the diffusion-weighted images. It's involving the mesorectal fascia, so the positive CRM. Here, it's actually invading the prostate, and you can see that on T2, and it's confirmed on diffusion-weighted images. This is a stage T4 because of involvement of adjacent structures. And on the coronal images, actually, there's lymphovascular invasion. You can see that there's a contiguous tumor signal extending into the vessels. Notice that there's maintained tumor signal, intermediate signal intensity, largely maintained on T2. This is an MRTRG 4 or 5, really doesn't matter. Point is, this is predominantly residual viable tumor, and patient unfortunately would do poorly. All right, so once we've talked about the tumor itself, then we also can talk about the lymph node status. So chemoradiation tends to decrease the size of both benign and malignant lymph nodes, and typically this change follows the pattern of change in the primary tumor itself. Again, just like on pre-chemoradiation imaging, you want to talk about malignant morphologic criteria, which include irregular margins of the lymph node, internal heterogeneous signal intensity, and a round shape. MRI has decent accuracy for predicting lymph node disease or demonstrating lymph node disease after chemoradiation. Patients that have positive lymph nodes on post-chemoradiation MRI have a lower disease-free survival than patients that don't. So here's some examples from the literature. A lymph node in the periphery here that completely disappears, and additional smaller nodes that are quite gone as well. This patient here that develops a high T2 signal in the tumor consistent with mucinous change in this particular lymph node, and then this patient here that has an irregular lymph node that maintains its heterogeneous signal intensity and had residual viable tumor in this particular lymph node upon resection. So important to report change in lymph node status and appearance as well. Last thing here is the reporting template. So this particular, the SGAR guidelines provided this template specifically for restaging after neoadjuvant chemoradiation. They specifically talk about the tumor mass, giving the stage of the tumor after radiation, distance of the residual viable tumor from the anorectal junction, the length of the tumor, whether or not there is any sphincter involvement. Sorry about that. If the mesorectal fascia or peritoneum are involved, and predicting the CRM status based on that. Talk about lymph nodes and tumor deposits, and then the extramural vascular invasion. This is in your handout. And this last case I'm going to show you because it's a great segue to Katrina's part of the talk. It's a patient that was undergoing watch and wait but recurred. So this is a patient that I showed you earlier, had a good response. This scar was biopsied, had no residual viable tumor. So they got a 3-month follow-up MRI, no residual viable tumor. We called it again MRTRG2. They followed the CEA. CEA started rising, and they got a PET about 8 months later that showed a mass-like abnormality with uptake of FDG, and then they got the MR, which confirmed the recurrence. It looks very much like the original tumor. So with that, the take-home point from my talk, rectal cancer management consists of resection plus or minus CRT, or in certain cases can involve imaging surveillance and non-operative management. MRI is vital for assessing response after chemoradiation. Use T2 weighted images and diffusion to differentiate viable tumor versus fibrosis. You really must compare to the pre-CRT images. If that's one thing you take away from my talk, you always compare to the pre-CRT images when you're interpreting these scans, and then you report location, size, MRTRG stage, the T stage, the degree of extramural extent, CRM status, if not, whether or not there's lymphovascular invasion, and also the nodal stage. Thank you very much for your attention.
Okay, well, now that you guys all know how treated disease looks, I'm going to be talking about what it looks like when disease recurs. Before I begin, I want to thank some of my colleagues who helped me out with cases for this talk, and I unfortunately have no disclosures. So I've broken it down into 3 parts. I'm going to start off by talking about which patients are more likely to recur, what recurrence looks like, and lastly, how we manage these patients. So the good news is recurrence is actually becoming a lot less frequent. As we've gotten better at treating these patients, as they get neoadjuvant therapy and multidisciplinary management, recurrence rates have decreased precipitously in the past couple of decades, going from over 30% to less than 10%. And usually when these patients recur, it's within 2 to 3 years of their surgery. Unfortunately, about half of them will have metastatic disease at time of presentation, but it's still important to identify these patients because there's very different survival outcomes depending on if they're treated. If they're untreated, their median survival is less than a year. Even with palliative treatment, it goes up to 5% at 5 years. And if they receive appropriate surgery and neoadjuvant therapy, it actually goes up to about a 35% 5-year survival. Again, not great, but certainly a lot better than 1 year. When these patients present, they'll present with things like changes in bowel habits, rectal bleeding, pain, but in about a third of these patients, the recurrence is actually going to be asymptomatic. And what makes it harder is these are very complicated patients to begin with. Many of them do have chronic pelvic pain because they've had extensive surgery. They have fistulas, discharge, masses, non-healing wounds, and all of these things can be very confounding to the diagnosis of recurrent disease. So when I think about recurrence, I try to think about the things that will place the patient at increased risk of recurrence, and I like separating them into 2 categories. You have the things that are related to the tumor itself, and then the things that are related to what we actually do to the patient. So if we want to know things in the tumor that are going to impact recurrence, you could look at the tumor location. So tumors that are lower or more anterior are less likely to recur. You want to look at tumor grade, of course, with higher grade being more inclined to recur, the presence of extramural vascular invasion or lymphovascular invasion, and the presence of adenopathy. But then we could also look at what we do to the patient. So positive margins, very big risk factor for recurrence. The surgery type does matter. Patients with APRs are more inclined to recur than those who have LARs. Things like intraoperative tumor perforation or postoperative anastomotic leakage, and also the surgeon caseload. Surgeons who do less than 10 to 12 cases have higher recurrence rates than those who don't. So a lot of these are getting triaged to multidisciplinary centers for more appropriate management. But if you can't remember all that, because there are a lot of things on that slide, you really only have to focus on 3 things: the margins, the tumor stage, and whether or not they get neoadjuvant therapy. So if you look at the margins on the tumor stage, patients who had T1 and T2 disease in a positive margin had a 12% recurrence. Those who had T3 and T4, 25% recurrence. You could see that in patients who got neoadjuvant therapy, they had half the recurrence rate of those who only got surgery alone in the appropriate patient population. So if you forget all that, you always want to know about your margins, your tumor stage, and what sort of therapy the patient had prior to their surgery. So what role does imaging play in these patients? We've got a lot of modalities at our disposal. Which ones should we be using? Keep in mind that in addition to any imaging that we're doing, these patients are getting colonoscopies and they're also getting CEAs. So it's not the only way these patients are being surveilled. For those patients who've had a transmesorectal excision, be an LAR, APR, CT is really going to be your workhorse of surveillance. They usually get a baseline study following their surgery. It's great for detecting metastatic disease, and it's actually pretty sensitive for local recurrence. Your PET-CT is going to be more of a problem-solving tool than your routine surveillance because of the high number of false positives, and it does have limited detection of smaller lesions. Your MR plays a role in those patients who've had transanal excisions. So usually for those patients, they'll either get sigmoidoscopy or MRI every 6 months for a period of 2 years, rather than getting a CT since they have a much lower risk of metastatic disease. You could also use MRI as a great problem-solving tool in those patients who have had transmesorectal excisions. And as Gaurav mentioned, it plays a role in watchful waiting in those patients who've had a complete response to therapy. So those are your imaging modalities that you have to work with. So now that we know how to image these patients and who's going to recur, what does recurrence actually look like? So there's different patterns of recurrence, and it's helpful to kind of break it down into categories of axial, anterior, posterior, lateral, and remote, which is going to be your metastatic disease. Obviously, you can combine these categories. It doesn't only occur in one compartment, but this is generally how it's categorized. So your axial recurrence is going to be along the expected course of the rectum, or if the rectum is resected, in the perineum. So your patients have had an LAR. This most often occurs at the anastomosis. Your patients post-APR in the perineum. And for your TAE patients, this is usually a local recurrence. So if you have an anastomotic recurrence, it could be intraluminal, which is actually usually very well seen with endoscopy, or mixed, or it can be extraluminal. And here's an example of that perineal recurrence that you'll see in your patients post-APR. And here's an example of a recurrence at the superior margin of the rectal stump. Again, these usually occur near the suture lines, and you could actually see the suture right there. So the anterior recurrence is invasion of the bladder or the reproductive organs. So here we have a case where you have tumor extending anteriorly. to contact the posterior wall of the vagina and the posterior cervix. And men will involve, obviously, the prostate and seminal vesicles. And the reason why it's important to differentiate these is axial and anterior recurrences usually have better surgical outcomes. These are usually easier to resect, so you do want to identify these. Your posterior recurrence are those that involve the presacral fascia or the sacrum or coccyx. So here we have a case of a fistulous collection that actually had recurrent tumor within it, invading the presacral space. And then your lateral recurrence is going to occur along either the bony pelvic sidewall or the pelvic sidewall structures, and here's an example from the literature of that. And of course, then you have your remote disease, and keep in mind, again, half of your patients will present with metastatic disease at time of recurrence. So you always, always, always want to look for the metastatic disease. So here we have a patient, they're 18 months post-treatment with a rising CEA, and if you look closely, this was that patient, they had a known presacral fistula, but over time we see increasing density within that fistula. They received an MRI, which showed, again, soft tissue in that, as well as a PET CT, because, have both modalities at our disposal, and this was a biopsy-proven recurrence. So it can be subtle on CT, but you can distinguish it. Here's another case of a patient who was 26 months post-LAR. You can see on this scan, there's no adenopathy. On their follow-up scan, they have a new retroperitoneal lymph node that's obviously pretty abnormal. And if you look carefully at the anastomotic margin, you can see there's increasing soft tissue density at the anastomotic margin. So they had metastatic disease as well as a local recurrence. Here was a patient 2 years post-LAR with a new lung nodule. They got a PET CT to evaluate the lung nodule. At the same time, they saw uptake at in the rectum, and this was a local recurrence as well as metastatic disease. So if we're looking at these areas on MR, it's important to try to differentiate fibrosis from tumor. And you kind of use the same principles that Gaurav talked about in our last session, that you want to look for T2 signal, you want to look at diffusion-weighted imaging. In general, with fibrosis, you will see decreasing T2 signal over time, angular margins, and it really shouldn't enhance quite as much. Whereas your tumor will typically have rounder borders. You can see here our recurrent tumor, although it's T2 intermediate, does have very round borders. It can also show more avid enhancement. So here we see an area of focal enhancement, whereas in fibrosis, it should be more smooth. This was recurrence within the wall and had focally restricted diffusion. That was not the same all around the tumor. So even though it was intramural, it was focally restricted diffusion. But keep in mind, there can be considerable overlap in these imaging features, which make it a little bit confounding. So here are a couple of cases. This is a 55-year-old male post-LAR with a rising CEA. Not much showing up on T2-weighted imaging, but on the diffusion-weighted imaging, you could see there's an area of focal restricted diffusion, and this corresponded to our biopsy-proven recurrence. So it's T2 and diffusion-weighted imaging, and in some cases, enhancement that help you make the decision. This was another case. You can see there's extensive fibrosis, very T2 hypointense signal on this MRI, and there's maybe a little area bulging into here. What we see is there's still that T2 hyperintense fibrosis, but on their follow-up scan, we see an area of growing T2 signal, and this was an extraluminal disease and a biopsy-proven recurrence. So that enlarging T2 signal is one of those things that you want to look for. And again, it demonstrated markedly restricted diffusion. That certainly helped it pop out. This was an interesting case because this was a 55-year-old male post-transanal excision. We didn't have an MR prior to his transanal excision, and this was what we got, and it actually looked the same over 2 scans because, well, we actually saw him 2 scans in. But when we looked at it, we saw this focal area of restricted diffusion in here that we were concerned about, and maybe a little bit of enhancement. So then the surgeons biopsied. They actually weren't that impressed with it. They thought maybe it was a polyp, and because of its more suspicious appearance and that focal area of restricted diffusion, we recommended rebiopsying, and sure enough, this was invasive adenocarcinoma. So even if the pathology is sort of going against what you initially thought, don't be afraid to tell them to rebiopsy because these are aggressive disease and portions of it may be more aggressive than others. So be confident. Lastly, I want to talk a little bit about how these patients are managed. So if there is a suspected recurrence, ideally you want to get a tissue diagnosis if possible. These patients should then be assessed via pelvic MR to assess if they are potentially resectable. They should have either a CT or a PET CT to look for metastases or occult metastases. If this is not possible at some institutions, they actually will do laparoscopy to evaluate for metastatic disease. But what I want you to notice is regardless of whether or not diagnosis is confirmed, these patients still should be presented at a multidisciplinary discussion. If they have likely disease, you want to assess, are they resectable? Should they be getting neoadjuvant therapy or adjuvant therapy? If the diagnosis is uncertain, you want to establish a firm plan of follow-up to either repeat imaging, repeat the CEA, or in some cases, repeat the biopsy. So you really do want input from everybody on how these patients get managed. Because the ideal goal in a recurrent patient is to get an R0 resection. So resectability means you get an R0 resection with acceptable postoperative morbidity and mortality. You don't want to achieve an R0 resection at the total expense of the patient's quality of life, but you really, what you want to ideally have no disease left. What you want to avoid is the R2 disease, because if you have macroscopically positive resections, these have higher complication rates and absolutely no survival improvement. So this is ideal. This is not ideal, but better, but that R2 resection is really doing absolutely no benefit to your patient. So how do you determine who's resectable? I want to stress that these are all relative contraindications. They will vary depending on the surgeon and on the institution, but these are the things that you want to look for and specifically address in your report. So unresectable extrapelvic disease or sacral involvement. We talk about sacral involvement. It's really that involvement at the S1, S2 level or involvement of those sacral nerve roots that will oftentimes push patients into that non-resectable status. When I talk about metastatic disease, surgeons will actually be pretty darn aggressive with resecting any sites of metastases because, again, for these patients, getting rid of that disease is really going to improve their survival considerably. So here was a patient, they had an implant in their abdominal wall that they thought was possibly a port site implant as well as local recurrence, and this patient was resected. Similarly, a patient who had lung cancer met, they're very inclined to resect local lung metastases. So it's really important to detail all the sites of suspected metastatic disease because it does not necessarily preclude resection. Ureteral encasement is considered a relative contraindication, especially if it's bilateral, but unilateral they still will consider resecting, although again, depends on other factors, as well as iliac vessel encasement. So these are all the things you want to make sure to explicitly mention and describe in your report because they will alter the management of the patient. So in summary, it's important to realize that even though rectal cancer rates are low, they have very high mortality if they're not treated. About half of our patients will present with metastatic disease, so you always want to look for that local recurrence as well as synchronous mets. You want to thoroughly describe your local recurrence and any possible sites of metastatic disease because this will aid in planning your resectability. And really, multidisciplinary management of these patients is mandatory for appropriate management. So, thank you.
Thank you very much. Thank you for the invitation. Good afternoon, everyone. I have no financial disclosures. What we want to do the next 25 minutes or so is discuss patient preparation and the MRI protocols for imaging of various uterine conditions. I'm going to go to how do I report a GYN MRI with specific reporting tips and pearls and pitfalls. We're going to review the added value of MRI on treatment selection and planning of patients with both benign and malignant uterine conditions. And as I go through some of the cases, I'm going to highlight a few pearls and pitfalls of MRI imaging. Just starting with the technique, we use both 1.5 Tesla and 3 Tesla scanners, either a pelvic or if you have a cardiac phase coil, that's also excellent. We ask the patient to empty their bladder prior to their examination because what you want is a semi-full bladder by the time you start acquiring the images. We used to ask them to fast for 6 hours, but now we give the antiperistaltic agent. In the US, glucagon. In Europe, you can give both glucagon and Buscopan. We don't use any vaginal gel, and that is, in my opinion, optional. And just to show you 2 cases here, a case here of a patient which had prior trachelectomy, and I'll talk about that in a minute, which means amputation of the cervix for fertility preservation for a patient with a small cervical cancer. You can see here, before giving antiperistaltic, there's a lot of movement mainly due to the small bowel getting here into the recess. And you can see the same patient, same sitting after the antiperistaltic. You can see how nicely this area of the neo-vagina is seen. And you can confidently say there is no tumor in this case. So what plans do we use for the uterus? We start with large field of view axial T1 weighted images. We want to look at the para-aortic region, especially for in case of malignancy, as well as in the case of uterine anomalies. You want to make sure that both kidneys are present. Then we do the high resolution T2 weighted images on the sagittal, axial, and coronal plane. Especially for the benign conditions. For uterine anomalies, we use the long axis, so parallel to the plane of the uterine cavity. or a short axis in case of endometrial cancer, which is perpendicular to the plane of the uterine cavity, and I'm going to illustrate those planes to you in a minute. So there we go. There's a sagittal here. If you want to look for uterine cancers to see the depth of invasion, to stage them, then you use an oblique plane, so perpendicular to the endometrial canal. We use diffusion. We have an axial multi-bivalue diffusion, IVIM type, and there's a larger field of view. At the moment, it's used for in the research setting. We also do sagittal and axial oblique to match the T2 weighted images with 3B values. We do give contrast, and we use multi-phase contrast in both sagittal and oblique axial plane, again matching the T2. In case, let me just emphasize you the plane in case of the uterine anomalies. Just a T2 weighted image here. As you see, it's a retroverted uterus here. This is the standard axial. And you can see here, yes, you probably even can diagnose here a septate uterus. However, you need to do a little bit more than that. You need to measure the length of the septum here. And it'll be much more accurate if you really did use a coronal plane here, true coronal to the uterus, so the oblique plane. As you can see in this case here, you can nicely measure the septum and describe the composition of the septum. When it comes to the cervix, again, you need a large field of view axial T1 weighted images to look at the para-aortic region for lymphadenopathy. You need the high resolution images. You really don't need the coronal in this case, or at least we don't do the coronal in this case. We do sagittal and axial. In this case, the short axis plane is to the cervix, so perpendicular to the cervix. And here you go. There is a sagittal image here with the tumor into the posterior cervix here. And if you do the oblique plane, so perpendicular to the tumor or to the cervical canal, you have these oblique axial planes, which allow you to actually look at the depth of myometrial invasion, cervical stroma invasion very nicely. We keep the same parameters for all uterine malignancies. So again, diffusion, IVIM on the large field of view, and then sagittal axial oblique on a short field of view with multiple b-values. And then we did give contrast on both sagittal and oblique planes to match the T2 weighted images. So in a way, you sort of keep some of the sequences the same, but you vary according to the clinical questions to the condition. So you try to sort of personalize a little bit the protocol on the pathology you're looking at. So just to re-emphasize that oblique plane, it has to be true oblique to the tumor, so perpendicular to the tumor. This is a case of a very large tumor, so dumbbell-shaped tumor endocervical. This is the case came from another hospital. You can see the sagittal here. That is the axial to the pelvis rather than to the cervix. And I wouldn't fault anybody for calling that a parametrial invasion. You can see the stroma is preserved here. You can see there is no stroma here with tumor, almost sort of, with no stroma between the interface between the tumor and the fat. However, the surgeon did say that, well, I think that the tumor is free and we don't detect any parametrial invasion. And actually, if you look at the axial oblique case, images perpendicular to the tumor, you can see exactly what they mean, and they're absolutely right. You can see that the stroma is absolutely intact, and the tumor is just confined into the cervical canal, although being a large tumor. So how do I report a GYN MRI? First of all, and that's sort of a mental check you do, I'm sure, on everyday basis when you read, you check that all the sequences are available for reporting. Sometimes, you know, the tech might forget to push a sequence through to PACS. I check the quality of the images, and we have a very nice tool now that we give both positive and sort of more critical feedback to the technicians on the quality of the images. Then you need to look at the need for extra sequences or planes, especially if you're supervising your studies. If you work on a small center, then you can supervise the studies. If you're looking for endometriomas or dermoids, or if you saw something high signal intensity on T1 weighted images, then you can ask for the T1 fat set images. And I'm sure you'll hear more in the next talk about this. You make sure the planes are correct. For the GYN malignancies or uterine anomalies, and you also check that the upper abdominal images are there for both the para-aortic region for the lymph nodes and also presence of kidneys. And if you actually supervise your studies, maybe you can get away without giving contrast in certain conditions, and I'm going to reiterate that. But if you actually have a lot of scanners spread out, like we do have along New York and New Jersey, then you probably are better off of actually having a standard protocol which is followed, because you can't really, you know, supervise every single study. But in a small setting, that is actually doable. So before starting to actually dictate your report, you need to know indications for the MRI, and they are obviously automatically populated, but we sort of tailor them accordingly because there is more information probably on the medical record. What is the intended treatment? Because then you have to mention certain things which pertain to a certain treatment, and we'll go through that in detail. Age of the patient is very important, so is the menopausal status, phase of menstrual cycle, as well as the use of oral contraceptive. And that's really important. Like this case here, you can see that was actually a patient who had an MRI of the spine for back pain, and the person reported it was a neuroradiologist a few years back now, and they thought the uterus was really abnormal. They got worried about the possibility of a sarcoma. But actually, this is a classic appearance of somebody with a long-term oral contraceptive when you actually have a lot of endometrial and inner myometrium junction zone atrophy and the globular myometrium. So, once you know the pitfall, then you can easily sort it out. And that was actually the case when the patient was asked. You have to ask for use of hormone replacement therapy because you have different thresholds for endometrial thickness, and then, of course, the risk of polyps and endometrial cancer. And, of course, any pertinent OB/GYN history. State the indication for the exam, describe the sequences used, and this pretty much in our hospital actually comes automatically, so we don't actually need to do that. You have to adapt it if you gave antiperistaltis or not, just to make sure you're accurate. In the uterus, presence, position, or orientation, you have to really state that. Size and 3D. It's very important because sometimes they decide on the approach. Endometrial thickness, obviously, comment on the junction zone if it's thickened or not, presence of adenomyosis, and comment on the cervix. Ovaries, obviously, presence, size. We don't usually measure ovaries unless they're abnormal, and then you have to give measurements. But otherwise, the ovaries appear normal, no adnexal masses will actually suffice. And just a word on free fluid, because we overuse the word ascites all the time. If there is a small amount of fluid in the pelvis, especially in the patient's premenopausal, you don't have to say there is ascites present. Ascites has got a pathological connotation, means that it's actually malignant cells, so, or due to, not malignant, but due to a pathology. So I use free fluid in my report. Uterine anomalies, again, presence, position, orientation, configuration, size of the uterus. If septated, you must state if it's complete or partial, muscular or fibrous or both, and the length of the fibrous part, and we saw that case already. If unicornuate, you have to state if there is a rudimentary horn, if it's communicating or not, and if there is active endometrium within a horn, and that's important. And again, I'll show you a case because it really is crucial when you plan the treatment. And for the ovaries, we just went through that. But in the case of uterine anomalies, there is a strong association with polycystic ovaries, so you have to mention them when you think they have a polycystic configuration. And of course, unicornuate uterus has a high association with endometriosis and hematosalpinx, so again, you have to mention that on your report. And again, if the kidneys are present, absence, or the duplex system. Just to show an example of uterine anomalies, that's actually a 15-year-old who came to the hospital with a RACA 125, around 4,500, and with abdominal pain. The ultrasound described a normal uterus and a left adnexal mass suspicious for ovarian cancer, which statistically probably was unlikely at the age of 15, but in the RACA 125. So we did an MRI. As you can see, this is a classic appearance of a unicornuate uterus with a banana shape. Cavity, and then you can see the other cavity, which is a non-communicating, and there is blood products. You can see on T1 FATSAT images, you can see these hematosalpinx here. So that's what we said, and what they do, they go in and actually they resect this horn, and of course there was no evidence of malignancy. Just put everything into the context: the age, the symptoms, and as well as the imaging appearances. Leiomyomas and adenomyosis, I've grouped them together in the interest of time. Again, you mentioned the size of the uterus, the junction zone thickness, obviously for adenomyosis, presence, size, and position of leiomyomas. This is important for treatment planning. Is there a compression of adjacent structures, type of degeneration, as well as any suspicious features? And I'm going to give you an example of that. And obviously, you got to comment about the ovaries. If a case is planned for uterine artery embolization, you have to comment on the vasculature. Is there an ovarian uterine artery anastomosis or not? That is really important for treatment planning. And of course, presence of hydronephrosis, which doesn't mean that that's a sign of leiomyosarcoma, because large leiomyomas can cause hydronephrosis. Now, moving to the uterine malignancies, it's been a really long way, especially in the US, to actually try to and accept MRI as one of the ways to evaluate extent of tumor in an endometrial cancer. I'm not using the word staging because it gets some of the clinicians a little bit too anxious if we say we can stage it with MRI, but actually we can. So, and finally, NCCN, this is the 2017, just all the press, it does recognize the role of MRI in several sort of indications, and that's quite a lot of achievement from the imaging community to establish the origin of the tumor, endometrial versus endocervical, when you have an endometrioid cancer pathology. Definitely for fertility sparing, and I'm going to show you an example of that. For suspected cervical involvement, as well as for type 2 histology, so serous papillary and clear cell carcinomas, you can use it for staging, and of course for recurrence. So we do actually have got a long way in the US. France was always very pro-MRI, and they have it as part of their staging, and of course the imaging societies have MRI as their modality of choice. But what we need to do is actually get the imaging into the clinical guidelines, not just into our imaging societies. So how do I report on MRI for the endometrial cancer? State the tumor grade, the cell type. Is it a adenocarcinoma, or is it a serous papillary type, or is it a clear cell type? And the CA125 level, if that was done. Because if you actually notice on the labs that the patient has a raised CA125 level, then you worry already about the peritoneal spread. And it makes you look extra carefully to the omentum and the paracolligators and the ovaries, because then the type of surgery would be the one that you do for ovarian cancer rather than the one for the endometrial cancer. The tumor appearance, the size, the morphology, if it's heterogeneously enhancing or not. And sometimes I put some sort of notice on how it looks on the ADC map, and I'll give an example later on. And of course, tumor extent, depth of myometrial invasion, is it superficial, is it deep, involves the serosa or not, is there any cervical stroma invasion? Just don't forget the endocervical extension doesn't change the staging anymore, but cervical stroma invasion makes it a stage 2. And of course, is there any extrauterine extension into peritoneal disease or lymph nodes? And so you can see in this case here, it's a deep invasion of this endometrial cancer, and there is bilateral ovarian metastasis already. That's a case of a serous papillary tumor. Again, your report will stratify the patient because none of that is actually available. Well, perhaps the cell type, and I'll discuss that later, prior to surgery. All these then will become available after the surgery, and you really want it before the surgery. So it's a lot of, it's one of the really good papers in this field. It's written by one of my colleagues, Alberto Vargas, looking at tumor location, endometrial versus endocervical. And it's actually pretty simple when you think about it. You have to identify the internal cervical os. And if the majority of the tumor is actually cranial to the endocervical os, that's going to be an endometrial cancer. And you can see here after contrast, just another image. And if the majority of the tumor is caudal to the internal cervical os, then this is going to be a cervical cancer. Why is it important? Well, it is very important because they cannot sort out it in pathology, but the treatment might be, it will be different because the type of the extent of the parametric excision you do is different for endometrial cancer compared to cervical cancer when you actually do a very time procedure and you do a very wide parametrial excision. So just a word on fertility preservation and endometrial cancer. This is actually very important since we're seeing some more and more young patients who require fertility preservation, or rather require or actually want fertility preservation. Because of the widespread obesity, we're seeing endometrial cancer in young patients now. So it's not the standard of care, but many institutions like ours do offer it, at least give it a trial. There are certain criteria, FIGO grade 1 endometrial cancer, absolutely no myometrial invasion, that's where the MRI actually enters the equation, no synchronous ovarian tumor, no ovarian metastases, no nodal metastases, obviously no Lynch syndrome, and no contraindication to progestin, which is the treatment they do. So in our institution, those patients have an MRI to actually exclude presence of any myometrial invasion, so this is really important. Otherwise, they'll be ineligible. And just to show you a case here, You can see on T2, it actually does look smooth, but it's very important to see this very smooth subendometrial enhancement line, which is completely intact here. You can't hardly see the tumor. You cannot see the tumor on this T2, but the junctional zone is completely intact. So this was confined to the endometrium, and the patient successfully received treatment with progestin. Compared to this other one, when the tumor is larger, it expands the endometrial cavity. A little tougher on those T2-weighted images, actually, to see the invasion. But very nice here after contrast, you can see this subendometrial enhancement line is actually interrupted. And you can see this sort of frontal leg of the tumor invading into the inner myometrium. So very important to keep in mind. And they do follow this patient with the MRI and biopsy to make sure there is no progression and there is complete response after treatment. There are several staging considerations one has to take into account in endometrial cancer. The majority of patients are actually stage 1 at diagnosis. It's very important, the depth of myometrial invasion, because if you actually have a deep myometrial invasion case with a grade 3 or a type 2 cancer, serous papillary or clear cell, your chance of para-aortic lymph node metastasis goes from 4% between up to 6% to actually 40%. So this is how important the myometrial invasion is. So is it easy? Well, nothing is easy, but now we have a lot of tools, so you can use both, all three, T2, diffusion, and dynamic multiphase contrast enhancement, and there is a lot of literature on that. And if you look at various studies, they propose a combination of one or the other. But basically, both diffusion and DCE probably perform equally, with a little bit better diffusion in this meta-analysis. And actually, I am a strong believer that if you did supervise your endometrial cancer staging on your MR scanners and you got nice diffusion-weighted images, you really don't need to give contrast. But if you don't supervise them, then it's better off to actually give contrast, because you don't know if the diffusion images are actually good enough. There's been some very elegant work done by one of my colleagues, Stephanie Nougare from Montpellier, looking actually at tumor volumetry and also the volumetry of the ADC as well. She showed that if the ratio between the tumor and the uterus volume was less than 25%, then there is no myometrial invasion. But if it was more than 50%, all cases had deep myometrial invasion. So that can be potentially actually applied, and you can do it in your scanners, and it does give quite a lot of information to the clinicians. Just a couple of stages as examples. This is a case of endometrial cancer, again on T2. It's a little tough. Maybe you can say, well, it's definitely not outer myometrium, and maybe it's really irregular. Maybe you've lost a little bit of junctional zone here posteriorly. After the contrast, just remember the tumor is of low signal intensity, no enhancement. It enhances less than the adjacent myometrium. And you can see on the ADC map here, on the diffusion weighted here, it's bright and will be dark on the ADC. I'll show an example in a minute. What I want to point out here is this bright area, which I've seen it called before a myometrial invasion. This is just peritumoral inflammation. It's a very, very nice paper from our Japanese colleagues here, and I encourage you to read, because it is a pitfall that you'll encounter very frequently. So again, peritumoral enhancement is an inflammation. It's actually not deep myometrial invasion. Just to show you the type of images you can actually get, this is a 1.5 Tesla, just really standard. And you can see a large endometrial tumor here invades a little bit more than 50%, probably on the sagittal. Nice to have those really perfect obliques, because you can see here in both T2, contrast, diffusion, and ADC maps that the tumor does invade into the outer myometrium. Again, if you get this quality of diffusion, you can actually cross the contrast and save some time and money in the scanner. Cervical stroma invasion, I think contrast does have some value when it comes to cervical stroma invasion, and so the diffusion actually can do the same. You can see this is a tumor here which extends into endocervical canal. On T2 it's a little tough. Is it actually invading, or is it just pushing the cervical stroma to the back? Much easier here on these post-contrast images. You can see tumor is infiltrating, kind of eating out into the cervical stroma posteriorly, and that was indeed cervical stroma invasion. Very, very important, because those patients will have vaginal brachytherapy after their surgery. So you can counsel a patient before actually they start their treatment. Just to give you many phases of sort of stage 3A, At this point, you probably don't need anything beyond the T-tumor anatomical images. This large tumor, obviously, the serosa is gone here. You can see the tumor is outside the uterine contour. This is a case of a septate uterus with a small adenomyoma in the septum, just to spice the case up. But that's an endometrial tumor here, with the tumor growing into both fallopian tube and the ovary. So definitely, that's easy on the T2. That's another case here with tumor with a met in the ovary. That's the primary endometrial cancer here, and then it's tumor walking into this fallopian tube, which is distended with tumor. It can be subtle, so I think diffusion does have a role here. And this is a case of serous papillary adenocarcinoma. So you can see there is deep myometrial invasion. It's actually less than what one thinks on T2, but still was deep at pathology. If you look at the T2s, you really wouldn't think anything on the adenxa here on the left, but on diffusion-weighted images, it's hard to ignore this bright spot here. And you can fuse the images. That usually does help to actually promote modality, especially with the surgeons and the oncologists, because it's like nice color pictures, and that's what we're supposed to do as radiologists. And you can go back, I can see the adenxa here. You can see there is a really indistinct area. We called it because the serous papillary was very strict to diffusion, and the CA125 was high, and indeed it was an 8 millimeter deposit in the surface of the left ovary adenxa. So that's a very nice case given to me by my colleague and friend, Professor Togashi from Kyoto. A large endometrial cancer, obviously invading the cervical stroma here. There is a little tumor sort of nodule in the serosa there, so definitely a 3A. Any vagina involvement, really hard to say on those T2-weighted images, but then you fuse them with diffusion-weighted images, and it just, even retrospectively, I don't think, maybe with the eye of faith, you can see that part here, but, you know, this lower vagina here, I wouldn't have picked it up on a T2-weighted. So I think diffusion is excellent when it comes to really small lesions, and like drop lesions in the adenxa, in the cervix. So I suggest using that because it's quick as well. So endometrial cancer aggressiveness, there's been a lot of literature on that, on diffusion-weighted images. There is some contradictory sort of evidence, but by and large, I think there is now sort of some consensus that there's a difference between grade 1 and grade 3, but there's no difference in grade 2 and grade 3 endometrial cancer. And actually, there is a nice talk in tomorrow morning's session at 8 o'clock on looking at different ways of looking at tumor aggressivity on endometrial cancer. There's also a relatively recent paper here, which is actually quite nice, again from Japan group, looking at DCE, and again there is indication here that you can actually predict the type of endometrial cancer, type 1 versus type 2, grade 3 serous papillary and clear cell, using the dynamic contrast analysis as well. And just to point out this very nice case given to me by my colleague, Professor Anwar Padani from Mount Vernon in London. And we actually see that not very infrequent now. This is, as you can see there, this is the diffusion B0, B500, and ADC, and the fused images. I just want you to appreciate that there is different shades of gray in this ADC. And although this patient had a grade 1 endometrial cancer at a biopsy prior to surgery, what the biopsy missed is the serous papillary cancer at the back here, which is actually the worst prognosis part of this tumor. So we do actually use this. We eyeball it, but you can also measure it. We actually use this in the report. And sometimes I do say on the report, like I do for prostate as well, the degree of restricted diffusion suggests presence of a type 2 or presence of a higher grade tumor. So they actually are extra careful for that when they treat the patient. Very quick on leiomyosarcomas. That's a whole holy grail. What do? You can distinguish very easily the garden variety leiomyomas from leiomyosarcomas. The problematic is the atypical leiomyomas or, cellular leiomyomas from leiomyosarcomas. And there is some elegant work done by my colleague here, Dr. Lackman, in combining certain features as described here, the nodular tumor borders, T2 dark areas, hemorrhage on T1, as well as central necrosis. And if you combine, if you have 3 or more features present, that actually you have a very high sensitivity and specificity to actually diagnose it. So you really have to get all the information together in order to achieve that. Diffusion, there has been some recent work there. The problem is there is always overlap in the ADC values. So I think we need to do a little bit more work on diffusion in order to actually use it effectively for this purpose. Just moving to the last part on cervical cancer, what are the MRI indications? Well, origin of the tumor, we already covered that. Selection of fertility sparing, and I'm going to spend a minute on this. Evaluation of parametrial invasion, that's the key question. Oh, I'm sorry. Radiotherapy planning and follow-up, and of course, evaluation of tumor recurrence. And finally, the suitability for pelvic exenteration, or like we call it now, pelvic reconstruction. So what does the MRI report say? Again, tumor grade, cell type, FIGO stage, you've got to state it, if it's available, tumor appearance, and tumor extent, parametrial invasion, hydronephrosis, vaginal, bladder, rectal invasion, of course, metastases and lymph nodes. So these are the criteria for trachelectomy, which means amputation of the cervix, a little bit of upper vagina, and the lower cervix and the lower uterine segment. And you have to accurately measure the distance. So, and again, this is some nice work done by Dr. Lackman here. If there is, you have to measure distance between the tumor and the internal cervical os. You can see here is very close to, definitely less than a centimeter. On the other case here is more than a centimeter. This case did not have trachelectomy, unsuitable. This case is suitable because the tumor is more than a centimeter from the os. Parametrial invasion, when it's subtle, it's more difficult. Obviously, when it's a big tumor, it's more difficult because it's adjacent stromal edema. And an intact low-intensity stromal ring will gives you a high negative predictive value for excluding parametrial invasion. This is a small tumor. You can see this lip of tumor here outside. Does the diffusion help? It does increase your confidence. You can see this sort of little bit of tumor going out into the parametria, and you can see there on the fused images, this patient had surgery because she had ulcerative colitis, so she couldn't have radiotherapy, and indeed she had parametrial invasion on the right. This is gross parametrial invasion. You can see there, there is spiculated tumor to parametrial interface. Here there is tumor, frank tumor, or soft tissue extension into the parametria, and then encasement of the periuterine vessels. Then we got into the advanced disease, and with this case, I'm going to illustrate all stages of the disease. And again, when it comes to this stage, you really don't need probably diffusion or contrast. It's just so advanced, and luckily we don't see them that often. But you can see here 3A, stage 3A vagina, lower vagina. Hydronephrosis is a stage 3B, and you can see there bladder invasion is a stage 4A. And you can combine, of course, diffusion and fuse your images. And there's a small note here, which you can't say much on the ADC alone or the fused images, but you go back to the T2 and you can see this node is round, and it's on the side of the parametrial invasion, which makes it highly suspicious for metastasis, and indeed it was. So with 1 second left, this is my last slide. So take-home points. It's imperative to optimize the MR technique and beware of person pitfalls. The use of pathology-specific report is crucial, and it's crucial you talk the same language with your clinicians. And MRI does play an important role and added value in all those indications that I discussed with you. And again, it's working with the clinicians is how we promote our modality and the value and the added value of modality. I just want to thank my super team here, Dr. Vargas, Nugara, and Dr. Lackman for just making my work fun. Thank you very much.
Pleasure and honor to introduce Professor Dr. Victoria Cherniak. Dr. Cherniak is going to talk about overview of CT, MR algorithm, and major features. Dr. Cherniak is a professor of radiology and urology in Montefiore Medical Center in New York. She is a co-chair of PI-RADS steering committee. I always tell her that she is the fearless leader. I'm not scared of her. She's really nice. She's a co-chair of lexicon and writing working group. Credit goes to her for a lot of the materials in the manual. She has been the lead for that. She's currently the interim section chief in Division of Abdominal Imaging in Montefiore. And she's also the director of body MR imaging. Victoria is very well known, and she's very talented in many things, and she's very talented radiologist. She is a very nice colleague, and she has many publications. You can look her up under these publications under her name, Victoria Cherniak. She is also a great writer, so whenever she's in charge of writing any manuscript. She is the best in putting it together. And the group, I mean, the whole group are really appreciative of her help. And right now I'm going to make Dr. Cherniak the presenter. So Dr. Cherniak, you can please share your screen.
Can you see it?
Absolutely, I can see it.
Okay, well, Dr. L says, thank you for this outstanding introduction. I'm bright red beet color right now, even though you can't see it. But again, thank you so much for the introduction, and really thank you for putting this terrific program together. I said that before we started, that if anybody on earth could have possibly put together such a wonderful program with such fantastic speakers so quickly, that would be you, Khaled. So thank you so much. Okay, so we're going to talk about LIRAD CT-MR diagnostic algorithm. Let's see if it's not going. Okay, this is my disclosure. I also want to acknowledge that some of my schematics came from LIRAD's manual and were created or co-created with Claude Serlin, who spoke yesterday. So outline of our talk today, we'll talk briefly about hepatocarcinogenesis as a background, then talk about HCC diagnosis and challenges it may present, and then move into CT-MR LIRADS specifically. So hepatocarcinogenesis is a stepwise process which begins with a cirrhotic nodule, and as time goes on, this cirrhotic nodule can progress and form a low-grade dysplastic nodule. By the processes of clonal expansion, this nodule then can progress to high-grade dysplastic nodule, at which point you notice that portal triads will decline in density and arterial flow begins to decline. As the process continues, the nodule can progress into early HCC, at which point you can see that the portal venous supply decreases considerably as well. The next step is small progressed HCC, and this is the step where the impaired arteries increase in density, and as a result we see increased enhancement on the arterial phase. Finally, we get to large progressed HCC, at which point the tumor can form a capsule, and then as the tumor progresses, transcapsular infiltration may happen, and in some cases the arterial flow can decline, and especially in infiltrative HCCs, they can switch to glycolytic metabolism. So one of the questions we can ask ourselves is why HCC diagnosis is so complicated. I'm sure many of us have been on the service and been presented with cirrhosis case and multiple lesions, have kind of groaned a little bit in anticipation of painful experience. So one of the things to remember is that not all primary malignancies in patients with cirrhosis are HCC. Remember, the hepatic progenitor cells are the ones who, under normal processes, differentiate into hepatocytes, which then, through oncogenic transformation, form HCC. These same hepatic progenitor cells also give rise to cholangiocytes, which then, under oncologic transformation, can form intrahepatic cholangiocarcinoma. So patients who have cirrhosis are also at higher risk of intrahepatic cholangiosis. Then these same hepatic progenitor cells can then form hepatic cancer stem cells and then form what's called combined HCC cholangio tumors. And then to complicate matters even further, the tumors that start out as straight up HCC or cholangios can then de-differentiate into these combined tumors. Another layer of complexity is that not all lesions in patients with cirrhosis are malignancies. There are plenty of other lesions, including all kinds of cirrhosis-associated hepatocellular nodules, non-hepatocellular benign lesions such as cysts, non-mass lesions such as areas of focal fat deposition or confluent fibrosis, previously treated lesions, and of course, various malignancies. Not all observations in cirrhosis are true lesions. Patients who have cirrhosis often form these pseudo-lesions either due to artifacts or areas of hypertrophy that kind of form these mass-like projections, vascular pseudo-lesions. So all these things complicate matters. As a result, in PI-RADS, we use the term observation, which we define as distinctive area relative to background liver. And the reason why we use observation, not lesion, because the word observation is both applicable to true lesions and pseudo-lesions. So it doesn't cloud our thinking when we find something in the liver. And then we have to go down the pathway trying to figure out if we're dealing with a true lesion or pseudo-lesion. So again, why is HCC diagnosis so complicated? Well, first, we need to detect a lesion. Then we need to distinguish it from a pseudo-lesion. Then we need to distinguish it from a benign lesion. Then we need to distinguish it from other malignancies. And we need to do so with specificity very close to 100%, which is a requirement that really doesn't exist for most other radiologic diagnoses, at least in cancer imaging. So why do we need this 100% specificity? Well, when we reach diagnosis of LR5 category, the management decision is that HCC is confirmed and patients undergo multidisciplinary discussion for consensus management, and notice that the biopsy is not required for confirmation. So in order to avoid a biopsy, we need to be very, very accurate and very, very specific when we say something is HCC. So what is LI-RADS? As Claude and Dr. Sutherland mentioned yesterday, LI-RADS is a system for standardized imaging of liver cancer. As of today, we have 4 algorithms, and today we're going to talk about CT MR diagnostic LI-RADS, which is a standardized system for HCC diagnosis on CT or MRI. This is the algorithm summarized in 1 page. This algorithm is accompanied by a core which provides definitions and descriptions of standardized imaging features along with their definitions. CT-MR diagnostic LI-RADS contains 8 diagnostic categories, which are listed here. And we're going to discuss how to assign these categories. Our first step in assigning these categories is apply the LI-RADS algorithm, which is the page that I just showed before. And we start this process by making sure that the patient is at high risk for HCC, which LI-RADS defines as patients who have cirrhosis, chronic hepatitis B viral infection with or without cirrhosis, or patients who have current or prior HCCs. Notice that LI-RADS is not applicable to patients who don't have these risk factors, who are less than 18 years old, or who have cirrhosis due to vascular disorders or congenital hepatic fibrosis. So the question is why? Why make things so complicated? Why can't we just use LI-RADS in everybody? And to understand that, we have to have kind of a little bit of digression into pretest probability. And to do that, we're going to assume that the LR5 criteria have positive likelihood ratio of 17 based on the data we have currently. We're also going to use kind of the pretest probability based on this gastroenterology paper that talks about different prevalences, and we use the highest versus lowest prevalence. So the pretest probability, if the pretest probability is 50, and our test has positive likelihood ratio of 17, our post-test probability is close to 95%. The same test, when applied in a situation where pretest probability is only 1.5%, gives us post-test probability less than 20%, which is of course insufficient to say that we can assume that a lesion is HCC when the post-test probability is only 20%. So we need to have high enough pretest probability of HCC to use LI-RADS 5 criteria as definitive diagnosis of HCC. And this is the reason why LI-RADS is only applicable in patients who are at high enough risk of HCC. And those are the patients I've listed before. Okay, so once we confirm that we're using the LI-RADS algorithm in the appropriate patient population, we're going to kind of march down this stepwise algorithm until we get to a node that fits our case. So the first node is if cannot be categorized due to image degradation or omission. This is LRNC, non-categorizable. To understand this, we have to kind of touch upon required phases, which are the same for CT and MR, and they include arterial phase, portal venous phase, and delayed phase. And again, these are required for either modality. LRNC is applicable when one of these required phases is either missing or non-diagnostic, and as a result, we cannot say whether the lesion observation that we're seeing is more likely to be benign or more likely to be malignant. So it's not enough to have a phase that's missing or non-diagnostic. It also needs to be a situation where we really can't tell heads or tails as to what we're looking at. So how does it work? Well, here's a T2-weighted sequence. We see a lesion on T2-weighted sequence. We give contrast, and the patient is just completely non-compliant, breathing. And if I were to ask you, do you think this is more likely to be hemangioma or HCC? The answer is I really don't know. Based on these images, we really can't tell. So this is a situation where LRNC is correct. So LRNC should not be used for cases where the imaging appearance is weird or we really don't know what's happening. It's only for the cases where the technical problems preclude even narrowing down the categories. Okay, so if this is not applicable, we're going to march down. So the next node is if definitely tumor in vein. It's LRPIV. It is defined as having a definite enhancing soft tissue in vein, as you can see here. In many cases, there's also going to be an accompanying parenchymal mass, but it doesn't have to be present. So presence of enhancing tissue in vein alone without a parenchymal mass is enough to assign this category. The next node is if definitely benign, LR1. PI-RADS doesn't provide criteria for these entities as of 2020. This is something that has been developed, but at this point, we just assume or hope that the radiologists know the classic imaging features of all these benign entities. So here's an example. We have cysts in this psoriatic patient. There's no doubt that there are cysts, 100% there's cysts. We can all bet there are cysts. There's absolutely nobody who can argue against them being cysts. And because we have this degree of certainty in this diagnosis, we're going to call it LR1, definitely benign. LR2, probably benign. The same entities also listed here, but when there's something is unusual about them, maybe hemangiomas or sclerosed or just have weird appearance that where you really pretty sure it's hemangioma, but not 100%, that's where LR2 is applicable. Another entity that's specific to LR2 is called LR2 distinctive nodule. These are nodules which are less than 2 centimeters in diameter. They lack imaging features of malignancy, either major feature or alarm features. They lack ancillary features of malignancy, and this is an example here of LR2 distinctive nodule. The next node in our decision tree, if probably or definitely malignant, but not HCC specific, and this is LRM category. Most LRM lesions will have target-to-it appearance. Target-to-it appearance can be seen on dynamic sequences as a rim arterial phase hyperenhancement, peripheral washout, or delayed central enhancement. And Dr. Fowler will discuss these in much more detail tomorrow. Target-to-it appearance can also be seen on GWI and hepatobiliary phase, as you can see here. So in all these cases, you see this kind of target-like appearance where the periphery of the tumor looks different from the center. Important thing to remember that presence of only one of LRM features is enough to assign LRM category. Okay, so if we move down this decision tree and none of these categories apply, we arrive to this node. Otherwise, use CT-MR diagnostic table to differentiate between LR3, 4, and 5. So before we talk about diagnostic table, we have to talk about major features that are used in the diagnostics table. So let's talk about major imaging features. The first one we're going to talk about is non-rim arterial phase hyperenhancement, which is defined as enhancement in arterial phase, which is unequivocally greater than the background parenchyma, not most pronounced in periphery of the observation. And this is what distinguishes non-rim arterial phase hyperenhancement from rim arterial phase hyperenhancement, where the hyperenhancement is primarily in the periphery of the lesion. These example of various modalities shown arterial phase hyperenhancement, you can see that it's all pretty much equivalent. Crucial thing to remember is that non-rim arterial phase hyperenhancement is a required feature for PI-RADS 5 categorization. So that if you have a situation where arterial phase hyperenhancement is not present, LR5 category is not applicable no matter what other imaging features are present, and no matter how certain you are in your heart of hearts that you're looking at HCC. So LR5 category must have arterial phase hyperenhancement. The next major feature is non-peripheral washout, which we define as temporal reduction enhancement. And as a result, the observation is hypo-enhancing relative to the background parenchyma. And this hypo-enhancement is not primarily in the periphery of the observation. And again, as a contrary to peripheral washout, where the washout is primarily seen in the periphery of the observation. Washout appearance can be assessed on either portal venous phase or delayed phase with CT or extracellular contrast MRI. It's important to remember if we are using getaxetate, the washout can only be assessed on portal venous phase, at least in the current version of PI-RADS. Enhancing capsule is defined as a smooth, uniform, sharp border, which is unequivocally thicker or more conspicuous than the background of fibrotic tissue surrounding the nodules. Capsule can be assessed on any post-contrast phase, either portal venous phase, delayed phase, or transitional phase. Size is measured as the largest dimension from the outer edge to the outer edge. If the capsule is present, it should be included in the measurement. Another important thing to remember is size over 10 millimeters is required for PI-RADS 5. So if the observation is less than 10 millimeters, it cannot be categorized as PI-RADS 5. So again, no matter what other imaging features are present, PI-RADS 5 cannot be assigned if the size is less than 10 millimeters. So I'm going to repeat that because it's so important that PI-RADS 5 category requires presence of both non-rim arterial phase hyperenhancement and size of 10 millimeters or greater. Another thing to remember for size mention is we should not use arterial phase or diffusion weighted sequences to measure the size if we see the observation on any other sequences. Why so? We'll consider this example. We have an observation with non-rim arterial phase hyperenhancement and a non-peripheral washout appearance. If we use arterial phase for size measurement, we get 12 millimeters, which allow us to get PI-RADS 5 categorization. But if we use the portal venous phase, this observation is only 7 millimeters, in which case this is PI-RADS 4. So the reason why we do not use arterial phase is because periarterial corona enhancement can be seen, blend in with the tumor, and overestimate the size. So to preserve the specificity of PI-RADS 5, we want to be as conservative as possible and really use not use arterial phase unless absolutely necessary. Threshold growth is defined as a size increase of a mass by at least 50% within 6 months. Threshold growth definition was updated in 2018. In the prior versions, there were 3 ways to get to threshold growth, as you can see here. In PI-RADS 2018, only the top one, again, 50% or greater size increase within 6 months is considered threshold growth. Everything else is considered subthreshold growth. A general rule for application of major features is that if you're not sure if the major feature is present or not, you assume that it's not present. So the idea is that you really have to be absolutely certain that the major feature is present to say that it's present. So if you're trying to decide if the washout is present or not, you go with not present. Another thing to remember is not for any given major features, none of them by themselves yield 100% positive predictor value for HCC. What does that mean? So if we create this graph with on the y-axis we have increasing positive predictor value for malignancy, and on the x-axis we have increasing positive predictor value for hepatocellular origin. And we put our major features on this graph, they kind of will look like this. But for PI-RADS 5 category, we want it to be here. We want to be nearly 100% certain that this is malignancy and nearly 100% certain that this is hepatocellular in origin, HCC. And notice that not a single one of the major features falls into this sweet spot. But different combination of major features do yield different probabilities of HCC. So if we look at our major features and we have a combination of arterial phase hyperenhancement and washout in a lesion which is over 20 millimeters in a patient with cirrhosis or hepatitis B, this means 100% probability of HCC. If we have a arterial phase hyperenhancement washout in a capsule in a small lesion less than 10 millimeter size, and again, in a patient with high risk for HCC, this lesion has about 70% probability of being an HCC. And if we have a 10 to 19 millimeter observation with arterial phase hyperenhancement only, this lesion in appropriate patient population has about 30% probability of being HCC. So probabilities are great. You may be wondering, well, how am I supposed to kind of arrive at these probabilities? And the truth of the matter, again, in 2020, we do not provide probabilities, but we use the categories as surrogates for these probabilities. And we assign the categories by using the table. And this is how the table is applied. So we're going to focus on this larger observation right now. First thing we're going to look at is whether or not arterial phase hyperenhancement is present. In this case, it's a yes. So we're going to select the part of the table that's labeled non-rim arterial phase hyperenhancement. The next step is to look at the observation size. In this case, it's 93 millimeters. Again, we're not going to use arterial phase for measurement, which means we're going to select the column where the size is over 20 millimeters. The next thing is we're going to count additional major features. And in this page, in this larger lesion, we only have the washout appearance, which means we have only one additional major feature. Intersection of the row and a column gives us the cell labeled LIRADS 5. So this observation meets criteria for LIRADS 5. If we look at the smaller observation in this patient right here, again, we start with whether or not arterial phase hyperenhancement is present. And the answer is it is. So we're going to select the part of the table called non-rim arterial phase hyperenhancement. We're going to look at the size. In this case, this is 17 millimeters. Note that the capsule is included in size measurement. So we're going to select the middle column labeled 10 to 19 millimeters. Next step, we're going to count additional major features. In this case, we have capsule and washout appearance. That means we have 2 additional major features. We're going to select the bottom row labeled 2 or higher. Again, intersect of the column and a row gives us a cell labeled LIRADS 5. So this observation is LIRADS 5. So this is how the table is applied. So this was a very long discussion of step 1. Step 1 is the longest and most labor-intensive step. When we're done with it, we may choose to apply ancillary features. It's optional at this point. If we do choose to apply ancillary features, this is the rules for its application. We're going to go we're going to increase the category by 1 if there's 1 or greater ancillary feature favoring malignancy. Make sure that remember that we cannot go from a 4 to a 5 based on the ancillary features in order to preserve specificity of LIRADS 5 category. If we have 1 or more ancillary feature of favoring benignity, we can decrease the category by 1. And if we have both ancillary features of malignancy and benignity, we do not adjust the category. The next step, if necessary, we're going to apply tie-breaking rules. What does that mean? Well, you went through steps 1 and 2, and you still are not sure if the category between the 2 categories. So the rule is that if you're not sure, you choose the category with lowest certainty, either lowest certainty of malignancy or benignity, or lowest certainty of hepatocellular origin, which means if you're deciding between 5 and M, you should go with an M because it's a lower certainty of hepatocellular origin. If you try and decide between 4 and 3, you go to the 3 because it's a lower certainty of malignancy. Final step 4 is very quick. Final check, just does the category that you arrive make sense? If it does make sense, you're done. If it doesn't make sense, you should go back and figure out where the mistake was and recategorize the lesion as appropriate. I spoke about the fact that each LIRADS category translates into probability of HCC malignancy, and we now have data that supports that LIRADS in practice actually works as intended. This was a meta-analysis published about 6 months ago, and you can see that there's a nice straight line for categories 1 through 5, where you see percentage of overall malignancy versus percentage of HCC, and as expected, LIRADS M kind of falls off this line. So LIRADS versions 2014 and 2017 performed very nicely. 2018 brought a little bit of a change to it. Dr. Serlin kind of went over this slide yesterday. But to reiterate that in 2018, a major milestone was achieved, which is unification with ASLD, which means that the LIARDS criteria were incorporated into the ASLD practice guidance. You can see this is from the paper where they use LIARDS categories. They accept LIARDS 5 criteria, so there's no longer separate ASLD criteria. But for that to happen, we had to change a little bit the LIARDS 5 criteria. How so? Well, the small lesions, 10 to 19 millimeters, which had non-rim arterial phase hyperenhancement and non-peripheral washout, in prior versions had to be visible on screening ultrasound to be called LIARDS 5 ultrasound. In all other cases, these lesions were called LIARDS 4. In 2018, the requirement for ultrasound visibility was removed, so that any lesion 10 to 19 millimeters with arterial phase hyperenhancement washout now meets criteria for LIARDS 5. Additionally, because there's only one threshold growth definition, the observations 10 to 19 millimeters with non-rim arterial phase hyperenhancement and threshold growth used to be called LR5G as a designation that they met criteria for opt-in HCC, one of the HCC categories. Now the G can be removed and it's just LIARDS 5. So, which means that the changes to this criteria will likely affect sensitivity and specificity of LIARDS 5. We now have a little bit of data that says that specificity for LIARDS 5 using version 2018 criteria decreases a little bit, somewhere between 3 and 5%. So to summarize what I've talked about, CT-MR algorithm is applied in 4 steps. We first apply this algorithm, we then optionally apply ancillary features. If necessary, we look at the tie-breaking rules and then final check. Does it make sense? Did we come up with an answer that actually makes sense? Remember, for major features, each individual major feature does not have positive predictor value of 100%, which is what is required for LIARDS 5. And the combination of features yield different probabilities of HCCs. And the diagnostic table is what we use to kind of arrive of what different combination, what different categories will yield. Remember that each LIARDS category reflects a probability of HCC malignancy or benignity. And then again, LIARDS diagnostic table is used to assign categories 3, 4, and 5. With that, this is our LIARDS steering committee, and thank you so much for your attention, for the fact that you joined us. And again, Khalid, thank you so much for organizing this.
Did you hear the clapping, Victoria?
Thank you for clapping, Khalid. I appreciate it.
I just want to show the appreciation of everyone. This was a great talk and really comprehensive, really informative, and it had a lot of information about LIARDS and how to use the algorithm.
Good afternoon, everybody. Thank you for the introduction. It is an honor for me to stand here and talk to you about the role of MRI in the staging of rectal cancer, and to tell you something how we as radiologists perform and interpret the MRI of the rectal cancer. So the main goal of the MRI is to provide a very accurate local staging, and thus to provide a roadmap for optimal treatment planning for every individual patient. As you all know, this schematic overview, the treatment of rectal cancer highly depends on the disease stage. Very early rectal cancer needs a different approach than locally advanced rectal cancer. And the stage of the disease depends on various factors, like the T stage, of course, the end stage, but also the involvement of the mesorectal fascia or the presence of extramural venous invasion. So knowing everything about these different factors will help us to know whether we have to deal with a good rectal cancer, namely the early stage disease, a more bad disease, or a very ugly rectal cancer. So all of these factors that I just mentioned, they can be seen on the MRI. So hopefully you understand that MRI is very important in this disease. Well, how do we do it? It's actually a quite basic protocol. We only need T2-weighted images in 3 orthogonal planes, in the sagittal plane and in the axial and coronal plane. And these are angulated perpendicular and parallel to the tumoral axis. And in very low-lying disease, we scan also parallel to the anal canal to optimally be informed about the invasion of the anal sphincters. We can do this on a 1.5 or a 3 Tesla scanner. That really doesn't matter. And to acquire very detailed anatomical information, we need slice thicknesses of a maximum of 3 millimeters. We do not need fat suppression. We do not need T1-weighted images, not before nor after contrast enhancements. And we have various options to reduce artifacts. For example, we can use spasmolytics to reduce bowel movement. This is especially important for tumors located in the upper rectum. We can also choose to administer a microenema right before the examination to remove all the gas intraluminally and thus the gas-related artifacts on the diffusion-weighted images. So on the top row, you see the 3 T2-weighted images in the 3 different planes, and these are added with a diffusion-weighted sequence on the far right. This whole protocol duration is less than 15 minutes, so it's easily and fastly performed. So how does diffusion-weighted image work? It's a very similar scheme here. It has a very low anatomical resolution, but a very high contrast resolution. So you have a very large differentiation between tumoral tissue and normal tissue, because normal tissue gets suppressed, because normal tissue has a very low cellularity, and that means that the water molecules can move freely. And the more they can move, the more signal that they lose. So here in this example, you see, for example, the bladder, and it becomes very black on the diffusion-weighted images. So all the information gets suppressed. However, in tumoral tissue, the water molecules cannot really move. They are contained in their original space, and they retain their signal intensity. So these remain high in signal. As you see here, in this rectal tumor has a very high signal intensity on the diffusion, the high B values of the diffusion-weighted images. With this protocol, we can get the anatomy at a very high resolution, and we can see all the structures that we need to be informed about very accurately. As you can see here, the mesorectal fascia is nicely seen, and also all the surrounding organs and structures. So we have a lot of factors that we have to look at. Of course, first we start with the morphology. Is it a very bulky tumor, or is it more polypoid lesion? What is the location? Is it anteriorly or more posteriorly? These interpretations we do in a clockwise manner, meaning at 12 o'clock is at the anterior side, 6 o'clock is the posterior side. And after that, we measure the height of the tumor. We do that from the anorectal junction, and then we measure it until the lower pole of the tumor. And then after that, we also measure the length of the tumor. With this interpretation, we also do the other factors that I already talked about, the T-stage, mesorectal fascia invasion, whether or not there are positive lymph nodes, and whether or not there is extramural venous invasion. And these factors, again, let us know whether this is a more early disease or a more advanced disease. So when we look at the T-stage, we can easily see whether or not the tumor is confined to the rectal wall. When we see a very black line confining all the tumor margins, we definitely know for sure that the tumor is confined to the rectal wall and that there is no mesorectal fascia invasion. And also the mesorectal fat is free of tumor. The stage T3, of course, means that the tumor has grown through the rectal wall into the mesorectal fat. And as we know that it has a prognostic value, we have to define the depth of invasion of the mesorectal fat. When it's very superficial, like in T3A and B, it's less than 5 millimeters, we can accurately measure this distance, as various studies have shown that the measurement on MRI correlates very well with the measurements on pathology. When you have a little bit more advanced disease, you have more deep infiltration of the mesorectal fat, up to more than 50 millimeters in stage 3D disease. And most of the time, that also means that the mesorectal fascia is threatened or involved. In stage T4, of course, we have invasion of surrounding organs. As we see some examples here on the left, you see that the posterior bladder wall is invaded. In the central image, we see that the prostate is invaded, and on the right image, again, the bladder wall that is involved with the tumoral tissue. Mesorectal fascia, that is of course a very important factor because it determines whether or not TME can be performed safely. So we have to consider that in low rectal tumors, the mesorectal fat is completely surrounded by the mesorectal fascia, and the higher up we go, the more close we come to the peritoneum. And at the level of the peritoneal reflection, which is shown here on the left image as a seagull, we know that there the peritoneum, instead of the mesorectal fascia, is located at the anterior side. And the more higher up you come, of course, the more the peritoneum is located at the mesorectal fat. Here, an example of a very bulky tumoral mass within the rectum itself, but you see that on the posterior and left lateral side, there is a lot of dark infiltration of the mesorectal fat extending to and even through the mesorectal fascia on the, mostly on the posterior side and a little bit on the left side. As you can see on both the axial and the sagittal plane. Another example of a very, very bulky tumor, a mucinous tumor, where we can see that the mesorectal fascia is threatened like 360 degrees, and on the right posterolateral side there is even breakthrough of the mesorectal fascia. Then the end stage. Here is a subject where it is a little bit difficult for the radiologist, because when we look at size only, we know that we are not that good, because as we can see here in this table, even very, very small lymph nodes measured 5 millimeters or even 0.5 millimeters, they can still be involved with tumor. And the other way around, also larger tumors, they can be negative as well. So that's not a criterion to base yourself alone on. We need other factors to predict whether or not we have involved lymph nodes. So we do not only look at the size, but we also look at the borders of the lymph nodes. Are these clearly defined or are these more indistinct? Another factor we can look at is at the signal of the lymph node itself. When it becomes very heterogeneous, we have more suspicion of lymph node involvement. And also when the lymph nodes become more round than oval, that might also be a clue to think that these lymph nodes are involved. And on the right side, you see that when you combine all these factors from size, border, signal, and form, you see that the accuracy of lymph node prediction increases. Here's some examples which are quite easy to interpret, of course. I think you all agree with me that these are lymph nodes that are absolutely involved. And the very important thing, of which we also will hear about later, is that we do not have to look only at the mesorectal lymph node, but also at the extramesorectal lymph nodes, as these can become a site of local recurrence. However, we also have more difficult cases, of course. I think the person who can differentiate the benign from the malignant lymph node based on only the T2 and the diffusion-weighted images as shown here, yeah, he can come and work at our department, because I'm really not sure which one is that. Only after reviewing at pathology, we knew that the above image represented lymph node metastasis, and the other one was just a reactive lymph node. The last factor that we also look at, and which is also a very important factor, because with the presence of extramural venous invasion, we know that this patient is at 4 or 5 times higher risk of distant metastases, either synchronous or metachronous. We have to look at the surrounding vessels, whether these have a normal size and normal signal intensity, because at the moment they become larger and they get the signal intensity of the adjacent tumor, then we have to consider that extramural venous invasion is present in this patient. At the bottom, we have some nice examples of the invasion when you see the tubular structure with the same signal intensity as the primary tumor, then we actually know for sure that the extramural venous invasion is present. When do we do it? We can do it at many different occasions, of course. We can do it for primary staging of both primary tumors, but also for recurrent tumors. At the top image, we see a very bulky tumor, circumferential tumor in the rectum, and this patient underwent neoadjuvant chemoradiation, and after that was restaged again with MRI to see whether or not there was a good response to the neoadjuvant treatment, and maybe whether or not this patient could enter a wait-and-see protocol and doesn't need any surgery at all, maybe. However, we see in this patient that there is still some signal on the diffusion-weighted images, so no complete response. He's responded very well. Of course, the size of the tumor has decreased. The signal on the T2 has become very dark, so it's mainly fibrosis, but the diffusion is still indicative of some residual tumor. Another occasion where we can do the MRI, of course, is during follow-up after the patient has reached a clinical complete response. What we do is, of course, at the standard MRI after the chemoradiation, we do the scanning. So this was a very low-lying rectal cancer on the left and posterior sides. This patient opted for chemoradiation, and after termination of the neoadjuvant treatment, we did a new MRI, and we saw a very dark signal at the site of the primary tumor, and also on the diffusion-weighted images, no signal left. So it was also on endoscopy suspicious of a clinical complete response, so we opted for the wait-and-see protocol. And then after 3 months, we re-evaluated again with MRI, and we saw no changes. Still, this, the image of a clinical complete response. And after that, again, the re-evaluation was performed with MRI and endoscopy, and both confirmed still the clinical complete response. Of course, MRI also has its problems and its challenges. Sometimes it's, of course, difficult for us to make the differentiation between T1 and T2 disease. This might not be that large of a problem if you don't opt for the local excision, for example. However, there are some studies that will be focusing now with even more detailed images and with the training of radiologists to become more familiar with the differentiation between these early tumors. Also, we might have some problems with the differentiation of T2 and T3A, because some tumors display some desmoplastic reaction, and as I showed you earlier, the clear black margin around the tumor will be a little bit infiltrated, and that might either be very subtle tumoral infiltration or the desmoplastic reaction. But of course, in that case, we know for sure that there is a large distance to the mesorectal fascia. As I told you, the problems with the lymph node staging, we still are looking for the best way to interpret that. Unfortunately, we haven't found it yet. The differentiation between fibrosis and viable tumor might also be difficult sometimes, but the diffusion-weighted images are very helpful for that differentiation. Then there are also some matters, of course, which are now a matter of debate. The timing of the scan after chemoradiation, we see that mostly it's advised to have it 6 to 8 weeks after the stop of the chemoradiation. However, in our clinical practice that we see, if you wait a little bit longer, like for example 12 weeks, we see even more response. Patients who were not responders after 6 weeks, for example, might become clinical complete responders after 12 weeks. And then during follow-up, most of the times people use every 3 months now, but also there that can vary between various centers. So to summarize, all the findings that we have at the MRI, we have to combine it with all the clinical findings and have a very thorough multidisciplinary team discussion. And in that way, we can opt for the most optimal treatment for every individual patient. Thank you for your attention.
Thank you, Arti. Hi, everybody. Hope you guys are all doing well in these trying times and trying to make the best of where you are and how you are. Are you guys all able to see the PowerPoint presentation?
Yes.
Okay, great. So I'm going to do a 15 to 20 minute talk on MR imaging of rectal cancer. For those of you that read a lot of rectal cancer MR, you know this is a broad topic and tough to cover in 15 to 20 minutes. I'm going to focus just on the initial staging of rectal cancer, not the post chemoradiation imaging. So I have no disclosures. So this talk was one I gave at last year, the 2019 SCBT MR SABI conference. So you may have seen some of these images, but we're going to talk about rectal cancer management, normal rectal cancer and rectal anatomy, the protocol that we use for rectal imaging, and then how we actually stage rectal cancer with MR, and then one last slide on the reporting template. So rectal cancer management is based very much on the local stage of the tumor. And what do I mean by that? Well, you know, the two real management strategies include the excision, which is total mesorectal excision, plus or minus chemoradiation, depending on the local stage. So if you have a tumor that is local stage T1 or T2 without any nodal disease, that patient goes straight to resection or TME without preoperative or without neoadjuvant chemoradiation. But if you have stage T3 or T4 or any nodal disease, N1 or N2, that's considered a locally advanced rectal cancer, and those patients get pre-op chemoradiation or neoadjuvant chemoradiation before going to excision. That's a very sort of a simplified algorithm that's followed in the US. It's a little bit different in Europe, a little bit more complicated, but this is, for the most part, what we do here in the US at this time. So the real crucial part of this is staging. Local staging is important, and MRI plays a huge role in that. So in order to stage rectal cancer appropriately with MRI, we really need to know the anatomy of the rectum. And what do I mean by that? I mean the cross-sectional anatomy of the rectum. So we really need to know the layers of the rectal wall. So the innermost layer is the mucosa, and then followed by the submucosa, and then this thick band that's typically dark on T2, which is the muscularis propria. And then surrounding the muscularis propria is the mesorectal fat in blue, and surrounding that is the mesorectal fascia. So these are important layers to keep in mind as we stage rectal cancer on MRI. Now you'll notice this is an axial oblique T2 weighted image. You may wonder what that is. Well, that brings us to the rectal cancer MR protocol. And this protocol is available on the SCBTMR or SABI website. There's also a protocol available on the SAR DFP website for rectal cancer. They also have a great resource there. So we start with sagittal and axial T2 weighted images. These are typically fast spin echo or turbo spin echo images. And then we want to perform imaging oblique to the image of the tumor, to the plane of the tumor itself. So we do axial oblique. And what do we mean by that? We actually take a plane that is perpendicular to the tumor, which provides us the axial oblique image. And you can see there, what we're looking at is a cross section through the bulk of the tumor there. And then we do similarly a coronal oblique image, which is in a plane parallel to the tumor on the sagittal image there. And there you can see the coronal oblique image. So the utility of both of these axial and coronal oblique planes is to really give you a good cross-section through the tumor along the cross-section through the walls of the rectum, and provide a relation and tell you about the relationship of the tumor to that wall. And as we go through, I'll show you examples of how that'll help us with the actual T-staging. We also perform diffusion-weighted imaging routinely at our institution. This is actually more useful in the post-chemoradiation imaging, which we actually will not go into today, but I'll show you some examples of diffusion-weighted images in the initial staging as well. I have there in gray the pre and post-contrast T1-weighted imaging. Typically, this is not recommended by the SAR DFP, and we do not do these, especially for the pre-chemoradiation cases. Sometimes we do in post-chemoradiation, but that's a different topic that we won't cover today. But in general, these are not required, especially for initial staging. Rectal cancer staging can be done on 1.5T or 3T. We use surface pelvic coil, not an endorectal coil. Patients are imaged in supine position. And then depending on your institution, you may or may not use a bowel prep, such as a microenema, intrarectal contrast, or a spasmolytic agent. Now, we have recently started using intrarectal contrast, and we have found some utility in it. We've always used glucagon, and we do have the patients administer a microenema before they come. So take home here is really the important part of the technique is these high resolution axial and coronal oblique T2 weighted images. These should be no more than 3 millimeters in thickness. And then as we go through the actual MR staging process, there's a number of parameters that we have to describe, and these are listed here. I'm not going to go through each one, but as I go through the talk, you'll see each one of these described. So the first thing is the location of the tumor. And this can be described as an upper, middle, or lower rectal tumor. The rectum is generally considered to be about 15 centimeters long from the anal verge. And so if you divide that into thirds, you can kind of gauge if the tumor is in the upper, mid, or lower rectum. We give a general description of the location, and then we actually measure the location and the distance from the anal verge. So we see the anal verge down there, and so you would measure up from the anal verge the distance of the inferiormost aspect of the tumor. We also measure the distance of the inferior aspect of tumor from the anorectal junction, the anorectal junction being obviously higher than the anal verge. And then finally, we measure the tumor size, and that's measured in a single craniocaudad maximal length of tumor. Then we talk about tumor morphology, and what do we mean by this? Well, a tumor can be semi-annular like this. It can be annular where it's completely circumferential, and it can be polypoid. So polypoid obviously is like it's got a stalk, and it's a bulk of the tumor is in the form of a polyp, intraluminal polyp there. So these are variations in morphology of the tumor. In addition, we can describe if a tumor is non-mucinous, so it's got this intermediate signal intensity on T2, which is typical of a non-mucinous rectal tumor, or mucinous, which is moderately hyperintense on T2 weighted images, such as this middle tumor here. And so the one in the middle is mucinous, the ones on the ends are non-mucinous. And this is important because mucinous tumor generally has a much poorer prognosis than non-mucinous tumors. So why would morphology matter? What I like to teach our residents and fellows is really the morphology, in addition to describing the tumor to the surgeon, actually helps you find the area which tends to be the most invasive component of the tumor. And so if you look here, this is kind of a semi-annular tumor with the edges of the tumor kind of seen here at the right anterior and right posterior aspect of the tumor. And so once you know where those edges are, if you look directly opposite from that area, that's where the invasive component of tumor is most likely to lie. Okay, so what I teach our residents and fellows is look for those look for those rolled edges, and then opposite from there is where you want to look for the invasive component of the tumor. So it can help you in that way. So for a polypoid tumor, typically the invasive component is going to be at the base of the polyp. So morphology helps you not only describe to the surgeon, but also for you to help identify the most invasive component of the tumor. So the local T stage, obviously, as I mentioned, determines management and need for preoperative chemoradiation, but also is a prognostic indicator and determines the rate of local recurrence. The T stage on MRI, the accuracy is only about 85%. So it's not the best, but you know, it's sort of the best tool we have, because the prior to MR, endoscopic ultrasound was used, but that was good mostly for T1 versus T2 stage, not extramural extension. So the local T stage, as I mentioned, is determined when you determine the relationship of tumor relative to the walls of the rectum. So here we have a tumor that is confined to the mucosa and submucosa. So this is a T1 tumor. This tumor here is involving the muscularis propria, but not going past it. So this is a T2 local stage tumor. And then if you have a tumor that's extending past the muscularis propria into the mesorectal fat, now that becomes a T3 tumor. And the T4 tumor will involve either the visceral peritoneum or any adjacent organ. So that's a T4 tumor. So the important distinction here is a T2 versus T3. T1 and T2 are treated with surgery alone, total mesorectal excision. T3 and below, T3 and T4 are treated with neoadjuvant chemoradiation followed by excision. So our job as radiologists really is to differentiate T2 versus T3 tumors on the MR. So let's look at some examples. So here's a coronal oblique image through this tumor. And if we magnify this, we look at it, we can see that this outer coat is the muscularis propria, it's intact. This tumor is involving the mucosa and the submucosa. So this is a stage T1 with intact muscularis propria. This patient goes straight to excision without chemoradiation. How about this tumor here? So this tumor actually involves the muscularis propria. You can see the muscular propria is gone, but there's no extension past the muscularis propria. So this is a stage T2. Again, patient can go straight to resection without chemoradiation. In comparison, this tumor here, so the way we describe this is a semi-annular tumor with the invasive component extending past the muscularis propria. You can see this sort of defect in the muscularis propria and tumor extending out into the mesorectal fat. So this is a stage T3. An MRI is better to define stage T3 than endoscopic ultrasound. And based on this finding, the patient in the US will get neoadjuvant chemoradiation and then go to resection after that. This is another example of a stage T3. This is that mucinous tumor, the circumferential mucinous tumor I showed you earlier. So the dotted line, as you can see at this juncture here, is disrupted with this kind of extramural extension of tumor. Similarly here. So these areas are sort of defects in where you expect the normal extension of the muscularis propria with tumor extending outside. So with these mucinous tumors, it can be tough to see the extension beyond the rectal wall. What you're looking for is you're actually looking for the defect of that muscularis propria because this hyperintense tumor may be very similar to the surrounding fat. But this is a stage T3 tumor. Patient will get neoadjuvant chemoradiation prior to resection. And here's an example of that T3 I showed you earlier. Here's an example of how diffusion images can be helpful. So we have this, again, semi-annular appearance with restricted diffusion. And not only do you see it in the bulk of the tumor, but you also see that restricted diffusion confirming that the abnormality outside the proper rectum, in fact, is tumor with the restricted diffusion. So once you determine that this is a T3 tumor, then you want to report what's called depth of extramural invasion. And this is a radial measurement outside from basically measuring out from the muscularis propria to the most peripheral extent of tumor, okay? So here's an example here. The muscularis propria is in that location and we're measuring out to the most peripheral portion of the tumor. Here's another example here. If we were to extrapolate where the muscularis propria would go, it would look like that. And then you want to measure out from there to the most peripheral extent of tumor. And why is this important? Well, we can substage T3s into T3A, which is less than 1 millimeter beyond the muscularis propria, T3B, which is 5 millimeters or less beyond the muscularis propria, compared to T3C and D, which, as you'll see, are 6 to 15 millimeters and over 15 millimeters beyond, respectively. And the reason this is important is because really it's an important prognostic indicator. Cancer-related 5-year survival is 85% in T3A or B tumors and 54% in T3C or D. So much so that in Europe, T3A and B, these tumors, which are less than 5 millimeters beyond the muscularis propria, they're treated in the same manner as T2 tumors, T2 and T1 tumors in the US. They go straight to surgery, and they've found very similar survival and recurrence rates in those patients that are T3B or below and don't get chemoradiation prior to surgery. So for us, it's very important to report this depth of extramural extension because it predicts survival. Now here's a pitfall when you're looking at tumors. So let's take this large mid-rectal tumor and draw a cross-section, get that axial oblique image, and we're seeing these fine spiculations in the mesorectal fat, and these are just spicules of desmoplastic reaction. You can see that these are very, very thin, nothing nodular about them, so you wouldn't call this T3 based on this image. But then if you take an image down here, now you're seeing this kind of more nodular extension as opposed to some of these more fine reticular extensions. So based on this finding, this is a T3 tumor. Same thing on the coronal oblique image, a T3 tumor based on that nodule of extension. But just solely based on these fine speculations, you would not call it T3. This is an important distinction to make, so I wanted to show this case. And here's an example of a much more advanced mid-upper rectal tumor. You can see it's invading the bladder dome here and also invading the peritoneal reflection with the yellow arrow there. So this is a stage T4B. T4A is if it only had peritoneal reflection involvement. 4B would be if it has organ invasion, in which this one does. So this would be a T4B. Okay, so we've talked about the local T stage. We've talked about the measurement of the extramural extent. Next thing to talk about is the circumferential resection margin. This is defined as the shortest distance of the tumor, of the outer edge of the tumor, to the mesorectal fascia. Remember, mesorectal fascia is that fascia that surrounds the mesorectal fat that I showed you in the earlier slide. The CRM is considered threatened if tumor comes within 1 to 2 millimeters of that mesorectal fascia. It's considered positive if it's within 1 millimeter of the mesorectal fascia. The mesorectal fascia serves as a natural dissection plane for the surgeon. So when the tumor is within 1 millimeter, it's considered positive, and the surgeon really needs to know that. And this is again important because it predicts 5-year survival, much lower 5-year survival when you have a positive CRM, and much higher rates of pelvic recurrence if you have a positive CRM compared to when you don't. Now, important distinction here is you must specify if the CRM is positive based on the primary tumor extent or based on lymph nodes in the mesorectal fat or tumor implants that may be separate from the bulk of the tumor actually within the mesorectal fat. And it's been shown that if the CRM is positive because of the primary tumor being that close to the mesorectal fascia, that's a poorer prognosis than if it's a lymph node that's close to the mesorectal fascia causing the positive CRM. So here's the case where this is greater than 2 millimeters, so this is a negative CRM. In contrast, here's a patient where if you were to draw where the mesorectal fascia is, the tumor is sitting right on it, and so this is a positive CRM. Now, lower rectal cancers are, you kind of have to think about them a little bit differently because in addition, so there's no mesorectal fascia down there. Instead, you have to worry about the levator muscles. So there's this separate staging system that was put out by the Mercury group a number of years ago for determining the stage of a lower rectal cancer based on their involvement of the anal sphincter complex. Now, the stage itself, you know, people tend not to report the stage because it can be confusing. Oncologists, medical and surgical oncologists think of stage differently than we do just on the imaging. So instead of actually giving it a stage 1, 2, 3, 4, as was proposed by the Mercury trial, we basically talk about if it's involving layers of the sphincter complex or not. And as you can see here, you're comparing it to the muscle coat of the internal anal sphincter, and then the intersphincteric plane, and then talking about how close it is to the actual levator muscles and external sphincter. And let me show you an example here. So here's a case where you have a lower rectal cancer. You can see that this muscular coat of the rectum itself is intact, and the intersphincteric plane here is clean. And then you have the puborectalis muscle outside that. Posteriorly here, you can see that this muscle is intact. And on the coronal image, which really is helpful for determining the extent of this tumor relative to the anal canal, you can see that the tumor is confined by the rectal wall. So this is confined by the bowel wall and not involving the muscular coat. So this is what you would call a stage T1. But basically what we would say here is no involvement of the sphincter complex. As opposed to this case here, another low rectal cancer, and you can see on the sagittal image that the tumor has grown through the rectal wall, completely involving the levator plate, and this is the outer sphincter muscle here. Same thing on the left side. On this coronal image, you can see this is the outer wall of the rectum. Tumor has gone through that. This fat is the intersphincteric plane. It's definitely infiltrated that, and also it's infiltrating the levator muscles and the external sphincter muscle here on the outside. So this would be the other extreme of positive involvement of the sphincters all the way through. And this again helps with surgical planning, because if there's involvement of the sphincters, then if the surgeon is considering excision, they would consider an extra levator APR potentially, which is obviously they need to know that beforehand. All right, next thing we want to talk about is lymphovascular invasion. This tends to be undercalled in radiology, and what this is tumor extending along the lymphovascular bundle. It can be contiguous, as is here. You can see the bulk of the tumor here, and you can see similar signal intensity within an expanded vessel extending up from the tumor. So this is pretty straightforward to call. But how about this? This is a different patient, axial image, and you can see a couple of these nodules in the mesorectal fat, and you may be inclined to call these mesorectal lymph nodes. But before you do, you definitely want to look at these on a different plane. And when we look at the coronal oblique plane, we see that this is actually a tumor implant along the course of a vessel. So this is actually meets definition of lymphovascular invasion. So this is You wouldn't call this a lymph node. You would call this a tumor deposit along a vascular bundle, which is, qualifies as positive lymphovascular invasion. So this patient would be called as having lymphovascular invasion. And a lot of people don't think about this as lymphovascular invasion. They always want to look for the contiguous tubular extension of tumor. And so I think that's why lymphovascular invasion tends to be undercalled, but make sure to call this lymphovascular invasion because that's what the definition is. And again, this is important because you have a lower 5-year recurrence-free survival and higher rate of metastases at 1 year. A negative lymphovascular invasion predicts better chemoradiation response, and you can see there the MR tends to have lower sensitivity because of some of the reasons I talked about, but better specificity. All right, how about nodal stage? So, traditionally people have talked about a 5 millimeter cutoff, size cutoff, to call involved lymph nodes, but it turns out that that's only it's very low sensitivity and specificity. So what you want to look for is the malignant morphologic criteria, and what this is irregular borders of the lymph node, heterogeneous signal intensity, or round shape. So if you have a lymph node that's less than 5 millimeters, in order for it to be considered suspicious, you should have 3 morphologic criteria, and then if it's 5 to 8 millimeters, you want to have at least 2 morphologic criteria. If it's over 9 millimeters, it's suspicious regardless of morphology, and any mucinous lymph node is also considered suspicious. I will tell you, and I've talked to other people in practice, if you have a very heterogeneous node, it looks rounded and spiculated, even if it's very small, we tend to call that as possibly a positive lymph node. Okay, so last couple of things here. Structured reporting. We've started using this SAR template recently, and I won't go through the details. This is available on the SAR DFP website, but basically, it divides the report into characteristics of the primary tumor. The T stage has a special section on low rectal tumors where it talks about involvement of the sphincters and what level of involvement. Lymphovascular invasion, the CRM, talks about a section on lymph nodes, and then the impression kind of puts it all together. So it's really a template, and it meets the criteria for the NAPRC. The NAPRC is the National Accreditation Program for Rectal Cancer. If you have not heard about this yet, it probably is going to come to a center close to you pretty soon. This is a American College of Surgeons initiative where they're accrediting various centers, and radiology also has certain requirements where we have to be involved with the multidisciplinary care, and we have to report according to what they call the Ontario template. And that SAR template I showed you has all the elements that are required for this reporting. I don't really have time to go into all of this right now, but if you have questions about it, feel free to reach out to me, and we can definitely talk about it more in detail. So I think we covered all these things, and in the interest of time, I'm not going to repeat the summary slide, but if you have any questions, I'm happy to answer those.
Awesome.
That was great. There is a question from Sajal. Sajal, do you want to just unmute and ask your question? She wrote in, if there is a 1 millimeter margin of error for the CRM, would you ever actually dictate a T2 tumor, since the muscularis propria is only about 1 millimeter and you may miss microscopic invasion through the muscularis?
Yeah, that's a good question. So as I mentioned to you, this MRI sensitivity specificity is about 85% or so, but it's sort of the best we have in order to determine the extension past the muscularis propria. Now, the hardest distinction we have to make is that T2 or late T2, meaning full thickness T2 involving the muscularis propria, versus the very early T3. If you have a T3 that's with an extramural extent of 10 millimeters, that's a pretty obvious call, but it's those 1 to 2 millimeter of extension past the muscularis propria that's very difficult. Now, the other problem is the second you say this is potentially T3, but you can't differentiate early T3 from T2. At least at our institution, the patient gets chemoradiation, and you never know if you were right or wrong. Extrapolating from the European data, where they treat T3A and B, meaning anything with 5 millimeter or less extramural extent, the same as T2 tumors, and have the same survival rates. In fact, in some cases, less morbidity because the patients don't go through the chemoradiation. I try to sort of undercall the T3As. So what I'll say is, if I'm favoring T2 or T3A, I might favor the T2 and just call it a T2 and say this is full thickness T2, knowing that that's about the only way I will find out if I was wrong was if this patient goes straight to surgery, and also knowing that patient in other centers like in Europe has the same survival as a maybe better in some cases as a T3A tumor treated with chemoradiation. So I'm not sure if that's the right thing to do. I've talked to other people from the rectal cancer DFP about this, and some have similar thoughts. Some tend to say, the second you can't tell T3A from T2 apart, you call it T3A. And depending on your relationship with your surgeon, that's something you probably want to talk about. But that is a known limitation. It's hard to tell the 1 to 5 millimeter extension sometimes past the muscularis propria.
Awesome. Any other questions? Okay.
Hi everyone, my name is Rajesh Bayana, and I'm going to be providing you with an overview of our study recently published in AJR that aimed to compare PI-RADS version 2 and 2.1 with respect to inter-observer agreement and diagnostic performance in both PZ and TZ lesions. My co-authors are listed here from Massachusetts General Hospital, and I want to thank them as well as AJR for giving us this opportunity. So the intention of this video is not to go through our entire study in detail. The paper is available on the AJR website, and I've included the link in the description below. But instead, I want to discuss some of the key findings from our study, so hopefully you walk away from this overview with some practical points that you can apply to your practice. So, as you know, PI-RADS is designed to standardize prostate MRI, including how images should be acquired, interpreted, and reported. And in our study, we are mainly focusing on the interpretation piece. PI-RADS version 2, released in 2015, really simplified the interpretation and scoring of lesions by specifying the primary sequences in both PZ and TZ lesions, namely diffusion score in the PZ and T2-weighted score in the TZ, and introduced a simplified algorithmic approach to scoring. In 2019, PI-RADS version 2.1 was released that kept this same basic framework and made further modifications. And these modifications were principally designed to improve the inter-observer agreement or agreement in interpretation between radiologists, and hopefully also improve diagnostic accuracy. And we'll go through all of these changes shortly, but since inter-observer agreement and diagnostic accuracy had previously pretty consistently been lower in the TZ compared to the PZ, most of the changes were to descriptors in the TZ, and the changes in the TZ have therefore received a lot of attention in the literature recently. But it's also important to note that there were some key changes in the PZ as well. So what exactly changed? And we can't cover every change to interpretation, but we'll focus on some of the most important, starting with the TZ or transition zone. As a reminder, the T2 weighted images are the primary sequence for scoring in the TZ, and the score is from 1 to 5. And on the left here we have the scoring system in version 2. A score of 1 corresponded to a completely normal gland, which is very rare, and a score of 2 in version 2 was assigned when there were typical BPH changes, namely assigned to nodules that were either circumscribed T2 hypointense lesions in the TZ or a heterogeneous nodule that was completely encapsulated. In version 2, lesions scored as a 2 could not be upgraded from there. On the right here we have the version 2.1 system. Since a normal gland without BPH changes is pretty rare and typical BPH changes can confidently be called benign, it was proposed that typical BPH nodules that were completely encapsulated could be assigned a score of 1. Then, version 2.1 introduced a new set of terms that were scored as 2, and this included atypical nodules, i.e. ones that were mostly but not completely encapsulated, as illustrated here at the top, circumscribed unencapsulated nodules, as illustrated here, as well as homogeneous mildly hypointense T2 signal between two BPH nodules. So this change is important. These are lesions that might have received a higher score in version 2 and potentially resulted in biopsy that were now being downgraded to a score of 2. In addition, and very importantly, here at the bottom, those lesions scored as a 2 based on the T2 weighted score could also be upgraded to a score of 3 if they demonstrated marked diffusion restriction, so markedly hyperintense on high B-value DWI and markedly hypointense on ADC. The idea being that atypical nodules can occasionally contain cancer, and DWI may increase the sensitivity in the TZ. In the PZ, the primary sequence for scoring is the DWI score, and the biggest changes were as follows. So first of all, in version 2, a score of 2 was described specifically as indistinct hypointense signal on ADC, as illustrated here. In version 2.1, a DWI score of 2 was described specifically as either linear or wedge-shaped restriction in the PZ, and this is designed to capture benign changes such as prostatitis. So what did we do in our study? Well, with the changes in mind that we just covered, we wanted to see how version 2.1 performed in comparison to version 2 in both TZ and PZ lesions. This would hopefully also give us some insight on how each of these changes affect interpretation. And how did we do it? Well, in brief, we had 6 radiologists look at 80 lesions on fully scrollable MRI studies, including 40 TZ and 40 PZ lesions. These included a broad array of cases, including PI-RADS category 2 to 5 lesions in each zone based on the initial reports. All 6 radiologists read all 80 of the cases, once with the version 2 rules and again with the version 2.1 rules a month later. And then we were able to directly compare how the systems performed, specifically the inter-observer agreement, and for those with pathology, a pilot performance comparison using area under the curve. Since our readers looked at all of the lesions with both of the systems, we also had the unique opportunity to look at clinically significant discrepancies between the systems, i.e., cases where a radiologist called something negative in one version, defined as a category or score of 1 or 2, and then called the same exact lesion positive in the other version, defined as a category of 3 to 5. So let's only go over the key results of our study and show you some real case examples with a lot of pictures so you can walk away from this video with something useful. First, overall, inter-observer agreement was quite good in both systems. It was substantial in both version 2 and version 2.1. For PZ lesions specifically, agreement was actually higher in version 2.1 than version 2. And for TZ lesions, agreement was similar between systems overall. When it came to our pilot comparison of diagnostic performance, overall, there was no significant difference in area under the curve between version 2.1 and version 2. In the PZ, there was no overall difference in performance amongst all 6 readers, but when we looked at the experienced readers only, aka those with over 5 years of experience reading prostate MRI, version 2.1 actually performed better in the PZ. In the TZ, there was no significant difference in performance between the two systems. So these improvements in the PZ with respect to inter-observer agreement and diagnostic performance with the experts occurred despite relatively minor changes to the algorithm. And remember, the biggest change in the PZ was the introduction of the score 2 term, or the linear/wedge-shaped diffusion abnormality term. And this new term had a higher inter-observer agreement than the version 2 term it replaced, indistinct hypointense. On top of that, when we looked at the discrepancies between PI-RADS version 2 and 2.1, again, cases where a lesion was called negative in one version or a category of 1 to 2 and positive in the other version, We found that our readers used the new term linear/wedge-shaped in 19 of these discrepancies, and this resulted in 14 more true negative interpretations in version 2.1. These were 14 lesions that were called positive, or a score of 3 to 5 in version 2, and then were downgraded to a score of 2 based on the linear/wedge-shaped term, and these were all patients that did not have clinically significant prostate cancer. And this is an example of this. So we have the high B value diffusion weighted image here, ADC, T2 weighted image, and dynamic post-contrast image here. And 4 of our readers called this mild to moderately restricting in version 2 and upgraded it to a score of 4 based on its positive DCE, aka these readers called this lesion positive based on version 2. All 4 of these readers called this linear or wedge-shaped diffusion abnormality based on the DWI and ADC maps, resulting in a version 2.1 score of 2, aka negative. This was biopsied and came back as benign prostatic tissue. This is another case, and although the term linear/wedge-shaped mainly introduced more true negative interpretations in version 2.1, like the previous case we showed, there were 5 cases where the term linear/wedge-shaped resulted in false negative interpretations with version 2.1. So in this case here, again, we have DWI, ADC, T2 weighted images, as well as the dynamic post-contrast image here. And in PI-RADS version 2, all 6 of our readers interpreted this as a category 4 lesion based on marked diffusion restriction. In version 2.1, one of our readers interpreted the diffusion signal as linear/wedge-shaped, giving it a score of 2. This was biopsied and came back as Gleason 7 prostate adenocarcinoma. And when we looked at the 5 false negative interpretations in version 2.1 based on this descriptor, cancers that were missed as a result of use of this term, 4 of them involved crescenteric, markedly restricting lesions that were interpreted as linear/wedge-shaped. It's important to note that other studies in the literature have shown that clinically significant prostate cancer can often be wedge-shaped, but when they are often mostly focal, discrete, and have lower ADC values than benign wedge-shaped PZ lesions like prostatitis. Further, small subcapsular crescenteric lesions are often misinterpreted or missed, and this one, as you can see based on the T2 images, is a subcapsular lesion. So, future PI-RADS versions may specify that focal, markedly restricting lesions and those that are exclusively subcapsular are exceptions to the new DWI score 2 descriptor, and that only radially oriented linear/wedge-shaped abnormalities be confidently assigned a score of 2. Moving along, the new TZ T2 weighted score 2 descriptors introduced in version 2.1 demonstrated only fair agreement. This resulted in much lower inter-observer agreement in version 2.1 compared to version 2 for PI-RADS category 2 lesions only in the TZ. As mentioned earlier, the overall inter-observer agreement in the TZ was similar between the two systems, and there was no difference in diagnostic performance. But when we looked at the individual discrepancies between the systems, use of these new terms resulted in 2 more true negatives, so cases downgraded to a score of 2 in version 2.1 that ended up not being cancer, but also 4 more false negatives, so cases that were downgraded to a score of 2 in version 2.1 that actually ended up being clinically significant cancer. And so let's go through some examples of these discrepancies. So in this patient, there is a T2 hypointense TZ lesion here that one of our readers called positive in version 2, and then when interpreting with version 2.1, called it a mostly encapsulated nodule, giving an assessment category of 2 or negative. This was benign at biopsy, so this case illustrates the intention of the new version 2.1 terms, namely to not overcall BPH changes. However, these new T2 weighted terms need to be applied with caution. This is an example of a case that was called positive by all of our readers in version 2. We're looking here at this homogeneous T2 hypointense lesion in the anterior TZ on the right. In version 2.1, however, 2 of our readers assigned this as an assessment category of 2, one calling it homogeneous mildly hypointense signal between 2 nodules, and the other a homogeneous circumscribed nodule without encapsulation. This lesion unsurprisingly came back as clinically significant prostate cancer, but again, since 2 of our readers misinterpreted this lesion using one of those descriptors, it's important to remember that these terms should be applied with caution. And the last change that I'll comment on is the increased emphasis of DWI in the TZ, specifically referring to the ability to now upgrade a T2-weighted score 2 lesion in the TZ to a category of 3 based on marked diffusion restriction. In our cohort, 4 patients were upgraded based on this new rule, 2 of which ended up coming back as clinically significant prostate cancer, so 2 cancers that were not detected with version 2 that were detected in version 2.1. Other papers looking at this have demonstrated similar results, ultimately supporting the use of diffusion signal in the TZ to improve sensitivity. This is an example of a case that all of our readers called negative in PI-RADS version 2. In PI-RADS version 2.1, one of our readers described this lesion as mostly encapsulated, a T2-weighted score of 2, and then upgraded the lesion based on the marked diffusion restriction to a score of 3. This was biopsied and came back as Gleason 7 prostate adenocarcinoma. In conclusion, overall there was substantial agreement in both systems and the 2 systems performed similarly. As described, there were some improvements to PZ interpretation, which is a notable finding given the emphasis in the literature on the changes to TZ interpretation in version 2.1. In the TZ, we found overall no significant difference in inter-observer agreement or performance, but bigger studies are definitely required to better appreciate smaller differences between the systems. It's important to note that the specific modifications introduced in PI-RADS version 2.1 produced mixed results. We covered only the most significant in this video, but again, I encourage you to check out the entire article for a more in-depth discussion. I think overall these findings are encouraging and support adoption of version 2.1. At the same time, we suggest areas where additional modifications might lead to further improved inter-observer agreement and diagnostic performance in PI-RADS. So that's it. Thank you again to my co-authors as well as AJR.
Good morning, everybody. Thank you, dear moderators, for the kind introduction. Thank you for the organizers to invite me to give this lecture. Although, like Dr. Verma said, PI-RADS looks to be so nice, everybody seems to like it. So why did I accept an invitation with this title? I use it every day. Why would I give a talk on PI-RADS? No. Was it because I really believe that PI-RADS is worthless? Not really. Because I think that I am smarter than Jelle Barends and Jeffrey Weinreb? I don't think so. Or is it because I have no respect for the many years and the high amount of work that were needed to develop PI-RADS? Not really. But because it gave me the opportunity to attend ISRM at Hawaii at reduced fee. That was a very good reason. So we're talking about prostate MRI, multiparametric MRI, and it's not always very easy to make a report of such an exam because it's a combination of morphological information from T2-weighted images, diffusion-weighted images, dynamic contrast enhanced imaging, and it used to be to include also in some institutions MR spectroscopy. So reporting prostate MRI and multiparametric prostate MRI is not very easy. So it was a very good step from the ESUR and the ACR and the ADMETEC to make these new guidelines, the PI-RADS system, like it was described by Professor Verma. So the objectives of PI-RADS were fivefold. First one was to provide minimal technical requirements for high-quality image acquisition. The second one was to standardize the reporting, to simplify the interpretation, to reduce the inter-observer variability, and to improve the diagnostic accuracy of prostate MRI. So in my talk, I would like to evaluate if PI-RADS could achieve these 5 goals successfully. So first goal was to provide the minimal technical requirements. In PI-RADS version 1, there were really clear minimal technical requirements described that we needed to have a high-quality prostate MR exam. In PI-RADS version 2, that's no longer the case, and it's only stated that any combination can provide adequate and reliable diagnostic quality when the acquisition parameters are optimized and appropriate technology is used. So they don't make any suggestions anymore about the use of an endorectal coil, yes or no, the use of high field imaging, 1.5T versus 3T, and so on. On one side, that's good. Everybody can do what he likes. But for radiologists who want to start with prostate MRI, this is not a big help. A more important issue is that in PI-RADS version 2, dynamic contrast enhanced imaging is recommended in all patients. Like Dr. Verma said, the added value of DCE DCE plays only a minor role in PI-RADS version 2, but moreover, currently, with the improved quality of the diffusion-weighted images the last years, the added value of dynamic contrast enhanced imaging over D2 and diffusion-weighted imaging seem to be limited. There are many studies who have been showing this, and also in my own study, where we compared the role of DCE, we found that when you strictly follow the rules of PI-RADS version 2 and only look at the DCE images in case of a PI-RADS 3 score in the peripheral zone, we saw that only in 20% of patients DCE is needed, and in 80% of patients you have scanned the DCE sequence for nothing. I'll show 2 cases. This is a patient where we have a very suspicious lesion. It's positive on the ADC map. It's clearly visible on T2. You don't need any DCE on a per patient base to show that this is a suspicious lesion. If you add DCE, you only show that it is enhancing, but the added value of DCE is limited. Another case, when you have a perfectly normal T2 weighted imaging, perfectly normal ADC map, DCE does not help much to show you that there is no enhancement. It is not unsuspected, so the added value of DCE is limited, and it can be questioned why it is still recommended to scan in all patients. If we would move over from a multiparametric MRI to a biparametric MRI by omitting DCE, this would simplify the examination because we have fewer sequences. It would be cheaper because we don't need any contrast. It would eliminate the potential risks of the injection of gadolinium. It would also result in a shorter scan time, which would be good to face the increasing demand for prostate MRI. I was recently co-author in a study where we even tried what would happen if we compare a very short, only 2-sequence, 10-minute protocol to multiparametric MRI. So we compared the performance of multiparametric MRI, including all the sequences, with only diffusion-weighted imaging and only transverse T2-weighted imaging, so no coronal and sagittal images anymore. And we saw that in the detection of clinically significant prostate cancer in patients with elevated BSA, so to decide, do we need a biopsy, yes or no, they performed similar. So this first goal was to provide minimal technical requirements for high-quality image acquisition. In the radiological community, the debate is still ongoing about the minimal requirements. Do we need 1.5 or 3T? Do we need endorectal coil? Yes or no? But this is not a major issue. I think it's not a major drawback of PI-RADS that it gives not the answer, because I'm really convinced that the prostate cancer detection rates are more importantly influenced by the tumor characteristics, the tumor volume, the Gleason score, the architecture, the location, peripheral zone of transition zone, than the field strength or the coils that are used. In the study of the systematic review that Professor Verma already mentioned, this is also clearly stated when they did subgroup analysis. The accuracy did not change in groups where they scanned on 1.5T as compared to groups where they scanned with 3T. So second goal of PI-RADS was to standardize reporting. Both PI-RADS 1 and PI-RADS version 2 give us a good indication how to score each separate image sequence on a score from 1 to 5, and the DCE was improved because it was a little bit complicated in PI-RADS version 1. In PI-RADS version 2, DCE is negative or positive, so that's very well. So PI-RADS version 2 provides explicit criteria to score each sequence and provides consistent instructions to determine the overall assessment category. In PI-RADS version 1, this was a little bit of a problem because there were no really instructions on how to calculate the overall assessment category. So, in PI-RADS, we have a 5-point score, 1, 2, 3, 4, 5, where the score 3 means equivocal. It means that it suggests that to the clinician that the clinically significant cancer, the presence of a clinically significant cancer is equivocal. This increases the specificity of findings associated with score 1, 2, 4, or 5, and it enables the radiologist to communicate a doubtful finding to the referring clinician, but it's also a problem because this indeterminate MRI remains a problem because the clinician wants, in the end, to need a binary recommendation for further diagnostic procedures. This 5-point scale has ultimately to be translated into a decision to biopsy or not. And then it's difficult. Is a score 3, is it positive or negative? It's not really indicated in a PI-RADS score what it means. Also, score 3, some descriptors, like here, state that a score 3 is if it does not qualify to score 2, 4, or 5. And this raises the possibility of a heterogeneous spectrum of abnormalities all scored 3. And in less experienced readers, the number of patients assessed with the score 3 is sometimes way too high. This is an example of such a patient with a score 3. On T2 weighted images, we have this rather suspicious, maybe low signal intensities. You cannot say that this is a normal peripheral zone. On the diffusion weighted images, it looks quite normal, although on the high BVR images, it's a little bit hyper-intense. In this patient, the contrast showed a diffuse contrast enhancement, should be scored negative. But what do we have to say to the clinician? I think we have to say it's an overall assessment score 3. It can be prostatitis, it can be low-grade prostate cancer, but if it is a low-grade prostate cancer, if this is all low-grade prostate cancer, if there is low-grade prostate cancer all over the place, then for many clinicians, this is also considered a clinically significant tumor. So what do we say to the clinician? Does this deserve a biopsy, or is it safe to watch? So this equivocal overall assessment score is a problem. The threshold score for a positive MRI is not defined. So if we said, we would say every PI-RADS score 3 should also have a biopsy, and it can be useful to target the equivocal area. This is against a further argument against DCE, since the only advantage of DCE was to upgrade a score 3 to a score 4. So a clarification of the cutoff value is needed and should be provided in the future versions of PI-RADS, but maybe this will depend on the clinical scenario. In the systematic review of WHO, they looked at the sensitivity and specificity when a cutoff value of 3 was used, as compared to when a cutoff value of 4 was used. As we saw in the systematic review, some radiologists use a score 3 as positive, others use a score 4 as positive. This score 4 may be preferred for general use, because then we have good sensitivity and a good specificity. A cutoff level of 3 may be preferred when higher cancer detection is needed, for example, in patients who have persistently high PSA despite already a negative biopsy. Then we need a higher sensitivity and the lower specificity is less important. Or maybe we could create a PI-RADS 2F. Then we don't have to decide to biopsy now or later on. We could do, just like in the renal cystic lesions, if we could provide a PI-RADS 2F, we could say it's not necessary to do the biopsy right now, but we could do a follow-up MRI within 6 or 12 months. And then this may decrease the number of PI-RADS 3 who require biopsy. In 6 months, if you see an evaluation, you see that a lesion is growing, then the biopsy can be performed. If the lesion stays the same, it can be followed. So third goal of PI-RADS was to simplify the interpretation. The PI-RADS descriptors are, however, still a little bit complex and prone to subjective interpretation, because in the descriptors, words are used like marked or mild to moderate or focal, or for example, the score 1 of the 2 weighted images in the transition zone is called the normal findings. But what is normal findings? So another thing is also that the lesion characterization remains difficult, because the different single modalities may yield discordant results, resulting in a wide scope of possible interpretations. Although with PI-RADS version 2, this concept of dominant sequences has been introduced, which improves makes the interpretation a little more easier, but this seems to be an oversimplification. It also ignores the multiparametric MRI. If you use really strictly the dominant sequence approach, you use diffusion-weighted imaging in the peripheral zone, and you not add the information that T2-weighted images may give you also. So I think when we scan a multiparametric MRI, all the sequences should be taken into account when interrogating a lesion. And we did a study in 245 patients with elevated PSA, and we compared the scoring in the same patients with PI-RADS version 1 and PI-RADS version 2. In PI-RADS version 1, using a subjective determination of the overall assessment score based on all the sequences, and in PI-RADS version, when scoring the patients with PI-RADS version 2, strictly following the dominant sequence approach. In about 90% of cases, PI-RADS version 1 and PI-RADS version 2 resulted in the same score. Positive and negative was here determined as a score 3 or higher. But in 12% of patients, we saw a discrepant overall assessment score when the same patient was scored with version 1 as compared to version 2. For example, we had 7 cases where T2 and diffusion-weighted images were suspicious, but there was absolutely no enhancement, and the MR spectroscopy was completely normal. In that case, we did score this as a negative MRI, and indeed, clinically significant prostate cancer was only present in 1 of these 7 patients. The other way, in 23 cases, we had lesions where in the peripheral zone, diffusion-weighted images were normal, but morphologically, there was a very suspicious lesion, and still in half of cases there was actually a clinically significant prostate cancer. An example here, we have a lesion that is a little bit rounded. It shows a little bit mass effect. It has a low signal intensity on T2-weighted images, but it did not really show restricted diffusion. So according to the PI-RADS version 2, this is negative because the diffusion-weighted images are scored 2, so overall assessment score is 2. When you use PI-RADS version 1, or a more subjective scoring, you use all the information and you see this suspicious lesion on T2, and it shows enhancement. Well, in half of cases, in this situation, we found a clinically significant prostate cancer. So instead of the really strictly dominant sequence approach, I think we should go to more to finding optimal weighting factors for each sequence. So diffusion-weighted images may still deserve the strongest weighting in the peripheral zone, but there should be a possibility for T2-weighted images to overrule diffusion-weighted imaging. And likewise, in T2, likewise in the transition zone, T2 may keep the strongest weighting, but diffusion-weighted imaging should also be able to overrule T2 in case of a heavily restricted lesion. Fourth goal of PI-RADS was to reduce the inter-observer variability. This has been evaluated in several studies, but appears to be rather moderate when they compare experienced and less experienced readers or between radiologists from different centers and practice settings. There are many studies on PI-RADS version 1. For example, this study of Tiffaine Vacher, who showed a poor to only moderate agreement among readers. The weighted K factor was only 0.4, 0.4, 0.3 between the readers, so that's not very good. Another study of Rosenkrantz, also PI-RADS version 1, the agreement between the experienced and the less experienced readers was only poor to moderate. Another study of Rosenkrantz also showing that in the transition zone, the agreement between readers was minimal to poor using PI-RADS version 1 in a transition zone. But also in PI-RADS version 2, it's a little bit better, but it only had a moderate level of inter-observer agreement for readers of varying experience, like in the study of Müller in radiology. We see a kappa score for PI-RADS of 0.542 in the peripheral zone, and the overall suspicion score was only 0.46. So there is still room for improvement. Also in a study of Rosenkrantz in radiology 2016 about PI-RADS version 2, the reproducibility was only moderate among 6 experienced radiologists from different academic centers for scoring PI-RADS 4 or higher. Fifth goal of PI-RADS was to improve the accuracy of prostate MRI. So in the paper itself, the PI-RADS score aims to detect or exclude clinically significant prostate cancers. In the PI-RADS paper, the definition to compare the prostate MR accuracy, it is suggested to use this definition. any Gleason score larger than 7, with prominent but not predominant component 4, and or tumor volume larger than 0.5 cc, and or tumor stage larger than T3A. The true diagnostic accuracy remains still difficult to determine because it is influenced by the threshold that is used for a positive MRI, like I said before. And also, it depends on the histopathological reference that is used to determine the clinically significant prostate cancer. The problem is that among clinicians, there is still no consensus about what exactly constitutes clinically significant prostate cancer, and this definition is not necessarily the definition that is used by the urologists. So when we compare the detection of clinically significant prostate cancer with multiparametric MRI before PI-RADS existed and now, we see that there is little improvement. Before PI-RADS, we found detection rates in this systematic review that was published in 2015. We found detection rates that ranged from 44% to 87%, and negative predictive values ranging from 63 to 98%. And we saw that the results depended on the definition of clinically significant disease that was used. Here is the systematic review of Wu and cohorts that was published recently, showed an improvement. The pooled sensitivity of PI-RADS version 2 was 95%, whereas for PI-RADS version 1 it was 88%, so it has improved. For similar specificity, PI-RADS version 2 73%, PI-RADS version 1 was 75%. So that's not too bad. Still, we see, again, a lot of differences in the sensitivity and the specificity, depending on the definition that is used, depending on the scan parameters that are used. So the sensitivity and specificity is quite well, but still, there is a problem with lesions that are very small. PI-RADS version 2 seems to be limited for the assessment of Gleason score 7 tumors, even if, when they are very small. So, in the study of Vargas I think 1 or 2 years ago, there was only a sensitivity of 26% to detect Gleason 7 tumors that are very small in the peripheral zone, and 20% sensitivity for high-grade tumors that were very small. So this is a problem, because PI-RADS version 2 states that it is a major objective to detect clinically significant prostate cancer, but it's in fact this definition of clinically significant prostate cancer includes this very small tumor. So PI-RADS does not fulfill its goals. This is a very low sensitivity. So how about other scoring systems? PI-RADS is one system, but the Likert scale has been also used in the past. Likert scale is a 5-point scoring system, just like PI-RADS, but it's more like a subjective characterization of the level of suspicion. There are no fixed criteria, and it's just based on weighting the modalities depending on the analyzing radiologist's impression. And when the results of the single scores are incoherent, the radiologist uses gut feeling to say which one of the modalities is preferred over the other. Another score that has been reported in the literature is the MLS score. It's a 13-level score, first presented by Philippe Puech in radiology in 2013. It's another scoring system, and it's based on the morphology, M, location, and signal intensity, with the 3-point score in peripheral zone, 3-point in transition zone. And then it gives also a level of suspicion for the different lesions that are found. These scoring systems were compared in some studies. So Tiffaine Vacher in 2014 compared the accuracy of PI-RADS version 1 with this MLS and Likert scale in 215 patients followed by radical prostatectomy, 2 senior readers, 1 junior reader. And they found that in the detection of prostate cancer with a Gleason score higher than 7, equal to or higher than 7, Likert score significantly was more accurate than PI-RADS version 1. When we look at the areas under the curve, for the overall populations or for the cancers with the Gleason scores larger than 7, the MLS and Likert score, the Likert score scored obviously in all readers better as compared to PI-RADS. The subjective scoring system, the Likert score, however, requires experience. So a semi-objective scoring system like PI-RADS can be easier for less experienced readers. Also, Rosenkrantz compared the accuracy of PI-RADS version 1 with Likert. They found, with 3 radiologists of equal experience, they found that in the peripheral zone, there was no clear difference between PI-RADS version 1 and Likert. In transition zone, PI-RADS version 1 scored poorer than Likert. Also, the inter-observer variability was compared in the same studies between PI-RADS version 1, Likert, and MLS. And there was PI-RADS did also perform a little bit worse than the Likert scale and similar to the MLS score. Also in the study of Rosenkrantz, the inter-observer variability between the PI-RADS scale and the Likert scale was quite similar. Of course, all these studies were performed with PI-RADS version 1. They should maybe be repeated using PI-RADS version 2, but so far I have no knowledge of this evaluation. So before I come to the conclusion, 2 final comments on PI-RADS. First thing is that the PI-RADS score is purely MRI-derived. So separating the radiological interpretation from the rest of the medical and biochemical history weakens the clinical worth of any test. I think that with prostate MRI, we should not try to detect or exclude all clinically significant prostate cancers. I think that prostate MRI performs best to detect and exclude the high-grade and large tumors. We can say to the clinician, there is a large high-grade tumor, yes or no. And then other clinical biomarkers need to be taken into account to determine whether a lesion is clinically significant or not. So therefore, prostate MRI should be incorporated in nomograms, including other relevant information to have better results. Another remark is that some recommendations of PI-RADS are based only on expert opinion. They lack concrete supporting data. They require evidence-based support or refinement. 2 examples. The size threshold of 15 millimeter to upgrade this category 4 to 5. Where does it come from? There are no studies that show that it's better than, for example, a threshold of 10 millimeters. Also, the upgrading of a score 2, the transition zone score 3 to a 4, in case of diffusion weighted score 5, it's not known whether it's optimal to apply the threshold at 5. Maybe it could be 4 too. So there may be some improvements necessary. So to conclude, PI-RADS absolutely has its merits, and the efforts so far are highly laudable. But PI-RADS does not yet achieve all its goals. Other scoring systems perform similar, or in some cases even better. And further refinements are required, and PI-RADS should still be considered as work in progress. Thank you for your attention.
Good morning. Thank you all for being here, and thank you for this invitation to beautiful Hawaii. Before I start, I just wanted to get by show of hands, how many are using PI-RADS in everyday clinical practice? Great, awesome. Not everyone though, so I was trying to gauge how much I should go into the details of this. So no financial disclosures. So just to go into a little history, how PI-RADS came about. So, Hawaiian tradition has a lot of storytelling, so it was a cold and dreary night in 2007, Stockholm ISRM, started as an ISRM. So it was the ADMATEC Foundation Working Group that was discussing prostate imaging in general, and the question came up that there was really a need for standardization. That led to a consensus group meeting in the UK, led by the urologist Louise Dickinson, and several of the radiologists came together. Again, the question was, really, there needs to be some more standardization in terms of image acquisition, interpretation, reporting, etc. And that is what led to the work by the ESUR, which is the European Society of Urogenital Radiology, to start putting something together. And that started in about 2010-11. This was published in 2012. And immediately, just to go over a little bit about what this was, the original PI-RADS version 1 had a 1 to 5 point scale for everything, for T2, for diffusion, for DCE, and spectroscopy was an option included in there. There was an equal role for DCE in that. And there was sector map and et cetera. So what it did, though, was it provided the first step towards standardizing MR, prostate MR. Clinical indications and minimal and optimal imaging acquisition protocols were provided in the originals as well, and a structured reporting system was described. So if all was there, so why was version 2 even needed? But as soon as the one was published, there were clear limitations, because this was something that was put together by a lot of just to try to get something out because there was such a big need. And there was rapid progress, obviously, especially in the area of diffusion imaging. And the idea was to get a single international standard, to have a common language for all to speak, and to simplify, to encourage widespread adoption. So the expectation was always that it was going to be a living document, that as scientific data accrued, that this could be tested, validated, and added to. So it was never supposed to be a one and all done document. And for this, there was a combined effort of the ACR, ESUR, and the Admatech. They agreed to collaborate, but it took 4 years. So for version 2 to come out, it took a fair amount of work. And this was published. This was the original 26-page document that anyone can download and see. And then this was a synopsis of the whole. And there was also an editorial by the urologist in the second, in the synopsis. And the best part was this was in a urology journal. So the idea was always to gain the clinician support, and so they were all speaking the same language, not just among radiologists, but also among the clinicians and the radiologists. So in the version 1, the focus was on technique, lesion detection, clinical applications. In 2, it was a combined effort, lesion detection, characterization, interpretation, and reporting, specifically also benign findings, image illustrations with scoring criteria, and specific measuring and mapping details were included. Lexicon is in there, and Atlas is still at work. It's a work in progress. But the idea was to make this more user-friendly. This is ideas to get it out, and so people can use it. So what, in general, what the PI-RADS is trying to do is it's a risk assessment, right? So it's trying to assess what is the chance of a clinically significant cancer. And so what is clinically significant? It's described in the document as a score of greater than 7, volume, certain volume, and if there's extraprostatic extension. So those are specific things that we're looking for. And there's an assessment category, and you may have all seen these, from very low, highly unlikely, to very highly unlikely. Now, the problem with this is we don't have any percentages because we don't have enough clinical scientific data yet. As that accrues, that can be added as well. One of the big changes between 1 and 2 was the diffusion. The highest B value was 1,000. That was included in 1, but it was 1,400 or greater for 2. And the idea is, you can see the dark area, large tumor anteriorly. You can acquire that using a high B value, or you can calculate it. And there's good data now showing that it's the same. And as you can see, if you acquire very high B values, your signal may be distorted and you can get this ghosting artifact, as opposed to the calculated B value that doesn't give you distortion and equal results. So the criteria in PI-RADS 1 was equal weighting in all, and then of course 2, there's a difference in where the lesion is located. It's all real estate, right? So location is important, and so diffusion dominates in the peripheral zone, T2 dominates in the transition zone, and here the DCE plays a minor role, but I will show you that the minor role is just not for name. It's actually fairly useful, not just for the upgrading, but I'll show you why. And here, MRSI was not included because of the not enough scientific data and the Akron trial not showing much in this arena. So of course, a 5-point scale for T2 and diffusion is still there, and the DCE is only a plus or a minus. And then algorithms and tables to determine overall score, the assessment category. So one of the bigger changes also was the size criteria in the T2 and diffusion to separate PI-RADS 4 versus 5. So if it's greater than 1.5 centimeters, it's a 5. So just quickly going into the PI-RADS T2 in terms of the peripheral zone, it goes from 1 to 5, uniformly hyperintense. And just to go show some examples, nice peripheral zone, it's bright, white, this is a normal 1. And if you go into 2, this is the stuff that you get in home, wet shape, diffuse, mild hypointensity, or you can get linear areas and indistinct margins, and that's a 2. If it's a circumscribed, homogeneous, moderate, hypointense nodule, and this is where the lexicon is very useful, what terms to use, and it gives very good examples and images in the document. And again, 5 is same as 4, but just the size is increased. But there's a little more. So there's also invasive behavior. So it's not just the size of it, but if it's if it's extraprostatic, if it's involving neurovascular bundles, et cetera, it's a 5. Now, what about transition zone? That's where really the problem is still persists. And so this is if you look at this transition zone with multiple nodules everywhere, typical enlarged transition zone BPH, this is a 2. You can have circumscribed nodules, that's a 2, but what about this? This is where you start having problems where there's it's a 3 because I don't know, it's obscured margins. And what I will show you, there are ways to help that is if you do coronal or sagittal images, look at the borders on that. And I'll go show you some examples about that. This is on the transition zone, a 5 is same as 4, but it's just enlarged, so greater than 1.5 centimeter. And here's the typical homogeneous, the erased charcoal sign that's been discussed, where you see the transition zone, you lose the architecture, and it's also bulging anteriorly. It can also be lenticular shaped, teardrop shape, et cetera. But you see, this is the normal transition zone, and now you lose it. These are fairly easy. The problem is when they're partially obscured, and it becomes a 3. So let's look into diffusion. Diffusion, obviously, one is when there's no abnormality. This is bright on ADC, and 1400, you see no bright areas, except for the posteriorly, and you can see that in the region up in the base, you'll see some dark areas in ADC, and that's bright on the high B value. It's the region of the ejaculatory ducts, and that's a normal finding. Now, what about 4? This is where you have the hypointense black and white. So a 4 is easy. It's dark on ADC, very bright on the high B value image. And if it's a 5, obviously it's bigger than 1.5 centimeters. Now looking into contrast, what is positive? For contrast to be positive, we have to have an abnormality on the T2 or the diffusion weighted imaging. So here we have a lesion in the peripheral zone, and this is focally enhancing. In the transition zone, here's a mass anteriorly that's bulging the capsule, and it's focally enhancing. So this would be considered a positive on DCE. Now, the problem is, its misunderstanding is that what is negative? So obviously, if there's no lesion on the peripheral zone here, this is negative. But if this was diffusely enhancing as well, that would be a negative. So you have BPH nodules that are enhancing, that's negative. So that's not because you're seeing this enhancement, but these are BPH nodules. Of course, you have to assess with T2 to make sure they are, and then, so that's a negative. So no early enhancement, or there's diffuse enhancement, it's a negative. So now how are these categories assessed? So again, real estate, right? Location, location, location. So peripheral zone, diffusion rules, transition zone, T2 rules. And so we have a score of 1 to 5. If it's a score of 3 in the peripheral zone, which is the intermediate category where I don't know, and the DCE is positive, it can be upgraded to a 4. Now, not so much helpful in the transition zone, because if you have a score of 3 in transition zone where I don't know, it has to be a fairly large volume diffusion change, meaning a diffusion of 5 for it to be upgraded to a 4. So this is where still some work needs to be done, but this is very helpful in the peripheral zone. So let's look at this. This is a very typical example, not great images. So this, you can get, this is something that I want to show because, instead of showing very great normal nodules, I want to show you something like this. T2 weighted image with ill-defined area in the peripheral zone. ADC, my gosh, there's so much distortion, you can hardly see. This is an area that's maybe some dark area, but look at the lesion here. You can see something bright. DCE, little enhancement there. So let's see. Let's just score how we would do this. So where's this? Obviously, this is in the peripheral zone. And this is a sector map that's available also in the document. And this will nicely map where this lesion is located. And then you can see on PI-RADS, how would you define this as wedge-shaped, mildly hypointense lesion. So it's a 2. Let's look at the ADC. It's mildly hypointense on ADC, but it's bright on the high B value, and so it's a 3. So this is where it's a 3. So if you look at 3, then contrast comes in play, obviously. And so, is the contrast positive or not? And you can see focal enhancement. That's on the other side there, and this is focally enhancing area. So this is a positive. So that's how it got upgraded to a 4. So, and this was a 3+4 tumor on biopsy.
So another example, 65-year-old with 3 negative biopsies, a high PSA, T2 weighted images. Again, not great T2 weighted images, but you can look that there's a lesion anteriorly. It's fairly large. It's greater than 1.5 centimeters, so it's a PI-RADS 5. Right away on T2, you can tell this. Diffusion is black and white, so that's also, and it's large, so it's 5. This is no-brainer. This was, a PI-RADS 5. So this is simple. Let's look at this. So 69-year-old, 2 negative biopsies and PSA of 10. Now you look at the T2. This looks okay, like BPH. What about this area? This area looks a little ill-defined, and these are the problems. And when you first start looking at this T2 in the transition zone, can be problematic. And so when you look at this, what do? I think that's where the other images, if you have the coronal and sagittal, really can play a role. And here you can see that even though it looks ill-defined here on the coronal and sagittal, you can draw the margins. And so by default, because it's transition zone and in T2, it's a PI-RADS 2. And so on ADC, it's black and white. It's this would be considered a 4 on diffusion. And DC is focally positive, so that's a but again, because it's in transition zone, this remains a 2. There are many clinical challenges. Okay, so the challenges are not just in PI-RADS, but just in imaging itself in prostate MR. And so I just wanted to highlight a few things, because once those challenges are done, that's where you can actually apply PI-RADS, because I found that to be some issues as well especially in training fellows and residents, I see that every day. For example, this is a 63-year-old man who has a PSA of 5. And he had Gleason score 6, and that was biopsied on a transrectal ultrasound, and he was referred to our institution for active surveillance. So 5% on the right base. That was the original biopsy. So as usual, when we enroll these men, we do an MRI, and when you look at this exam and the base, going back, you could not see anything in his peripheral zone, transition zone, anywhere. But when you look at his apex, there's a small area that looks slightly ill-defined, but let's focus on that. So if you look at this T2 weighted image, something is there. Yeah, ADC is a little dark here. Nothing on the high B value, but boom, look at this. DCE focally enhancing. So I find it's not just that DCE can help upgrade. I think detection, sometimes it may lead you to find the lesion as well. And so it's not just that it's a minor, and right now, because we don't have enough data for the pharmacokinetic modeling, it's a minor role, but we don't know in the future how that will play. So in this case, here's a lesion on T2. You would rate it as 3 out of 5 because it's focally defined, and diffusion will also be 3 out of 5. It's a positive DCE, so then it gets upgraded to a 4. This patient actually had distal apical extraprostatic extension. And of course, he had insignificant cancer in the base. That was all the reason he was enrolled for active surveillance. And he ended up having, his care was changed completely. He, on biopsy, had Gleason pattern 4, and he was obviously unsuitable for active surveillance. So this is a typical clinical scenario that can make a huge difference in someone's life. So now let's look at this. Where's the lesion? Don't really see it as well, but maybe something in here. But this is where you really have to use your other sequences and coronal image. So look at the coronal and sagittal. If you have either one, we get both, but some people only get one of the two. Look at them, because you'll find invariably it helps in the transition zone. It also helps in these small subcapsular crescentic tumors. And prostate cancer actually originates in the subcapsular region. So the early cancers are going to be there. Now, early doesn't mean necessarily it's going to be low grade. In this case, it was a 3+4 tumor, and it wasn't, it's hard to see it on the axial views. So how is PI-RADS doing with all this? So let me just go back actually in here. So the challenges are clinical. Obviously, detection is a big problem still, because there are tumors that hide in the apex. You can have extraprostatic extension in the apex, and you may not be able to see it on imaging as well. There are lesions that hide in the base, and so obviously understanding all of that is very important to really apply PI-RADS well. But even so, just in the past year, if you just do PubMed, you get over 300 articles not only in the radiology journal, urology, oncology, so this is all over the place. It's what I would call has gone viral on the internet. There are active blogs by patients and interest groups. I get referrals from physicians wanting to know the PI-RADS, and these are not academic physicians, so it's very impressive to see this. Nevertheless, let's see what the facts are actually. So if we look at one of the, so there's so many articles, I'm just going to concisely tell a few big ones. So this was a fairly big study, 425 patients, and the reference standard was prostatectomy, where they looked into PI-RADS version 2 and got just great sensitivity and specificity. And the best part was the inter-reader agreement. Kappa was 0.8, which was very good. And not only that, in the multivariate analysis, the PI-RADS version 2 category of lesions greater than or 4 were the only significant parameter for clinically significant cancer. So if you, and this was the study, this was in 2016, and they looked at other things such as the biopsy Gleason score, greatest percentage of biopsy core, all of that, but all of that failed in front of the PI-RADS scoring in the multivariate analysis. And so that's very obviously encouraging to look at. Another study just published this year, this was larger. This was 4,000 patients, up to 4,000 patients, and they also looked at PI-RADS version 2, but the sensitivity and the pool sensitivity and specificity was 89% and 73%. One of the interesting part in this article is that there were highly variable negative predictive value for the exclusion of clinically significant prostate cancer. This is all over the place, 63 to 98%. Significant variability in the published results, some of the typical problems with meta-analysis, differences in patient population, reference standards, magnetic field strengths, obviously all of these. But what was interesting is that it did also subgroup analysis between PI-RADS 1 and 2, and I'll go over that in a second here. So the head-to-head analysis of PI-RADS 1 versus 2, this was the WU study that was just published this year. In that, if they do head-to-head analysis of 1 versus 2, there's significant improvement from PI-RADS 1 to 2. So sensitivity goes up to 95% and specificity is 75%. Specificity hasn't changed. But the idea is the sensitivity is markedly improved. Another meta-analysis of 2,000 some patients in 14 also showed improved sensitivity. In that study, they had meta-analysis, they found specificity was also improved. So question is it a step in the right direction? I would have to agree with Dr. Armstrong, a humble scientist from University of Cincinnati. But anyway, I think it is because it's an accepted global language. Now, if you learn any language to get fluent, you need to use it more, right? So you need practice and you need just more time for it. And so that's what we don't have. This just came up in 2015, and we're, in the process of developing this. There's still data coming in, and I think everyone's beginning to speak the language in terms of standardization of image acquisition, interpretation, and reporting. And obviously, sensitivity is significantly better than PI-RADS 1. So there's no doubt about that. So the idea was standardization, and I think that is achieved. So in summary, obviously, there's still issues in PI-RADS, and this is already being worked on. This is already that focus group is looking into training and certification to reduce inter-observer variability, add clinical scenarios such as active surveillance, which is not part of PI-RADS at this moment, recommendations for follow-up or biopsy. And again, the dreaded PI-RADS 3 transition zone, which overlaps with BPH, prostate cancer versus BPH. And the role of high B value in ADC will obviously, hopefully help in this region. It needs to be worked into. And I think quantification of diffusion-weighted imaging, because it is just very subjective to say hypo versus hyper-intense on the high B value images. Well, I may call it something moderate, and someone may say it very hyper, and so that you can change from 3 to 4 very easily in that. And I think that's where I think it'll make a big difference. Thank you.
Thank you, dear moderator, for the introduction. Dear colleagues, We'll talk about prostate MRI interpretation in the next 30 minutes. I have nothing to disclose. Prostate cancer MRI stands for multi-parametric MRI of the prostate, which includes T2-weighted imaging, providing information about anatomy, diffusion-weighted imaging, providing information about the biology of the prostate cancer, and vascularity provided by the DCE. So T2-weighted imaging is a cornerstone of imaging in prostate cancer. You can actually appreciate the peripheral zone, which has a higher signal intensity compared to the transition zone, which is located over here. And if you look at the T2-weighted imaging, in this case, there's a large bulky lesion in the left peripheral zone. However, not every low intensity area corresponds to prostate cancer. So also other benign diseases may mimic cancer, like prostatitis, BPH, or even biopsy hematoma. So we have to add other techniques to improve the accuracy of MRI of the prostate. For example, adding diffuse-weighted imaging, which provides information about the biology. Vascularity, a lot of things will enhance after contrast injection. However, not every enhancing nodule of lesion will present prostate cancer. Especially in the transition, it's quite cumbersome to use DCE and detect cancers. For example, in this case, a lot of enhancement is visible in the transition zone. However, most likely this will be BPH if you look at the T2-weighted imaging. So far, a lot of imaging techniques are being used. I didn't mention, for example, MR spectroscopy, and there's a need for standardization. So that, for example, we talk the same language in Italy, Netherlands, and, for example, Japan to acquire the same imaging sequences, and also if we make a report that we make the same conclusion at the end of the day. The first attempt to do this was by the PI-RADS version 1, which was introduced in 2012. We introduced the PI-RADS version 1 based on guidelines how to acquire the images, but also how to interpret the MRI images. We've got a large list of how to interpret, for example, T2, diffusion-weighted imaging, and also perfusion imaging, and you could score points for each sequence. However, there are some limitations with regard to PI-RADS version 1. There's a rapid progress in the field, so there are increasing numbers, for example, in terms of MR sequences. Diffuse-weighted imaging is increasing, for example, in resolution, but also different kind of post-processing techniques are available to look at, for example, diffuse-weighted imaging. Furthermore, because we had a lot of points which could be scored on T2, diffusion, and perfusion, we tried to simplify the interpretation, and also this will most likely simplify the widespread adoption of this technique. And also want to have a single international standard for prostate MRI. So in version 2, which was introduced in 2015, already 2 years ago now, we also looked, if you compare version 1 and version 2, the focus in version 1 was technique, detection of significant cancers, the clinical applications. We also included extraprostatic extension and staging in PI-RADS version 1. In version 2, we had a more globally involvement of the ACR, ESUR, and ADMITEC Foundation, and the focus was lesion detection and characterization, but also including benign diseases compared to the version 1. It also included explicit instruction how to interpret, but also how to measure lesions within the prostate. And for example, images were provided how to look and to score certain lesions on the T2 diffusion and perfusion maps. A lexicon was provided and even an atlas, for example, which location within the prostate a lesion would be assigned to. There's a huge debate what is clinical significant cancer. In the PI-RADS version 2, we focus on Gleason score 7, including a 3+4 with prominent but not predominant Gleason 4 component. That's, I think, already a discussion. A volume of 0.5 cc or extraprostatic extension. And for each sequence, at the end of the day, we have the assessment categories, and each lesion is assigned a PI-RADS assessment category on a 5-point scale. For T2 and diffusion, And for the perfusion, it's either positive or negative. And if you score the entire lesion, it's either 1 to 5. 1 represents very low or low chance of finding a clinical significant cancer. And if you have PI-RADS 4 or 5, the presence of a significant cancer is high or very highly likely to be present in that particular lesion. In PI-RADS version 1, the highest B value was 1,000. We now advise to use at least a B value of 1,400 or even higher, and may be acquired depending on your system, or being calculated if you have the possibility to extrapolate your extrapolation on your diffusion weighted sequence. For example, this is a ADC value, shows impeded diffusion in the transition zone on the right side. The calculated B value shows the high signal intensity, which corresponds to the impeded diffusion area. But if you go to a much higher B value of 2,000 in this case, which is also calculated, this is more likely to catch your eye and look, for example, at the T2 to make your final diagnosis. Version 1, we had also a 5-point scale for DCE. It's quite cumbersome. It was comparable, for example, with the breast MRI interpretation. We tried to simplify that, for example, by it's either positive or negative, and a positive finding was if you have a focal and early enhancement of a lesion which was seen either on T2 or diffusion. I will show an image in one of my next slides. What about MR spectroscopy? In PI-RADS version 1, we included MR spectroscopy, but in version 2, we didn't incorporate it. It's not discussed in the document, and cannot also be incorporated into the overall score. And just to stress that PI-RADS version 2 is only focusing on detecting cancers. So if a patient has a biopsy-proven prostate cancer, or a patient comes in for a local recurrence question, we don't use the PI-RADS version. In PI-RADS version 2, we also have a dominant sequence. So for the peripheral zone, the diffusion with imaging sequence is the dominant sequence. In the transition zone, the T2, because we have a lot of false positive if you only look at the high B value compared to T2 with imaging alone, and DCE plays a minor role. So we have simple algorithms and tables to determine the overall score, the assessment category. Some examples. I won't go into in too much detail, but for T2, we divide the prostate in the peripheral zone and the transition zone. And if you look at, for example, in this case, this is a PI-RADS 1, normal peripheral zone. We don't see any abnormalities. However, if you look closely, there's an abnormality visible here in the transition zone, most likely a large cancer. Again, peripheral zone, some heterogeneous, mild hyperintense lesion with an indistinct margin, on for example, on this side in the right peripheral zone. This triangular-shaped lesion, most likely atrophy or post-biopsy artifact, quite often seen, and this most likely will be some prostatitis. Another example, small homogeneous mass in the right peripheral zone. This most likely corresponds to PI-RADS 4 on T2. And the transition zone, those lesions are very difficult. Look at, for example, this case on the left-hand side, bulky BPH nodules within the transition zone, very difficult to interpret. A lot of false positive findings are found in this area. And also, if we get referrals from outside, a lot of those lesions, like for example, these lesions are overcall for cancer. So if it's a nodule within a nodule, you can be quite sure that this is not a cancer. The same is true, for example, for this lesion. It's still within a BPH nodule. The capsule here is intact, so there's no invasion through the capsule, so most likely this is a benign disease, so BPH nodule. This is an example of a 5 lesion, more than 1.5 cm. This is a large bulky lesion with also invasion into the anterior fibromuscular stroma. Quite often this area is overcalled for cancer, but in this case this is moderate hyperintense and not as dark, for example, as this area, which can correspond to anterior muscular stroma. Diffusion, we don't make any difference between the zones. So if it's either in the peripheral zone, transition zone, or central zone, we will use the same scoring system for diffusion. As an example of no abnormality, we're aware there's always some abnormality at the mid-level or at the base of the prostate. The triangular shape, be careful. These are the electrolytic ducts, which also is a pitfall for assigning that as a cancer. There's a small lesion visible here in the right peripheral zone, less than 1.5 cm on the actual image. It's a PI-RADS4 lesion, and with a high B value, shows a high signal intensity. DCE, as mentioned before, has a minor role in PI-RADS version 2. We only look at focal and early enhancement. And if we look down at, for example, in this case, with a PI-RADS 1 to 5 score, we only look at the peripheral zone or the transition zone. And in the peripheral zone, the diffusion with imaging is the most dominant sequence. So only if you have a score of 3, if it's equivocal, the DCE can alter the final diagnosis and upstage a PI-RADS 3 to a PI-RADS 4 lesion. For the transition zone, the T2 is a dominant sequence. And if you have a score of 3, the diffusion with imaging, only if it's a score of 5, can upstage the lesion within the transition zone T2 from a PI-RADS 3 to a PI-RADS 4 lesion. So I have a case here. PSA of 6, 1 negative thrust biopsy session in the history, very small prostate, but the PSA density is above 0.15. So there's a chance of finding a clinical significant cancer. It's a T2 sagittal and axial. And if you look at it closely, the entire peripheral zone look mildly hyperintense. If you look at the diffusion, there's some impeded diffusion in this area, somewhat high signal intensity, but I'm not really convinced. And if you look at the PI-RADS category for T2, the first question is where is it located? I already gave that away. It's a peripheral zone lesion in this area. So it's most likely at the apex mid part, so in this area, corresponding area, there is the lesion located. So in the peripheral zone, and so the score for T2, in this case, is T2, diffuse mild and hyperintensity. Most likely, if you would see that case the first time, I would think about prostatitis or chronic prostatitis. However, the diffusion, there's somewhat high signal intensity and high B value, but not very, but there's no impeded diffusion. And based on the criteria, you should call this as a category 3. So if you come down to the peripheral zone lesion, diffusion score of 3, only the perfusion may alter the final diagnosis. So if a dynamic contrast Hans MRI was performed, so it's either no early enhancement or yes, focal early enhancement. So look at the enhancement curves. We don't look at the K-trans models anymore, K-trans or KP or washout. The early phase of the contrast uptake, that's the most important part in the PI-RADS evaluation. There is early enhancement, focal enhancement, at the same location as the abnormality seen on the high B value. So most likely we'll call this positive. So there's focal enhancement. So the final score in this case is PI-RADS 4. So what we do with those lesions, PI-RADS 4 or 5, we most likely will do a target biopsy, either in-bore or trust-MRI fusion biopsy. And if you compare in this meta-analysis from Moon 2014, what is the sensitivity and specificity for PI-RADS? PI-RADS version 1, the sensitivity was around 75%, an increase in PI-RADS version 2 using a dominant sequence up to 82%, but still there's some room for improvement. And PI-RADS, of course, is not the holy grail, because if you look at the inter-observer agreement between expert readers, this paper from Andy Rosenkrantz in 2016, it is fair to model the inter-observer agreement. So the idea behind PI-RADS was standardization to get people doing the same sequences, minimal requirements, minimal image quality, but still there's room for improvement, how to interpret and how to perform the analysis of the prostate MRI. So despite the improvements, the precise details of the scoring system reflect a combination of the most relevant published data, supplemented by the experience of the developers of the system. So we need studies to validate the system and to highlight potential continuous limitations. So what are the improvements or suggestions for improvements? Especially the transition zone is quite a difficult area for us as radiologists. And we have to improve our detection rate in that area. We also could think about quantification of ADC maps or ADC values. What about DCE? A lot of discussion is going on if we should use DCE in the detection of prostate cancer. And what about active surveillance, recurrence, and focal therapy? Should we use PI-RADS for those indications? So if we dive into the transition zone, T2 again is dominant sequence, and quite often we call a lesion in TZ a PI-RADS 3 lesion because there's quite some overlap between PPH and prostate cancer. So there's some subjectivity on the hypo and hyperintense signal intensity. So signal abnormalities may vary depending on detecting parameters, and also, for example, using which B values, but also which diffusion weight sequence, and for example, also which vendor. So we have to define explicit criteria for distinguishing the degree of any such signal abnormality in the transition zone. An example, 1400 is advised as the highest B value, acquired or calculated. There is some evidence if you go to a high B value up to, for example, 3000, you have a higher lesion detection, especially in the transition zone, using these kind of high B values. What about the lesion in the transition zone / anterior fibroblastoma? DC has little effect on the assessment of TC, actually no effect. A lot of hypervascularity is seen in the PPH. The AFS is hypovascular, but however, DCE may be helpful to distinguishing lesions in this area. This is an example. This is the anterior fibroblastoma, which is located over here, but there's an asymmetry visible in the right side of the anterior horn, and also the TZ on this side here. And if you look at the high B value, this high signal intensity on high B value and impeded diffusion, but the perfusion really helps you to assess the total extent of the lesion, which is also invading into the anterior fibroblastoma. Quantification of ADC. Several papers have shown that there's a negative correlation between the Gleason grade and the ADC value. So the lower the ADC value, the most likely you will have a more aggressive cancer within this certain region of interest. However, using thresholds is not indicated in the PI-RADS version 2. It also depends on the vendor, sequence dependent, B-value regime. What about the correlation with pathology? There's some interpatient variability and also intrapatient variability using diffusion-based imaging. So we can also use advanced models like IVM, kurtosis imaging. As we heard yesterday, there are some papers which shows clear benefit of using these advanced modeling, but also there are also papers against it, which shows none advantage of using these advanced quantification models. So we don't have the answer yet, but I think we have to head in this direction to have a more precise quantification, but also a more precise definition of what is a significant lesion within the prostate. Biparametric MRI of the prostate, DCE. There's a lot of discussions mentioned before. If you look at the 5 arguments against DCE, it doesn't provide significant diagnostic gain, and therefore we shouldn't use it. Extra costs. We had this morning in the plenary session about the risk of injection of gadolinium, the increase of duration of the examination, make it also less accessible, and also the role of DCE in PI-RADS version 2 is limited to the peripheral zone. So what exactly constitutes early enhancement, and enhancement that's focal and that matches an abnormality on other sequences is unclear. So we have to have more rigorous definitions of what's positive and negative. So DCE is a secondary sequence, so we only upgrade 3 to 4 based on DCE, and which also may create false positives in this case. As mentioned before, this looks more like a prostatitis than a significant cancer. In this case, at biopsy, we found a prostatitis. However, we have to keep in mind we only look at detection, and if we have debates on conferences, most commonly those are the experts. And if you're starting with prostate MRI, this is quite some steep learning curve. But also, if you have information, try to get all the information you have. PI-RADS is only for detection. We have also other indications like recurrences, and contrast-enhanced MRI really helps you to define and to localize the recurrence within the prostate. But what about active surveillance? Most oftenly, the diffusion with imaging will not help you in finding the not significant lesions within the prostate. Of course, it will help you if the Gleason goes from a 6 to a more aggressive one. But basically, the DCE will help you to define and to localize the lesion within the prostate. What about focal therapy? Diffusion with imaging after focal therapy is quite difficult. How to interpret and what's the value of diffusion is still not yet known. Also, artifacts, if you have gas and rectum, hip implants, may also degrade the image quality. So we have to think about smart algorithms. For example, we just do T2 in the fusion, and in some cases in which we have technical difficulties with the diffusion, but also if you have degraded image quality or patient move of rectal gas, you may call the patient back and then inject contrast, which is of course less expensive than giving contrast to each patient. What about active surveillance, currents, and focal therapy? I already mentioned that. I think PI-RADS has to be adjusted for other indications. Recurrence T2 is less important. DC and diffusion is more important. If you have a lesion in a transition zone, after, for example, radiotherapy, DC and diffusion is much more helpful than T2. And with active surveillance, we focus on non-significant disease, as mentioned before. So what are the challenges? What about the size? 50 millimeters is just based on expert opinion. Of course, we have some evidence, but the question is, should we downgrade, for example, to 10 millimeters? In the PI-RADS version 2 assessment, we don't take into account clinical scenarios. So what should we do with the PI-RADS 3 lesion or 4 lesion? Which one should we biopsy? Which one should we do a follow-up? And we also should use our brain at the end of the day, because only a PI-RADS score doesn't give you the final conclusion. You also have to include all clinical data from the patient, like PSA, digital rectal examination. Is there a fast increase in PSA? What about PSA density? PSA kinetics, which will influence the conclusion in your report. So what do I recommend? In PI-RADS 1 and 2 lesion, we don't do a biopsy. In the PI-RADS 2, follow-up depends on the lesion. For example, if it's a BPH, we don't suggest follow-up. Based on recent literature, we found that if you have a PSA density below 0.15 and a PI-RADS 3 lesion, the chance of finding significant cancer on biopsy is very low. So we don't recommend biopsy in those patients. If the PSA density above 0.20, we advise to do MR target biopsy. In 20% of the case, you'll find a significant cancer. And 4 or 5, we advise to do an MR target biopsy, either import or using a truss MR fusion. So in conclusion, there are several challenges. We already have made some good steps in a good direction. However, the interpretation, there's still quite some inter-observer variability in interpreting prostate MRI. Of course, if it would be very easy, we wouldn't be here. But it took us at least 15 years to get here. So if it would be easy, then we already had the solution. Furthermore, we need validation studies. For example, we look at outcome. There's a lot about validation, but also outcome studies are needed. So what is, for example, the implication on outcome, for example, for PI-RADS 4 or 5 lesion for the patient? And we have a lot of expertise, evidence. If you look at studies, there are a limited number of studies done in a multi-center setting, multi-vendor setting, hardly any studies done yet. Prospective trials are not there yet. Of course, single-center studies are there, but we need more evidence with regard to multi-center and multi-vendor studies. And this information will provide improved recommendations in the future. Thank you for your attention.
All right, and I see a pretty packed room, so thank you all for staying to the last talk of this whole day session. Thank you for the moderators also for being here with us all day. I'm going to take a slightly different approach for the prostate compared to everything else you've heard. Rather than going through individual cases and features and things like that, I'm going to focus more on shifting trends in clinical indications. I'm going to focus on some topics that may be controversial. I'm going to try and give you a brief summary of the recent literature with regards to changes in the MR acquisition protocol. And I'll finish by just speaking very briefly about a couple of things that may not be standard clinical care right now, but I do feel that will be there in the near future. I'll prep that by clarifying from the beginning what we talk about when we speak about multiparametric prostate MR in particular. I've witnessed very heated discussions about what the minimum technical requirements are before you call something multiparametric. Rather than participating in those discussions and ending up saying, well, you need to have this and that and the other, I prefer to take a very literal approach, and anything that has more than one sequence apart from the anatomic T1 and T2s, in my book, is a multiparametric sequence. Perhaps what's a little more important than that before you start any discussion is to consider that given that you can have multiple different combinations of these sequences listed here, you really have to look into what was done. And this is particularly important when you're trying to interpret the literature. So you can't just read the numbers about AUCs and sensitivities and specificity. You have to see what sequences were done, how they were done, how they were assessed, and how they were compared. In addition to the phrase multiparametric MR, be on the lookout for related terms that are starting to pop up in the literature more and more often. Biparametric, shortened multiparametric. None of these terms are specifically established in what they mean, and usually they're trying to somehow describe some form of summarized multiparametric, which usually consists of a combination of T2 and diffusion. But in the same spirit, I really recommend that you look in detail as to what everyone is talking about when they talk about multiparametric in their specific data set. So one thing that actually is not a source of any disagreement is the fact that prostate MR use has really grown throughout the world. This is just plotting out how many prostate MR papers have been published over the years. And if you look at this, by the time 2016 finished, you really would have had to read 2 to 3 prostate MR papers per day, including weekends, just to be able to keep up with what was out there. So it becomes increasingly difficult, almost impossible, to really be aware of everyone that's publishing and what everyone is doing. So it's not an easy task to do. And this is not only in research, also in clinical use. This is data from Northwestern in Chicago, but I'm sure many of you will identify with the numbers that are reported here. Almost 500% increase in the prostate MR volume over 2 years between 2013 and 2015. Indications shifting. So this is the first, or the first important point that I'd like to make. Not only the volume of prostate MR is changing, but also the reason why it's being done. And with changing indications for prostate MR come changing information that's required of us as radiologists when we report these MRIs. So in this recent report, the most common indication was abnormal screening, meaning that the patients were coming because of risk factors or high PSA or abnormal physical exam, but they weren't coming after a diagnosis of prostate cancer on biopsy. That was actually the second most common indication, 13% of cases. So that's the first change in practice. About 7% of cases come for evaluation of recurrence. So MR, I want to emphasize here that has a role at the various clinical states of the disease. So recurrent is an important part of what we use prostate MR for. And MR is also done for planning specific treatments. And I was surprised by this number, 3%. For me, it was a little bit low. Maybe in my department, this number would be a little higher. But the point is to say that MR is important not just for surgical planning, but also very important for radiation planning as well. And this is important because it highlights the fact that whereas in the past, patients would come for MR after a biopsy, meaning that almost all of them would have had the biopsy, and the biopsy would have been positive or it would have been negative, but there was still clinical suspicion of cancer by the time they came to the MR. Now MR is starting to be used for triaging patients as to whether they should or shouldn't have biopsy. So this is what I mean when I'm talking about these shifting trends in clinical indication. I don't have to do too much to convince you, and I'm not going to go through all the literature, but extensive documentation is out there proving that multiparametric MR, however you want to define it, is really increasing the cancer detection diagnostic capabilities when you compare that with T1 and T2 weighted images alone. However, its role, it's changing. I just mentioned that in the past, many patients would have diagnosis of prostate cancer proven on biopsy before they came to us, but there's been a series of very recent high-level publications that are changing the approach to prostate MR. And this is just one of the examples very recently from the Lancet this year. These are the results of the PROMISE trial. And basically the take-home points to get from this paper are the fact that when MR was used to decide whether patients should have biopsies or not, about a quarter of patients avoided a prostate biopsy. About 5% fewer clinically insignificant cancers were diagnosed. Remember that in prostate cancer, our aim is not to diagnose all prostate cancers. Most prostate cancers are indolent and patients will die of something else and never even know that they had prostate cancers. So we certainly don't want to diagnose clinically insignificant cancers. We want to diagnose the cancers that are likely to kill the patient. And in this particular study, the rate of clinically significant cancers increased by 18% when taking this approach. So this and several other studies that have looked at the same topic and more or less come to the same conclusions are all over the discussion areas and conferences when you go to urology meetings or radiation oncology meetings. So as radiologists, we really need to know this data very well because the other specialties will look to us to provide recommendations and to explain why we think that the results that are being reported are as they are. So one of the things that also comes up very often when you talk about the value of MR and when you talk about this concept of using MR to triage patients to having biopsies or not is what does a negative MR actually mean? How much can we trust a negative MR? And one important point to highlight, and I'm going to show you some results from multiple studies here, summarized in a meta-analysis published recently, is that, like everything else in life, MR is not 100% accurate. So you really have to be able to emphasize and effectively communicate that to your referring physicians. If you're looking for anything to be 100% or 0%, if the case is to exclude any pathology, then no technique exists that it's able to do that. It's all a question about knowing exactly how good or how bad something is. So this study actually looked at, this meta-analysis looked at 48 studies over 9,000 patients. The median negative predictive value was around 88%. And the interquartile range was between 86 and 92%. I would say the data from my institution and some of the data you hear from other academic institutions as well is around 90% or above 90%. The reason you have some discrepancies is because, you know, when you bulk everything into a meta-analysis, you see that some of the variability is influenced by factors such as the study design, the prevalence of the cancer in the study population, the definition of a positive MR. So whether you consider PI-RADS or LACER3, like indeterminate lesions, as positive or negative, will vary your positive and negative predictive value. And even the definition of clinically significant cancer is not something that's universally agreed upon. Most people would agree that if you have a tumor volume more than 0.5 ml in the prostate, or if you have cancer that's of a Gleason 7 or above, or predominantly Gleason 7 or above, that would constitute clinically significant disease, but alternate criteria for clinically significant disease exist. The point of this slide is to emphasize that probably one of the greatest strengths of prostate MR in general is its very high negative predictive value. So the likelihood of having clinically significant cancer in a plumb normal prostate MRI is very small, but not zero. Now, I'm not going to talk a lot about PI-RADS. We have a whole session about PI-RADS tomorrow at 7 a.m., which I'm sure all of you will be there. I will be there because there will be two excellent speakers and because I'm moderating the session. So the first reason more than the second one, but I will be there for sure. But I did want to say a couple of words here because no talk on prostate MR in 2017 can be complete without a few words on PI-RADS. So I'd like to focus on a very sort of simplistic question. Is it a step in the right direction? And for a simple question, you have a simple answer. Of course it is a step in the right direction. And in fact, even if you disagree with me, I could argue that there's not that many dissimilarities between PI-RADS and alternate approaches. No matter if you use PI-RADS or Likert or anything else, if you have a nodular lesion that's low on T2, that has restricted diffusion, and that has early enhancement, that's going to be bad, no matter how you want to look at it. So it's very similar using PI-RADS or any of the other things. PI-RADS has been shown to have relatively good performance. Again, a recent meta-analysis from a couple of months ago showing pretty decent sensitivity and so-so, but okay specificity. But what I really want to emphasize here is that more than being about accuracy, more than being about improving accuracy with respect to other techniques, PI-RADS is about standardization. So it's about agreeing and making sure that we acquire the images in the same way, and that it doesn't matter if we're acquiring and interpreting images in Hawaii, if we're doing it in the Netherlands, if we're doing it in Italy, in Asia, anywhere, we should really be interpreting it in the same way. So the greatest strength, in my opinion, about PI-RADS is the theory of attempting to standardize prostate MR acquisition and interpretation. Now, this is also true. There's been no studies that show that PI-RADS perform better than any other approach to interpreting prostate MR. So it probably emphasizes it even more. PI-RADS is a lot about standardization. It's definitely the way forward, but it really is not about improving the accuracy of reading prostate MR. Now, the other thing I really like about the PI-RADS document itself is that it acknowledges extensively and actually talks a lot about the limitations of prostate MR in general, and has a section on areas that require more work, which is nice for orientation into what we should be thinking about when we're generating new research in prostate MR. So I want to spend a few minutes on this section here, highlighting what are the well-understood limitations of prostate MR. I already told you, in my opinion, greatest strength, very high negative predictive value. Now, how about the positive predictive value? Now, the positive predictive value is not as good when you have a positive MRI that can indicate, and usually indicates, clinically significant cancer, but sometimes it can be clinically insignificant cancer, and sometimes it can be no cancer at all, i.e. inflammation or prostatitis. Now, I'm sure by now many of you will have had cases like this. This is one of ours from a few months ago. T2 weighted image showing a lesion in the right posterolateral midgland peripheral zone here that doesn't look very healthy at all. We had the contrast enhanced image here that actually raised suspicion for rectal involvement. You had like a little tongue of something there going into the rectal wall. So we went for the diagnosis PI-RADS 5, consistent with extracapsular extension, probable rectal involvement. The patient went for surgery, and the surgeon calls us back and says, listen, there's no tumor. And we're like, what? Are you sure you took the right patient to the OR? Did you get it wrong? There's no tumor. And I said, well, we can't believe it until we see the pathology map. We're going to need to have definite proof that this is no tumor. And he said, okay, I'll speak to the pathologist. Here it is. Tiny little bit of Gleason 6 tumor on the right side, tiny little bit of Gleason 7 tumor on the contralateral side, where we didn't see that much on the MR. The final diagnosis here was granulomatous prostatitis. an entity that's being diagnosed more and more frequently. It's associated with BCG, usually BCG treatment for prior bladder cancer, so maybe something to try and elicit from the history, but ultimately a great pitfall because there is no way on earth that you can look back at any case of granulomatous prostatitis that I have seen and confidently say this is not going to be cancer. And in fact, a couple of papers from February this year published in Abdominal Radiology basically come to the same conclusion. These are both very nice case series trying to document the features of granulomatous prostatitis and trying to come up with differences with cancer. And the bottom line is you definitely cannot do that. Another prostate MR limitation that I think warrants a few words about, this whole concept about sparse tumors on pathology. When we say sparse tumors, I'm not talking about imaging. This is on pathology. Now, we know that biologically prostate cancer is heterogeneous and that tumors can be either composed of densely packed malignant glands or there can be few malignant glands scattered around normal tissue. And this is basically the definition of sparse cancers. So sparse cancers are very difficult to see. This is from the first paper on this topic published in 2008. We go back from the pathology map to the imaging. In the pathology map, the area outlined in red was actually tumor, and the area outlined in blue is normal prostate. When you look at the corresponding T2 weighted image and the corresponding ADC map, you really cannot see anything. So when you see a pathology report talking about sparse tumors, you know that there will be problems looking at them on the MRI or identifying them on the MRI. And this is one of the reasons that explains those few cases where the negative predictive value of MR is not perfect, because an MR can be completely negative and you have tumor, and they can be sparse tumors that are just not identified with any MR sequence that we throw at them. So where do we need to improve when it comes to prostate MR? I would say one of the greatest things is improve the reproducibility. I said PI-RADS is about standardization, standardizing acquisition, and standardizing the interpretation. However, it's quite clear that there is quite a way to go when it comes to getting the inter-reader agreement to be there. Some of it is easy to explain. Training plays a big role. If you take inexperienced readers versus experienced readers, there's going to be poor agreement. But Andy Rosenkrantz from NYU published the two papers. This one was in 2013, and this one in 2016. Now there's no experience versus inexperienced. Now we have 6 very experienced prostate radiologists, and even then, the percentage agreement for PI-RADS lesions score 4 or above was only about 60% for PZ, peripheral zone lesions, and only about 50% for lesions in the transition zone. So when the experts are agreeing only half of the cases, then you know that there is room for improvement for sure. Some of the features didn't perform that bad, but some of them actually had very low reproducibility, like ECE only had a kappa of 0.29, and this very defined lesion on the transition zone, moderately T2 hypointensity in the TC, only had a kappa value of 0.14. So a lot of these features will need revamping, and hopefully that will be something to do about improving reproducibility. Another topic that comes up all the time is traditionally the multiparametric protocols have been consisting of T2, diffusion, and DCE. And recently, there is a slur of literature showing that perhaps having just 2 of the 3, at least for qualitatively evaluation, is enough. So I have just a series of papers here, all from the last year. So 3 papers here and another 2 papers here, all coming to the same conclusion. The DCE MRI can have additional value to the T2 weighted images, but it doesn't have additional value when it comes to T2 plus diffusion, right? It's shown when applying PI-RADS, when not applying PI-RADS. As you all know, in the most recent PI-RADS version 2, the role of diffusion of DCE is actually minimized, It has zero role in the assessment of transition zone lesions, and the assessment of peripheral zone lesions, it only has a role in lesions that are categorized as having a PI-RADS score of 3 in diffusion. So the literature so far seems to support that statement. I wouldn't want to imply or conclude that that means that DCE is being written off completely. It may play a different role when it comes to trying to quantify the biology of these tumors. So that we don't know at this point. Now, the other question that comes up all the time is spectroscopy. Is it dead? Is it not dead? Spectroscopy was mentioned in the original version of PI-RADS in 2012. In the updated PI-RADS v2, there's little or no mention of spectroscopy. And I just said most multiparametric protocols consist of T2, diffusion, and DCE. No one is adding spectroscopy. Well, I don't want to dwell too much into this, but I do want to say that maybe it's dead, but maybe not. Hyperpolarized carbon-13 MR is something that's being done in the research realm. There are human data in this topic already. Again, I don't want to dwell into this too much because it will be presented here on Wednesday at 8:15 in the morning. But just to show you what it can do, T2 weighted image, ADC map, an obvious tumor in the left midgland peripheral zone. You inject the hyperpolarized pyruvate and then image sequentially every 4 or 5 seconds. And this is the sort of thing you get. You get carbon-13 MR spectra. If you image early after injection, this is about 19 seconds after, you get a very high pyruvate peak and very small lactate peak. If you image later on, this is about a minute after the injection, the pyruvate peak is smaller and the lactate peak is higher. So you're basically imaging the anaerobic conversion from pyruvate to lactate, and you can actually produce a map of the rate of this conversion, and you can create overlay images like this that show what the event is going on. Again, this is a spectroscopy-based technique. It's not really in the clinical realm now, or is not anywhere close to being, but maybe, just maybe, I want to throw that out there to have it in the back of your mind and not consider spectroscopy to be completely dead yet. So, a few words on optimizing prostate MR acquisitions and protocols. This is hot off the press, March 2017. It's about getting shorter duration diffusion weighted scans. It compares the standard of care 3-scan trace acquisition versus this new diagonal acquisition. On the standard of care acquisitions, what we usually do in diffusion is the gradients are switched on in 3 perpendicular directions sequentially, one after the other. And basically, the images that we're getting represent the geometric mean of all the 3 signals. This sequential application of the gradients has some shortcomings, essentially dwelling from the fact that it doesn't employ the full gradient strength on all the axes, and therefore the images are acquired with a relatively high TE, and the acquisition time is relatively high. This proposed diagonal acquisition has the benefit of all 3 gradients being turned on simultaneously to maximal strength, and that the diffusion is measured in only one direction, that is essentially the net direction of the 3 gradients being applied. And this results in lower TE images and lower acquisition times. So the group at Mount Sinai, led by my friend Bashir Taouli, tested this in a few patients. Both sequences were acquired with 3 B values, B50, B1000, and B1600. The scan times were reduced by about 30%, and at the same time, there was no difference in or any effect on the image quality. There was no change in artifacts, no effect on subjective tumor detection or conspicuity. And in fact, the estimated SNR was higher for the diagonal technique, for the standard technique as expected compared to the diagonal technique. So this is one way of optimizing the diffusion sequence, being able to scan in a shortened amount of time without really compromising the qualitative assessment. This is another optimization approach described a couple of months ago as well, acquiring accelerated simultaneous multi-slice diffusion. This is from the group in Tübingen who used phantoms, volunteers, and patients, and were able to come up with this simultaneous multi-slice single-shot echoplanar imaging sequence and compared it to the standard acquisition, which consists of a single-shot epi sequence. They halved the scan time to about 3 minutes from 6, and they also saw no significant difference in image quality or the ADC measurements. So these are just a couple of relatively newly described methods, simple methods to optimize. Both of these primarily result in a significant reduction in the scan time, which is something we're all looking for and looking into in our standard of care MRIs these days, without affecting quality, it seems, in a lot of ways. The last topic I want to talk to you about is not something that is really done as standard of care everywhere, but it's something that I have increasingly heard of different departments doing, which is quantifying the diffusion. There are some departments that are now including in their prostate MR reports an ADC value for a given lesion or an ADC value for the normal prostate, etc. So I thought this might be the right setting to do a short mini review on this whole issue of quantifying diffusion. I don't need to tell you a lot about the ADC. It's been talked about in many of the lectures today. It's essentially the simplest possible description of the diffusion signal decay, and it assumes a Gaussian behavior where water molecules are treated as if they're moving freely, and the linear decay of the diffusion signal decreases as the b-value increases. That's what it's called, the mono-exponential model, or represented graphically like this. The slope of that decay is what represents the ADC. But some of the questions that arise when you think about the quantification of diffusion, and you say, well, if we're going to quantify it, should we do it in the best possible way? And many studies have recognized that in human tissues, diffusion is obstructed by microstructural barriers, such as cellular membranes, and therefore this mono-exponential model may not be appropriate for trying to explain the diffusion signal decay. Maybe more complex non-Gaussian models should be more appropriate. Now, some of those are cortosis, IVIM, diffusion tensor imaging. I don't want to go into them in too much detail, only to say that there are alternate ways of explaining diffusion decay. They have some slight variations when it comes to how the images are acquired. For example, for cortosis, you require high b-value images compared to the standard diffusion. The b-values are in the range of 2 to 3,000. And essentially, they're trying to quantify slightly different things. Cortosis is quantifying the deviation of diffusion from the Gaussian pattern, and it's essentially considering the signal decay as consisting of two different curves, one of them talking about the diffusion decay and the other one talking about the non-Gaussian deviation from the actual decay. So it's basically looking at something slightly different. Now, there are a few studies showing improvements compared to the ADC, and these are these 3 studies here, the 3 most recent studies. The problem is that there are a few others that show no benefit. Now, again, IVIM looks at the data in a slightly different way. In IVIM, we're focusing more on what's happening at very low b-values and essentially determining that the signal decays in a bi-exponential way, and that the way the signal decays at low b-values is representative of the perfusion component of the tumor microenvironment rather than its diffusional behavior. So you generate a sequence of parameters that are different from the ADC. And essentially, similar to cortosis, there's discrepant results in the literature. Some find added values from ADC and others don't. Now, and there is a problem with repeatability. Now, I feel that there's been a couple of recent papers that shed some light on this issue of whether these techniques are going to be able to add value to the ADC or not. This one was published just a week ago or so. It's the largest study to date looking at cortosis. It's a large patient study, about 300 of them. It showed that both ADC and the diffusion cortosis coefficient were significantly different between tumors and benign tissue and between tumors of different Gleason scores. However, ADC and the diffusion cortosis were highly correlated, and there was really no improvement over the standard ADC for tumor detection or Gleason score assessment. Now, whether this truly reflects the biology, I doubt so. But what this is telling us is that at least the technology that we have available to date is not being able to capture these different in biology. So the ADC is probably going to perform as well as some of these fancier factors or metrics that are being calculated assuming other kurtosis models. Similar reports for other models, including IVIM. This is another very recent study, 21 b-values acquired, calculated 8 different parameters from IVIM and kurtosis using mono-exponential, bi-exponential, stretched exponential, and diffusion kurtosis fits, and basically came to the same conclusion. No parameter clearly outperforming the ADC for any sort of differentiation between tumor and normal tissues or tumors of different Gleason scores. So the take-home messages of the topics I presented to you today: be aware of the shifting trends and the indications for prostate MR and the information that MR provides in each clinical scenario. It's a different kind of information and it's a different kind of report if you're evaluating a patient who's never had a biopsy, they want to know what to target, versus someone who has already got a prostate cancer diagnosis, they want to plan treatment, versus someone who had treatment and is now being evaluated for recurrence, for example. Understand, and perhaps more importantly, make sure your referring clinicians understand what the strengths and limitations of prostate MRI are. Take advantage of some of these new techniques that are being reported in the literature to optimize MRI and in particular diffusion acquisition. And as I said, it's not quite here yet, but it's only a matter of time. The referring clinicians are desperately looking to us to quantify or somehow come up with a metric that's going to be able to tell them what we're seeing or what we're reporting qualitatively. Ready for prime time? Maybe not. But if anything is as close as it can be, it's going to be the ADC for now. Some of the fancier metrics, the data is just not there to support that it's worth going through the trouble of acquiring them and representing them. And with that, I thank you for your attention.
So thank you very much for inviting me. So yes, the placenta is my favourite organ. So first of all, health warning, because I'm a physicist, as was said, and that's probably why the placenta is my favourite organ, because it's just a great piece of engineering. So this talk, I'm going to talk about, first of all, why the placenta matters. I'm going to talk about normal placental structure and development, because quite a lot of people don't realise how the placenta functions. And then I'm going to talk about the sort of data that's available from MRI. I'm going to talk about structural information, and that's where I'm going to be outside my comfort zone a little bit, talking about clinical applications, and then the qualitative and quantitative information that's relevant, and the functional information that's relevant for looking at sort of placental development. And then eventually I'll talk sort of slightly about the pitfalls, and I have no interest to declare. So the normal fetus grows to about 3 kilograms, and most of that weight gain is in the last trimester. This is fetal growth curves. And obviously the placenta is responsible for the provision of nutrients for this fetal growth, the oxygen for the fetal growth. It's also responsible for removal of waste products, including heat, and any heat we put in with our RF heating. It's responsible for reduction of hormones, and it's responsible for immunosuppression of the mother. At term, it's about 20 centimetres in diameter. It's about 3 centimetres when it's delivered in thickness, but 8 centimetres in utero. It's about 500 grams when it's delivered, but probably about 1 kilogram in utero. That's important because it means that when you're looking in utero and when you're comparing it to ex utero, if you're trying to do remote perfused placental models, all this sort of thing, the placenta in utero is very different. It's very much a functional organ. It's the blood flow that determines the structure. Maternal blood flow is about 80% of the uterine blood flow goes to placenta. It's about 50 mils a minute at 10 weeks. It goes up to 600 mils a minute at 38 weeks. This is the sort of growth structure of the placenta, about the size of a dinner plate in theory. This is the fetal side, so the umbilical cord, the coronic plate. This is the maternal side with a basal plate across the surface. And it's sort of separated into these cotyledons, which are separated by septa, and these contain 2 or more villi. I'm going to talk about the villi in a minute. The maternal blood, we've just heard, comes in at about 90% oxygenated. It goes through the umbilical artery at about 80% oxygenated. It comes back through the umbilical vein at 55% oxygenated, and ends up going out of the uterine vein at about 69% oxygenated. So obviously, as we just learned, there's big differences between the maternal and fetal oxygenation, and also, of course, differences in the affinity of the fetal hemoglobin for oxygen compared to the maternal hemoglobin, which is why the oxygen transports across the placenta to the fetus. This is how the placenta works. So on this side, we've got the fetal side, the umbilical vessels, and on this side, we've got the maternal side, the maternal uterine wall, or the myometrium. So the blood comes in the umbilical cord from the fetus and goes across the chorionic plate through these little vessels to the stem villi. And here we've got these villi, which are like trees, or I like to think of it as a sort of inverted lung, where the blood's flowing through these vessels in these trees, and then it's bathed in maternal blood. So there's no transfer of maternal blood to the fetus directly. The only contact is through the walls of the villi. So the fetal blood's restricted to these villi. The maternal blood comes in through what's called spiral arteries, and then it's transferred into this intervillar space, which is like a lake of blood. And it goes through the villar space and it transfers oxygen to the, it percolates through the intervillar space. It transfers oxygen from the blood of the mother through the villus tree to the fetal blood, which is restrained within the fetal capillaries, and it gets deoxygenated and then exits through the maternal veins. It's worth noting that the septa in the placenta that divide it into sort of segments, and that some of the villi are actually anchored onto the maternal wall. The spiral arteries are key to the placenta. So the spiral arteries deliver the maternal blood into the intervillar space. And my belief really is what we're looking at most of the time in the placenta is maternal blood. These spiral arteries at implantation are, as I said, spirals. This is related to their function in menstruation. But as pregnancy develops, during the first trimester, they get eroded, I suppose, and broken down into much more low-resistance vessels. So the blood flow through the placenta, into the placenta from the maternal vessels is very much unrestricted. And by the second trimester, they're opened into sort of funnels, really, just pumping blood straight into the placenta. And this restriction is what you see when you're looking at Doppler ultrasound of the uterine arteries. It's the resistance here, the breakdown of these vessels here, that determines whether you're getting the resistance apparent in the waveforms in the Doppler. So the spiral arteries are transformed into inelastic, dilated, low-resistance vessels during pregnancy. On the fetal side, you've got these trees containing the villi, which contain the maternal and fetal blood. And the important thing about these villi is they do get damaged during pregnancy, and you get fibrinoid deposits. And I think some of this is what we see in the fetal imaging. So placental imaging is relevant clinically in placenta previa, placenta accretia, preeclampsia and fetal growth restriction. And we've heard a little bit about fetal growth restriction already. Could you put the clock on? Put the clock on so I know what time it is. Oh, don't worry, it's okay, thanks. So talking first of all about the morphology of the placenta. So this is a normal placenta. It's got a fairly uniform wall around it. You can see the myometrium here coming right round behind the placenta. It's normal for the myometrium to have sort of hyper-intense and hyper-intense spots in it corresponding to vessels. And the wall between the myometrium and the placenta is fairly uniform. So this is data from Daniel Prayer at Vienna showing the progression of the placenta through gestational age. So at the beginning of the second trimester, it's a fairly uniform organ like this on the T2 weighted scans. And as you progress through pregnancy, you get increasingly these heterogeneities through the placenta, and it looks sort of increasingly lobular. Now, I guess it remains to be proven whether this is structural or functional, though I think this is probably actually functional, as we'll see later, related to the blood oxygenation. So this is other work from Daniela Prayer, showing you can see gross abnormalities in the placenta. In this case, an infarction. So this is a T1 weighted scan. There's a sort of hyperintensity there. A flare scan, T2 weighted scan, again a bit hyperintense. When you get to DWI, we're going to come back to DWI later, you get particularly hyperintense regions in the DWI. So this indicates less movement of the water in this region and almost certainly less blood flow in this region. So clinically, DWI is very useful for just identifying regions of low blood flow in the placenta. I'm going to go on to talk about later how you can use this quantitatively, but qualitatively it shows up low areas of blood flow. So clinically, it can be used to identify placenta previa. These are two examples showing the placenta lying straight across the cervix. It's very easily to identify that on MRI, so cervix here in C, at the placenta in P. Adhesions, this is data, this is from a paper by Elizabeth Whitby at Sheffield. So placental adhesions are often identified by dark bands on the placenta on FSE scans, and dark regions will look bright on balanced FFE scans, FISP. You get bulging of the uterine wall, and you get thinning of the myometrium. So again, here is these bright spots in the myometrium, which are quite normal, but you get these thinner regions where you've got adhesions. Here's more images of placenta ecretia. So here's dark bands again on the placenta on the haste, dark bands here. And here's bright spots on the BTFE, which are appearing dark on the T2 weighted scans and bright on the BTFE. These are often called vessels on MRI, and I think they're called lacuna on ultrasound. So I think the sort of structural correlates of these are not clear to me, at least. But again, here are regions that have been called vessels within the placenta on high-res FSC. This is the same regions on the BTFE. They're definitely blood as showing up bright on the BTFE. Here's another case showing again in breakdown of the uterine wall, and here. So here's the normal myometrium coming round, and here's breakdown of the uterine wall. So now going more towards function of the placenta. So first of all, just looking at placental growth. So these are data from some time ago from us looking at the volume of the placenta over gestational age with the controls in the open circles and the fetal growth restricted fetuses in dark circles. And you can see that the fetal growth restricted fetuses had reduced placental volume from very early gestation. So even from 25 weeks, these fetal growth restricted babies had smaller placentas. The fetal growth restriction in this case were defined by babies who were eventually at the low IBR centile. So they were small, not just small for gestational age, they were actually growth restricted. And this is similar data from Iris Dewing at King's College London. This is where we've got birth weight centile, again corrected birth weight, and log volume of the placenta. And again, the low birth weight babies have got smaller placental volumes. This is work from Mary Rutherford, looking at something that's kind of obvious when you look at placentas, but they measured it and proved that the babies that have small placentas actually have thicker placentas. So this placenta is much thicker in the fetal growth restricted placenta, whereas the control placentas are thinner. And they showed this looking at the placental thickness to volume ratio. And again, the triangles here are IUGR and the circles are normal placentas. So the volume is more squashed up and less in contact really with the uterine wall in the fetal growth restricted placentas. As an example of the use of this, we looked at this in mothers who smoked. The baby's eventual birth weight, well, the baby's volume, the fetus's volumes were lower at 25 weeks and 36 weeks in the smokers in black compared to the non-smokers in grey. But similarly, the placental volumes were reduced at 25 weeks and at 36 weeks in the smoking. So now, moving on to looking at the tissue properties. So there are many MR parameters that relate to tissue properties, T1, T2, magnetisation, transfer. I'm going to show T1 and T2 data. In the past, we've got MT data at 0.5 Tesla, which is very low field. And I'm quite sure now that MT is probably the way to go. Well, I'm quite sure that MT is the way to go, to particularly look at fibrin deposits in damaged placentas. But looking at T1 and T2, where you've got effects of oxygen and macromolecules binding, with gestational age, T1 and T2 both decrease, and that's normal. And at late gestations, looking at babies with IUGR or preeclampsia, there are reduced T1 and T2 in these groups. I just add here that we measured T2 in this data with spin echo EPI, which I think is actually quite a simple way to measure T2 and can overcome some of the artifacts you can get with other methods. That data was from 0.5T, which is low sensitivity really, and has low sensitivity to variations in relaxation times. This is data from 1.5T, also looking at variation in T1 and T2 with gestational age, and again showing a decrease in T2, slightly less significant decrease in T1. And this is from Manchester, and they also related the relaxation times to histology measures of fibrin to villus volume density ratios, and showed that T2 increased with that ratio. So this is important because these parameters are actually potential to give us information about the histology, or indirect information about histology in the placenta. So now moving on to blood flow. So I described how the blood flows through the intervillous spaces, and I think that most of the blood, well, I'm sure that most of the blood we're seeing in the placenta is maternal blood. So that's determined by the maternal delivery to the placenta, the fetal placental flow, so the blood that's coming through the umbilical cords and through these intervillous spaces, but also the percolation of the maternal blood through the intervillous spaces. So it's not enough for the blood to arrive in the placenta, it actually has to distribute through the intervillous spaces and reach all the villus trees to exchange adequately the oxygen to the fetal vessels. So we're really interested in not just what's delivered, but how it's distributed and how it moves through this space. So there's lots of ways of measuring blood flow with MRI. Contrast agents, arterial spin labeling, and gradient sensitization or diffusion-based methods. Excuse me, sorry, I've got something. So just starting with conventional contrast agents. So they've definitely been used in the past, either sort of accidentally, really, when the mother was having an MR scan, say, of the brain, and the gadolinium was then found in the placenta subsequently, or was observed in the placenta subsequently. This is actually data from mice. I think now it's absolutely clear it's not possible to give gadolinium in pregnancy deliberately, because we know it crosses into the amniotic fluid. We know that now that gadolinium accumulates in adult brains, and, well, I wouldn't give it. Ultrasound microbubbles are obviously used in ultrasound, and I think probably will give contrast in MRI. I've tried them at low field and couldn't see much, but I think it's worth reinvestigating those. However, we've already seen work today using oxygen as a type of contrast agent in MRI. So this is very similar to the work you presented, Ellen, and you presented in the heart. This is data from Anne Sorensen in Denmark, and again looking at the effect of maternal hyperoxia on the bulb contrast in the placenta. And this immediately identifies that the contrast you can see in the placenta at late gestation on T2 weighted scans, in fact this is bold, this is T2 star weighted scan, is due to oxygenation, because once you give oxygen, this becomes much more homogeneous. So first of all, this tells us what's going on here, and this tells us how well the oxygen is distributing through the placenta. So this heterogeneity is now giving us information we weren't quite sure what it meant in the past. There's been similar work in the past. This is work from Manchester again, looking at this with T1 and looking at the change in oxygen on T1 change in T1 on oxygen inspiration with gestational age, and showing that the change decreased with gestational age. So these methods will be important not only for understanding how the placenta is oxygenated, but also I think by using methods similar to the methods that we discussed from the brain earlier, for looking at fetal oxygen consumption by looking at blood flow to and from the placenta and the uterine cavity. So now moving to ASL. So these are images explaining how ASL can be used in the placenta, in the uterus. So this is data acquired at different time points after an inversion pulse. But the inversion pulse isn't across the, just across the imaging slice. It's either across the whole imaging slice and the whole placenta, or just across the imaging slice. These are very low field scans from some time ago, because this is old data. But you can see at this point here, the blood flow in the uterine arteries is white, whereas the blood flow in the uterine arteries in here is dark, because the blood flow has flown into uterine arteries. If you look at the placenta here at a later time, you can see it's brighter compared to the unsaturated case. And you can use this to measure perfusion. Iris Dewing at KCL has done this, looking at small for gestational ages and appropriate for gestational ages placentas. She looked in 3 regions. She looked at the basal plate, which is the region between the placenta and the myometrium. She looked at the centre of the placenta, and she looked at the whole placenta. And she showed in each case that the FAIR signal was reduced in small for gestational age babies compared to the appropriate for gestational age babies, so reduced blood flow. Now, diffusion weighted imaging, you'll be familiar with using it for DTI, it was shown earlier. You're probably also now familiar with using it in cancer for studying tumour blood flow. So we know that diffusion weighted imaging is sensitive to diffusion of water. We know it can be used in intravoxal incoherent motion to look at flow in the capillaries. It turns out that it's also sensitive to anything that has turbulent or complex flow. And that's what's going on in the placenta. So we haven't got flow like this, and we haven't got movement of water restricted within axons. We've got flow not dissimilar to this. And this gives us the chance to measure something related to blood movement in the placenta, which is, of course, what we're interested in. So what you get when you measure the signal in the placenta for different B values, for increasing your B value, is a sort of bi-exponential decay. So this is log signal against B value, which is what you'd normally measure with diffusion. And the fast-moving blood moving through the villi gives you this fast component here, and then the slow-moving water may be trapped in the villi themselves, or very slowly moving through the villus spaces gives you this slow compartment here. Now, I should say, it always looks pretty bi-exponential, so it does imply there are 2 compartments, really. Not 2 compartments, but a fairly clear separation between fast and slow compartments. There's not a kind of general move between multiple compartments here. So if we look at this in the placenta, these are maps. You can measure many things off this curve. You can measure the rate of decay here. So in this case, this is the diffusion coefficient. We call this 1D star. You can look at the relative amplitude of these 2 components. And we can call this fraction here F, the moving blood fraction. And that's what we normally map, because that's got the highest sensitivity. Traditionally, this IVIM technique was meant to have very low sensitivity, but it's really good in the placenta because we've got a really large moving blood volume. So this is a control infant, fetus, and a diabetic fetus at about 24 weeks and 38 weeks. And you can see the increased regions which have got low perfusion later on in gestation. And again, these regions are analysed usually by looking at the basal plate, that region that lies very clearly between the placenta and the myometrium, and also the coronic plate, the fetal side, and the whole placenta itself. And for this sort of data, we usually do some kind of histogram analysis to separate out high and low perfusing fractions. So again, IRIS at KCL looked at this, and again, looking at appropriate for gestational age and small gestational ages in those 3 regions, and again found it to be lower in the small for gestational age fetuses. Now, IRIS compared IVIM and ASL as 2 methods for looking at the placenta, and in her experiments, ASL came out as more sensitive. I think they had to be careful completely concluding that at this point, because the 2 techniques need to be optimized very carefully in the same way. But they give slightly different information, but very complementary, well, actually quite similar information in some ways. So it needs to be decided which is the best method for looking at blood flow. So finally, I just want to mention some practicalities, and these have been talked about largely already. So first of all, in terms of safety, I'm not going to talk about it much, but yes, you need to think about RF heating, vibration, I think, more than acoustic noise, so direct mechanical coupling of the bed to the mother's abdomen, and cable compression. And yes, we don't go above 2 watts per kilogram. And of course, motion is the main technical problem. We use fast sequences, HASTE, FISP, and EPI, so all the quantitative data is with EPI. And of course, the mother and fetus are moving separately. For the quantitative data, actually, for placenta, movement's not quite such a problem because you're not worrying quite so much about a moving target that you are with a fetus. So usually for many of these data sets, some control over maternal respiration, but then we usually oversample so we can look for outliers and remove them some way automatically from the data sets. Okay, so in conclusion, the placenta is an ideal organ to study with MRI. You need motion-insensitive sequences. There are many ways to monitor placental structure, growth, microstructure, and blood flow, and it's got applications clinically and in research studies. And I'd like to particularly thank these people who collected the data, and Carolyn here, and our volunteers, and Daniel Prayer at Vienna. Thanks.
Good morning, everybody. So, how many people have we managed to get here? Ooh, about 20. Well, congratulations. Thursday morning, 7 o'clock. You're heroes. How many people were here over the weekend courses? Anyone? Wow. Gold medals all round, I think. Anyway. So here we go. You're nearly at the end. So added value of MRI in patients with DSDs. So DSDs are disorders of sex development. I have no conflicts of interest to declare. So what is a DSD? I think that we as imagers, many people actually don't understand that the term DSD has now replaced the term intersex. And this has happened because a lot of the intersex terms are quite pejorative. They have terms which really make you sound like, you know, a half person, you're between one sex and another, and certainly patient groups really did not like the terminology. So in 2006, Professor Hughes led a consensus group, and a paper was published in which all the definitions of intersex were reclassified, and it's now called DSD, disorders of sex development, defined as a congenital condition in which the development of chromosomal, do you want to start the timer? You start it, okay. So it's a congenital condition in which development of chromosomal gonadal or anatomical sex is atypical. So this is how the terminology has been revised. So we have the previous definitions with intersex, male pseudo-hermaphrodism. You can imagine that if you were a male pseudo-hermaphrodite, you'd find that a pretty unpleasant name. And they've now been called sort of non-judgmental names. So we have 46XY DSDs, 46XX DSDs, and so on. So examples of these. So examples of the 46XX DSDs are disorders of gonadal development, including the ovotesticular disease, DSDs, streak ovaries, disorders where you have androgen excess, and then the other group of disorders, which includes cloacal anomalies and the majority of the Müllerian anomalies, which I'm mainly going to be talking about today. So 46XY DSDs are things like Swires syndrome, partial and complete androgen sensitivity syndrome, and also severe hypospadias and atypical epispadias are included in that group. So how are DSDs assessed? Well, imaging actually forms a tiny bit of the assessment of patients with DSDs. The majority of the assessment is clinical, hormonal, genetic. A lot of psychological assessment, which is very important, and metabolic. But those few cases in which we do use imaging are really very important, and imaging is critical. So today I want to talk about what is the added value of MRI for DSDs. Well, we have diagnosis and anatomy, preoperative assessment, post-operative follow-up, and what is becoming a very interesting topic is the follow-up of dysgenetic gonads, retained dysgenetic gonads, and then in very complex cases where MRI is really superb. I'm not really going to talk about diagnosis and anatomy because I addressed that in my lecture last year. And if anyone is interested in that, those lectures are now available to anybody, even if you weren't at the courses, and you can get at those online. I'm mainly going to talk about the other aspects of added value. So, pre-surgical planning. Well, what do you need to know if you're going to operate on one of these patients? You need to know very clearly the anatomy. You need to know level of obstruction. You need to know a lot about the vagina. You need to know about the ovaries, other associated anomalies. And what would be nice is to know something about the function of the residual uteri, if there are any. So, anatomy. There are some things that are absolutely critical that your surgeon will want to know. This, for example, is a patient who's got a unicornuate uterus. So we have a relatively normal right uterine horn, which is, this is a terrible, it's floating all over the place. It's like I have no control over this pointer, but anyway, so we have a right-sided uterus, and you can see that uterus is unobstructed, and there's a normal cervix. In contrast, we have a functioning but obstructed left cornua. And what the surgeon wants to know is how much of it is attached, and in particular if it's involving the cervix. If you have a tiny little attachment, this is a sort of half-hour operation where they literally just snip it off. A very long attachment means that there's a much longer operation and the morbidity is higher. Your chances of damaging the residual uterus is much higher. And if the cervix is involved, that makes it a very difficult operation because you're trying to preserve the integrity of the cervix for potential pregnancy at a later date. Another example where anatomy is very important is in septate uteri. As you probably all know, they're associated with miscarriage, and the current treatment is resection of the septum. However, the septum can be fibrous or muscular. And if they go in and resect a very muscular septum, they get a lot of bleeding and adhesions. And so they want to avoid doing this. And MR is actually very good at predicting what is fibrous and what is muscular. So in this example, I have a septate uterus, and you can see that this is close to the fundus, and at the fundus we have a muscular septum. But also right down as we extend towards the cervix, the septum is still muscular, and this patient really shouldn't be touched. Another case of a muscular septum, but a less extensive one, but all of this is muscular. There's no fibrous component to it. Whereas in contrast, in this patient, almost the entire septum is low signal and clearly fibrous. And in this patient, they can resect right up almost to the fundus of the uterus. So, you've got to identify the level of obstruction, which, as you probably know, can occur at virtually any level. And the rule of thumb is if there's a high obstruction, you get hematocolpos and hematometria. If you have a low obstruction, you get vaginal distension. The caveat to that is that your patient may be hormonally suppressed, and if they are suppressed, that can be very misleading, and you don't develop these the typical retained blood that you're expecting. So this is a patient with a very high vaginal obstruction, and you can see that the uterus, the corpus uteri, is obstructed. There's the level of the internal os, and the entire cervix and the upper vagina is obstructed. With high vaginal obstructions, it can be quite hard to define where the cervix ends and the vagina begins, because as a result of chronic distension, the vagina become quite thickened and fibrous, and they find that surgically. So this is an example of a very low obstruction where the entire vagina has distended up, and we have really quite a normal looking corpus and cervix uteri with relatively normal internal os. Patient with cervical agenesis. Now, rule of thumb says that this patient should have a distended uterine body, but they don't. And the reason they don't is because they have been hormonally suppressed for a long time, 6 months to a year. So pre-surgical planning, assessment of the vagina. Now, how the surgeon repairs or recreates or operates on the vagina depends very much on the length of the vagina and where it is and the size of the gap and so on. They have a number of surgical options, including direct anastomosis if you've got a good portion of vagina. If there's very little vagina, they do a bowel interposition, but those are becoming unpopular because you can sometimes get terrible colitis of the vagina, and the girls eventually opt to actually have the vagina resected. And a more recent development is they are beginning to do buccal mucosal transfers. So they create a tract and then they take mucosa out of the mouth and just do a plastic operation and coat the neovagina. And preliminary evidence shows that these are going to be much more successful than bowel interpositions. So you need to measure the vagina. You have to determine if a stenosis is present. You need to define the definition of the vagina from the perineum. What's the gap? And you need to be able to clearly recognize vaginal tissue and the level of the perineum, because you measure everything from the perineum. So we ask, is there a vagina there? Is there one? Is there two? How much proximal? How much distal? Is there a gap? Is there a transverse septum? All of those are questions that you have to answer. So what does the normal vagina look like? Well, it is collapsed as a structure. Normal vaginas do not contain any retained fluid. If there's any retained fluid there, it's your hint that there is some degree of vaginal stenosis. Now, vaginas are either H-shaped or they're smileys, and this is an example of a smiley vagina. So you can see, I always think they look like little clowns. You see they've got a big nose there, which is the urethra, and a big smiley lip, that's the vagina, and then they've got the little eyes. And this is an enhanced clown. Again, his eyes, his nose, and his mouth. So there we are, clown vaginas. So how do you define the urethral meatus? Because the urethral meatus is where the perineum is. So if you find the urethral meatus, you know what level you can do your measurements from. So if you find the urethra and then just go down slice by slice, and then you hit this comma shape, so it's like a double comma, that is the level of the urethral meatus, and that is the level of the perineum. So it's quite a sort of critical thing to get your eye in for, to make your measurements from. This is an example of a double vagina where instead of the H or the smiley, we've got a couple of trefoils here. You can see the high signal in the center there from both vaginas. So the ovaries, why are the ovaries important? Well, they are frequently ectopic in Müllerian anomalies. In our own series of patients with Rokitansky syndrome, either one or both ovaries have been ectopic in up to 50% of patients, about 46%. You need to know where those ovaries are so that you don't go, when patients have complex anomalies, you don't want to damage them. And also for patients like Rokitansky, their only hope of having a child is with egg harvesting and surrogate pregnancies. So that you need to know where those ovaries are in order to harvest them. The most common sites for ectopic ovaries are either high at the pelvic brim, where they tend to lie anterior to the psoas, or low down, but very anteriorly and rather laterally. And we've got one patient with Rokitansky syndrome where both the small rudimentary uteri and the ovaries are just sitting at the internal inguinal orifice. So she was diagnosed as a complete androgen sensitivity syndrome because they sort of looked a bit like ectopic testes. But so you can find ovaries in quite bizarre places. So this is a patient with that septate uterus that we looked at earlier. So she has a normal right-sided ovary. And here you can see we're right at the pelvic brim. This is S1. And here is the left-sided ovary, way out of where you'd normally expect it to be. So finally, about pre-surgical planning, uterine function. Now, obviously, the function of the uterus is to become pregnant and carry a baby to term. But we actually are very poor we don't know what factors define an adequate uterus. I mean, we think it's probably size, morphology. We know it's something to do with endometrial thickness. And as Professor Tagashi knows herself, that there's a lot of information on uterine function which tells us about how a uterus is working and the motility. And so we think that motility is also very important in how a uterus functions. But it's actually very difficult to assess these patients because often if they're obstructed, they're hormonally suppressed, and so we don't know what is suppression and what is the fact that it's just a pretty rubbish uterus. And so another approach is to start challenging these uteri and imaging them. For example, you can challenge them and image the endometrium. An example of hormonal stimulation is seen in this patient with Swires syndrome. Now, Swires syndrome is where patients have XY, so they have male genetics, but they have streak ovaries, so they don't have testes, so they don't produce Müllerian-inhibiting hormone, so they produce a uterus. So you have XY patients who are phenotypically female, and they have a uterus. But they don't have ovarian stimulation. So this is a patient who had a very small uterus, patient with Swires syndrome, and she has had hormonal stimulation. You can see that she's now got really a very adequately sized uterus, and there's quite good development of endometrium. So this is potentially a uterus that could become pregnant with egg donation and in vitro fertilization. So the other thing we need to look at is other abnormalities, and there are a lot of them. There are a lot of associated abnormalities, the most common being renal and skeletal. Sometimes they're syndromic. The absent kidney is the most common, and this is often associated with ureteric anomalies. You want to know about these ureteric abnormalities because sometimes you have these obstructed ureteric remnants, and again, if someone's going to go in and deal with this complex surgery, complex anatomy, they need to know about it so they don't go chopping it. The other thing is that there's an increased incidence of ectopic ureters, and this can be a cause of incontinence. We've seen patients with insertion of ureters into the vagina, into low urethra, and that can cause incontinence. So this is a patient who has got a unilateral kidney, and she had a uterus didelphus with a left hemivagina and presented with obstruction. So this is the left-sided ureteric remnant. You can see it's extending from quite high in the pelvis, but it has an ectopic insertion. This is the double vagina. This is the ectopic ureter, and you can see that it's actually full of blood. This is a T1 image, and it's full of blood. And this is because it's inserting into the vagina, which is itself obstructed. So you've got retrograde reflux of blood. Endometriosis. This is an example of a patient not with a uterine anomaly, but with deep endometriosis. Endometriosis is seen very commonly when they laparoscope patients with obstructed Müllerian anomalies, but in fact it doesn't appear to be a problem. If you relieve the obstruction, it just goes away, so they don't end up with significant clinical endometriosis once they become unobstructed. Adenomyosis can occur in an anomalous uterus like it can occur anywhere else, and we can see here this is a patient with bicornuate uterus and bilateral adenomyosis with thickening of the junctional zone and little areas of ectopic blood. So post-operative patients, well, uterine and vaginal surgery does have a relatively high failure rate, and the patients represent with recurrent pain and amenorrhea. And the most common problems are recurrent vaginal stenosis, and the other problem is in these patients with unicornuate uterus where they've had difficult operations, where you've been worried about the cervix, and you leave a little bit of functioning endometrium in the resected uterus, and they get recurrent hematometria. And in these patients, MRI is invaluable. So I've shown you a couple of cases. This is a patient who has had a colonic transposition to create a neovagina. And if you look here, we've got the bladder, the sagittal scan, we've got rectum posteriorly, and this is the neovagina. You can see it's surrounded by a huge amount of fat, And that is because the section of colon is brought down with a sort of big chunk of mesentery to maintain its vascular supply. So we can see that this uterus has got a distended body and cervix, and then the vagina looks pretty good in transverse section, but there is an anastomotic stenosis here at the junction between the cervix and the neovagina. In contrast, we have a patient here who's got lots and lots of hematosalpinx and a distended cervix and uterus. So here we can see that there is a stenosis between the cervix and the vagina. But if you remember, I said you don't get fluid in a normal unobstructed vagina, and what she had was a second stenosis. So in addition to that stenosis there, she had a more distal stenosis of the vagina, and this section here of the vagina, all the lower third of the vagina had stenosed up again, probably because it was not adequately perfused. So, dysgenetic gonads, they're becoming a bit of a hot topic because patients are requesting to retain their gonads. And a good example of this are patients with complete androgen insensitivity syndrome. So these patients are XY, they're phenotypically female, they have testes, but they have complete insensitivity to testosterone, so they develop as women. But they do have testes, and these can be sited either in the groin or in the pelvis. These ectopic testes have an increased incidence of malignancy. The disease starts as in situ disease and probably takes about a 7-year course to become invasive. But it's very hard to quantify that risk. Now, the old way of dealing with this disease was, or disorder, is that patients were allowed to go through puberty and then the testes were resected because of that increased risk of malignancy. In fact, what we're doing now is that we're finding that there's a whole bunch of women who now want to retain their testes. And they want to do it because it gives them a feeling of well-being. There probably is some non-specific effect of the testosterone. They don't require hormone supplements, so they don't have to take pills every day if they retain their testes. And they do, somewhere in the back of their brains, they sort of hope that one day they will be able to use these testes for reproductive material, for genetic material for reproduction. So we're now left with this problem is, what do we do with people with retained testes that are potentially very malignant? So we have recently looked at our entire series of patients with CAS who have retained their testes, and we've characterized the appearance of the testes, correlated this with histology, and we've asked the question, can we detect malignant disease? So we have reviewed 46 testes in 25 patients, about half of which have still got them in, and then half of them decided to have them out after the age of 16, but after they had kept them in for a long time, relatively. So these retained testes were resected at the age of 24, a mean of 22. Our patients who've continued to keep their testes in are aged up to 39. This is our oldest patient. So what we see in these testes is they have nodules. You see nodules in around 60% of patients. And these nodules, these low signal nodules, are adenomas. We also see ELF hats in a smaller proportion of patients. And this is the hyalinized pampiniform plexus. And you see cysts, which are paratesticular cysts. Some of them are clearly epididymal cysts in the majority of patients. So in 13 patients that did undergo gonadectomy, and you must remember their mean age was 22 years, 3 of these had pre-malignant foci. None of them had invasive disease. And 2 of these were intratubular germ cell tumours, and there was 1 patient with a sex cord tumour. 13 testes had germ cells within them, but these were spermatogonia and spermatocytes, so they weren't sperm, and these do not have reproductive potential. So this is an example of a patient with a retained testis, and this low signal nodule here is a adenoma, and you can see that actually they're scattered throughout the pelvis. And there we have our paratesticular cyst. And this is the thickened pampiniform plexus down here, which is the ELF hat. Now you might ask, why do I call this an ELF hat? And it's because this is actually an upside down ELF. If I turn him up the right way, you see there's his hat. So there's the ELF hat. There's his face, and there's his white beard. And this the ELF hat, is this thickened hyalinized panpiniform plexus with fibromuscular hyperplasia. And we've been through all our patients like this and sort of really done very detailed matching of macrohistology and histology. And so we really, we now really know what's going on in these testes. This is the patient, or one of the patients, that had ITGCN and cells. So this is in situ disease, staining up with PLAP, which is placental alkaline phosphatase, a germ cell tumor marker. So what do we know about these dysgenetic gonads? Well, we know we can't detect in situ disease. They looked exactly the same as all the others. We don't know what is the necessary interval between follow-up. There's this feeling that probably they have in situ disease and then they suddenly fall off the cliff. So at the moment we're choosing to image them every year, but this may be inadequate. We may have to start to biopsy these testes in order to be able to identify when they have in situ disease, which would, if you develop in situ disease, we would recommend to the patient that they have them resected. There is some potential for developing special histology stains which might recognize early malignant disease. And we've just set up a European Working Party collaborative study where we're pooling all our patients with retained testes so that we can then have a longitudinal natural history study to actually work out what we should be doing with these patients. So the other place that MR is absolutely fantastic for is complex cases. Some of these cases are extremely complex. And I'm just going to show a couple. So here we have one patient who had spina bifida, exstrophy. She had uterus diadelphys. She had adenomyosis, an obstructed left vagina, and a right vagina, which was draining into the perineum, but not the perineum in the midline. It was really into the right buttock. So this is her image, and you can see it's really very complex. So these are axial scans. So this is the anterior margin of her superior pubic ramus, and you can see there's a large defect in her pubic rami. So this is the exstrophy. There's a very poorly formed pelvic floor muscle, and she has no coccyx because she had a spina bifida. Here we see a bit of bladder. This is part of the right-sided uterus, and this here is an obstructed left vagina. You can see she's had surgery before. And on this slide you can see that this is now the right-sided vagina, and really it's just ending in the perineum at the common cloacal opening. When you get these cases, we see them in their teens, but of course these very complex cases have been looked after by the paediatricians for many years before we get them. But as children, the overwhelming part of their care is directed towards improving their musculature, dealing with their urinary problems and with their rectal problems in patients with anorectal atresia, for example. So we see them as teenagers when suddenly they start to either develop obstructed menstruation or when they start to talk about their reproductive potential. You know, am I going to be able to have babies? So by the time we get them, they've often had a lot of surgery. So unpicking the complex surgery from what is actually going on in their pelvis is extremely difficult. The other thing is that they do tend to have a poor outcome in terms of their reproduction because very often the surgery that they've undertaken makes it impossible to do laparoscopic surgery. They're at high risk for open surgery, and they are extremely difficult patients to look after. So the more information you can give your surgeon, the better. So another patient with complex anomaly is a girl who has a transplanted right kidney. She's got a dilated left ureter, and the reason it's dilated is because it's draining into the urethra, so she's incontinent. And she also had a septate uterus. So here we have this transplanted kidney. We have a septate uterus with a thick muscular septum. Okay, don't go anywhere near that with the laparoscope. And don't start chopping away that septum, you'll run into trouble. And then on the next slide, you can see this in cross-section. This is her distended ureter. And the reason it's distended is because it's inserting just down here, just below the vesico-urethral junction, and it's partially obstructed because the wall of the urethra is acting as a valve. but every now and then her pressure was building up and then she'd be incontinent. She was wearing pads and smelt when she came to the clinic. So does MR have added value? I think definitely. It's an absolutely fantastic tool in looking after these complex patients. Finally, I'd like to thank all of you for turning up so early in the day, and I'd like to acknowledge my co-workers in the DSD team because we very much function as a team, including Sarah Crichton, who's pediatric adolescent gynecological surgeon, and our adolescent urologist Dan Wood and Chris Woodhouse. But there are, of course, many others. Thank you for your attention.
Thank you very much. Thank you for the invitation. Good afternoon, everyone. I have no financial disclosures. What we want to do the next 25 minutes or so is discuss patient preparation and the MRI protocols for imaging of various uterine conditions. I'm going to go to how do I report a GYN MRI with specific reporting tips and pearls and pitfalls. We're going to review the added value of MRI on treatment selection and planning of patients with both benign and malignant uterine conditions. And as I go through some of the cases, I'm going to highlight a few pearls and pitfalls of MRI imaging. Just starting with the technique, we use both 1.5 Tesla and 3 Tesla scanners, either a pelvic or if you have a cardiac phase coil, that's also excellent. We ask the patient to empty their bladder prior to their examination because what you want is a semi-full bladder by the time you start acquiring the images. We used to ask them to fast for 6 hours, but now we give the antiperistaltic agent. In the US, glucagon. In Europe, you can give both glucagon and Buscopan. We don't use any vaginal gel, and that is, in my opinion, optional. And just to show you 2 cases here, a case here of a patient which had prior trachelectomy, and I'll talk about that in a minute, which means amputation of the cervix for fertility preservation for a patient with a small cervical cancer. You can see here, before giving antiperistaltic, there's a lot of movement mainly due to the small bowel getting here into the recess. And you can see the same patient, same sitting after the antiperistaltic. You can see how nicely this area of the neo-vagina is seen. And you can confidently say there is no tumor in this case. So what planes do we use? For the uterus, we start with large field of view axial T1 weighted images. We want to look at the para-aortic region, especially for in case of malignancy, as well as in the case of uterine anomalies, you want to make sure that both kidneys are present. Then we do the high-resolution T2 weighted images on the sagittal, axial, and coronal plane, especially for the benign conditions. For uterine anomalies, we use the long axis, so parallel to the plane of the uterine cavity, or a short axis in case of endometrial cancer, which is perpendicular to the plane of the uterine cavity, and I'm going to illustrate those planes to you in a minute. So there we go. There's a sagittal here. If you want to look for uterine cancers to see the depth of invasion, to stage them, then you use an oblique plane, so perpendicular to the endometrial canal. We use diffusion. We have an axial multi-bivalue diffusion, IVIM type, and there's a larger field of view. At the moment, it's used in the research setting. We also do sagittal and axial oblique to match the T2 weighted images with 3B values. We do give contrast, and we use multi-phase contrast in both sagittal and oblique axial plane, again matching the T2. In case, let me just emphasize you the plane in case of the uterine anomalies. Just a T2 weighted image here. As you see, it's a retroverted uterus here. This is the standard axial. And you can see here, yes, you probably even can diagnose here septate uterus. However, you need to do a little bit more than that. You need to measure the length of the septum here. It'll be much more accurate if you really did use a coronal plane here, true coronal to the uterus, so the oblique plane. As you can see in this case here, you can nicely measure the septum and describe the composition of the septum. When it comes to the cervix, again, you need a large field of view axial T1 weighted images to look at the para-aortic region for lymphadenopathy. The high-resolution images, you really don't need the coronal in this case, or at least we don't do the coronal in this case, we do sagittal and axial. In this case, the short axis plane is to the cervix, so perpendicular to the cervix, and here you go, there is a sagittal image here with the tumor into the posterior cervix here. And if you do the oblique plane, so perpendicular to the tumor or to the cervical canal, you have these oblique axial planes, which allow you to actually look at the depth of myometrial invasion, cervical stroma invasion very nicely. We keep the same parameters for all uterine malignancies. So again, diffusion, IVIM on the large field of view, and then sagittal axial oblique on a short field of view with multiple b-values. And then we do give contrast on both sagittal and oblique planes to measure the T2 weighted images. So in a way, you sort of keep some of the sequences the same, but you vary according to the clinical questions to the condition. So you try to sort of personalize a little bit the protocol on the pathology you're looking at. So just to re-emphasize that oblique plane, it has to be true oblique to the tumor, so perpendicular to the tumor. This is a case of a very large tumor, so dumbbell-shaped tumor endocervical. This is the case came from another hospital. You can see the sagittal here. That is the axial to the pelvis rather than to the cervix. And I wouldn't fault anybody for calling that a parametrial invasion. You can see the stroma is preserved here. You can see there is no stroma here with tumor almost with no stroma between the interface between the tumor and the fat. However, the surgeon did say that, well, I think that the tumor is it's free and we don't detect any parametrial invasion. And actually, if you look at the axial oblique case, images perpendicular to the tumor, you can see exactly what they mean, and they're absolutely right. You can see that the stroma is absolutely intact, and the tumor is just confined into the cervical canal, although being a large tumor. So how do I report a GYN MRI? First of all, and that's sort of a mental check you do, I'm sure, on everyday basis when you read, you check that all the sequences are available for reporting. Sometimes, you know, the tech might forget to push a sequence through to PACS. I check the quality of the images, and we have a very nice tool now that we give both positive and sort of more critical feedback to the technicians on the quality of the images. Then you need to look at the need for extra sequences or planes, especially if you're supervising your studies. If you work on a small center, then you can supervise the studies. If you're looking for endometriomas or dermoids, or if you saw something high signal intensity on T1 weighted images, then you can ask for the T1 fat set images. And I'm sure you'll hear more in the next talk about this. You make sure that the planes are correct. For the GYN malignancies or uterine anomalies, and you also check that the upper abdominal images are there for both the para-aortic region for the lymph nodes and also presence of kidneys. And if you actually supervise your studies, maybe you can get away without giving contrast in certain conditions, and I'm going to reiterate that. But if you actually have a lot of scanners spread out, like we do have along New York and New Jersey, then you probably are better off of actually having a standard protocol which is followed, because you can't really, you know, supervise every single study. But in a small setting, that is actually doable. So before starting to actually dictate your report, you need to know indications for the MRI, and they are obviously automatically populated, but we sort of tailor them accordingly, because there is more information probably on the medical record. What is the intended treatment? Because then you have to mention certain things which pertain to a certain treatment, and we'll go through that in detail. Age of the patient is very important, so is the menopausal status, phase of menstrual cycle, as well as the use of oral contraceptive. And that's really important. Like this case here, you can see that was actually a patient who had an MRI of the spine for back pain, and the person reported it was a neuroradiologist a few years back now, and they thought the uterus was really abnormal. They got worried about the possibility of a sarcoma. But actually, this is a classic appearance of somebody with a long-term oral contraceptive when you actually have a lot of endometrial and inner myometrium junction zone atrophy and the globular myometrium. So, you know, once you know the pitfall, then you can easily sort it out. And that was actually the case when the patient was asked. You have to ask for use of hormone replacement therapy, because you have different thresholds for endometrial thickness, and then, of course, the risk of polyps and endometrial cancer. And, of course, any pertinent OB/GYN history. State the indication for the exam, describe the sequences used, and this pretty much in our hospital actually comes automatically, so we don't actually need to do that. You have to adapt it if you gave antiperistaltis or not, just to make sure you're accurate. In the uterus, presence, positional orientation, you have to really state that. Size in 3 dimension. It's very important because sometimes they decide on the approach. Endometrial thickness, obviously, comment on the junction zone if it's thickened or not. Presence of adenomyosis. and comment on the cervix. Ovaries, obviously present size. We don't usually measure ovaries unless they're abnormal, and then you have to give measurements. But otherwise, you know, the ovaries appear normal, no adnexal masses will actually suffice. And just a word on free fluid, because we overuse the word ascites all the time. If there is a small amount of fluid in the pelvis, especially in the patient's premenopausal, you don't have to say there is ascites present. Ascites has got a pathological connotation, means that it's actually malignant cells, so, or due to, I'm non-malignant, but due to a pathology. So I use free fluid in my report. Uterine anomalies, again, presence, position, orientation, configuration, size of the uterus. If septated, you must state if it's complete or partial, muscular or fibrous or both, and the length of the fibrous part, and we saw that case already. If unicornate, you have to state if there is a rudimentary horn, if it's communicating or not, and if there is active endometrium within a horn, and that's important. And again, I'll show you a case because it really is crucial when you plan the treatment. And for the ovaries, we just went through that. But in the case of uterine anomalies, there is a strong association with polycystic ovaries, so you have to mention them when you think they have a polycystic configuration. And of course, unicornate uterus has a high association with endometriosis and hematosalpinx, so again, you have to mention that on your report. And again, if the kidneys are present, absence, or the duplex system. Just to show an example of uterine anomalies, that's actually a 15-year-old who came to the hospital with a raised CA-125, around 4,500, and with abdominal pain. The ultrasound described a normal uterus and a left adnexal mass suspicious for ovarian cancer, which statistically probably was unlikely at the age of 15, but in the raised CA-125. So we did an MRI. As you can see, this is a classic appearance of a unicornal uterus with a banana shape. Cavity, and then you can see the other cavity, which is a non-communicating, and there is blood products. You can see on T1 fat cell images, you can see these hematosalpinx here. So that's what we said, and what they do, they go in and actually they resect this horn, and of course there was no evidence of malignancy. Just put everything into the context: the age, the symptoms, and as well as the imaging appearances. Leiomyomas and adenomyosis, I've grouped them together in the interest of time. Again, you mentioned the size of the uterus, the junctions on thickness, obviously for adenomyosis, presence, size, and position of leiomyomas. This is important for treatment planning. Is there a compression of adjacent structures, type of degeneration, as well as any suspicious features? And I'm going to give you an example of that. And obviously, you got to comment about the ovaries. If a case is planned for uterine artery embolization, you have to comment on the vasculature. Is there an ovarian uterine artery anastomosis or not? That is really important for treatment planning. And of course, presence of hydronephrosis, which doesn't mean that that's a sign of leiomyosarcoma, because large leiomyomas can cause hydronephrosis. Now, moving to the uterine malignancies, it's been a really long way, especially in the US, to actually try to and accept MRI as one of the ways to evaluate extent of tumor in endometrial cancer. I'm not using the word staging because it gets some of the clinicians a little bit too anxious if we say we can stage it with MRI, but actually we can. So, and finally, NCCN, this is the 2017, just all the press, it does recognize the role of MRI in several sort of indications, and that's quite a lot of achievement from the imaging community to establish the origin of the tumor, endometrial versus endocervical, when you have an endometrioid cancer pathology. Definitely for fertility sparing, and I'm going to show you an example of that. For suspected cervical involvement, as well as for type 2 histology, so serous papillary and clear cell carcinomas, you can use it for staging, and of course for recurrence. So we do actually have got a long way in the US. France was always very pro-MRI, and they have it as part of their staging, and of course the imaging societies have MRI as their modality of choice. But what we need to do is actually get the imaging into the clinical guidelines, not just into our imaging societies. So how do I report an MRI for the endometrial cancer? State the tumor grade, the cell type. Is it a adenocarcinoma, or is it a serous papillary type, or is it a clear cell type? And the CA-125 level, if that was done. Because if you actually notice on the labs that the patient has a raised CA-125 level, then you worry already about the peritoneal spread. And it makes you look extra carefully to the omentum and the paracolligators and the ovaries, because then the type of surgery would be the one that you do for ovarian cancer rather than the one for the endometrial cancer. The tumor appearance, the size, the morphology, if it's heterogeneously enhancing or not. And sometimes I put some sort of notice on how it looks on the ADC map, and I'll give an example later on. And of course, tumor extent, depth of myometrial invasion, is it superficial, is it deep, involves the serosa or not, is there any cervical stroma invasion? Just don't forget the endocervical extension doesn't change the staging anymore, but cervical stroma invasion makes it a stage 2. And of course, is there any extrauterine extension into peritoneal disease or lymph nodes? And so you can see in this case here, it's a deep invasion of this endometrial cancer, and there is bilateral ovarian metastasis already. That's a case of a serous papillary tumor. Again, your report will stratify the patient because none of that is actually available. Well, perhaps the cell type, and I'll discuss that later prior to surgery. All these then will become available after the surgery, and you really want it before the surgery. So it's a lot of, it's one of the really good papers in this field. It's written by one of my colleagues, Alberto Vargas, looking at tumor location, endometrial versus endocervical. And it's actually pretty simple when you think about it. You have to identify the internal cervical os. And if the majority of the tumor is actually cranial to the endocervical os, that's going to be an endometrial cancer. And you can see here after contrast, just another image. And if the majority of the tumor is caudal to the internal cervical os, then this is going to be a cervical cancer. Why is it important? Well, it is very important because they cannot sort out it in pathology, but the treatment might be, it will be different because the type of the extent of the parametric excision you do is different for endometrial cancer compared to cervical cancer when you actually do a very time procedure and you do a very wide parametrial excision. So just a word on fertility preservation and endometrial cancer. This is actually very important since we're seeing some more and more young patients who require fertility preservation, or rather require or actually want fertility preservation. Because of the widespread obesity, we're seeing endometrial cancer in young patients now. So it's not a standard of care, but many institutions like ours do offer it, at least give it a trial. There are certain criteria, FIGO grade 1 endometrial cancer, absolutely no myometrial invasion, that's where the MRI actually enters the equation, no synchronous ovarian tumor, no ovarian metastases, no nodal metastases, obviously no Lynch syndrome, and no contraindication to progestin, which is the treatment they do. So in our institution, those patients have an MRI to actually exclude presence of any myometrial invasion, so this is really important. Otherwise, they'll be ineligible. And just to show you a case here, you can see on T2, it actually does look smooth, but it's very important to see this very smooth subendometrial enhancement line, which is completely intact here. You can't hardly see the tumor. You actually cannot see the tumor on this T2, but the junctional zone is completely intact. So this was confined to the endometrium, and the patient successfully received treatment with progestin. Compared to this other one, when the tumor is larger, it expands the endometrial cavity, a little tougher on those T2-weighted images actually to see the invasion. But very nice here after contrast, you can see this subendometrial enhancement line is actually interrupted. And you can see this sort of frontal leg of the tumor invading into the inner myometrium. So very important to keep in mind. And they do follow this patient with the MRI and biopsy to make sure there is no progression and there is complete response after treatment. There are several staging considerations one has to take in account in endometrial cancer. The majority of patients are actually stage 1 diagnosis. It's very important the depth of myometrial invasion because if you actually have a deep myometrial invasion case with a grade 3 or a type 2 cancer, serous papillary or endometrial or clear cell, your chance of para-aortic lymph node metastasis goes from 4% between up to 6% to actually 40%. So this is how important the myometrial invasion is. So is it easy? Well, nothing is easy, but now we have a lot of tools, so you can use both, all three, T2, diffusion, and dynamic multiphase contrast enhancement, and there is a lot of literature on that. And if you look at various studies, they propose the combination of one or the other, but basically both diffusion and DCE probably perform equally with a little bit better diffusion in this meta-analysis. And actually, I am a strong believer that if you did supervise your endometrial cancer staging on your MR scanners and you got nice diffusion-weighted images, you really don't need to give contrast. But if you don't supervise them, then it's better off to actually give contrast because you don't know if the diffusion images are actually good enough. There's been some very elegant work done by one of my colleagues, Stephanie Nougare from Montpellier, looking actually at tumor volumetry and also the volumetry of the ADC as well. She showed that if the ratio between the tumor and the uterus volume was less than 25%, then there is no myometrial invasion. But if it was more than 50%, all cases had deep myometrial invasion. So that can be potentially actually applied, and you can do it in your scanners, and it does give quite a lot of information to the clinicians. Just a couple of stages for the as examples. This is a case of endometrial cancer, again on T2. It's a little tough. Maybe you can say, well, it's definitely not outer myometrium, and maybe it's really irregular. Maybe you've lost a little bit of junctional zone here posteriorly. After the contrast, just remember the tumor is of low signal intensity, no enhancement. It enhances less than the adjacent myometrium. And you can see on the ADC map here, on the diffusion weighted here, it's bright and will be dark on the ADC. I'll show you an example in a minute. What I want to point out here is this bright area, which I've seen it called before a myometrial invasion. This is just peritumoral inflammation. It's a very, very nice paper from our Japanese colleagues here, and I encourage you to read because it is a pitfall that you'll encounter very frequently. So again, peritumoral enhancement is an inflammation. It's actually not deep myometrial invasion. Just to show you the type of images you can actually get, this is a 1.5 Tesla, just really standard. And you can see a large endometrial tumor here invades a little bit more than 50%, probably on the sagittal. Nice to have those really perfect obliques because you can see here in both T2, contrast, diffusion, and ADC maps that the tumor does invade into the outer myometrium. Again, if you get this quality of diffusion, you can actually cross the contrast and save some time and money in the scanner. Cervical stroma invasion, I think contrast does have some value when it comes to cervical stroma invasion, and so the diffusion actually can do the same. You can see this is a tumor here which extends into endocervical canal. On T2 it's a little tough. Is it actually invading or is it just pushing the cervical stroma to the back? Much easier here on these post-contrast images. You can see tumor is infiltrating, kind of eating out into the cervical stroma posteriorly, and that was indeed cervical stroma invasion. Very, very important because those patients have vaginal brachytherapy after their surgery. So you can counsel a patient before actually they start their treatment. Just to give you many phases of sort of stage 3A, at this point, you probably don't need anything beyond the T2 anatomical images. This large tumor, obviously, the serosa is gone here. You can see the tumor is outside the uterine contour. This is a case of a septate uterus with a small adenomyoma in the septum, just to spice the case up. But that's an endometrial tumor here with the tumor growing into both fallopian tube and the ovary. So definitely, that's easy on the T2. That's another case here with tumor with a met in the ovary. That's the primary endometrial cancer here. And then it's tumor walking into this fallopian tube, which is distended with tumor. It can be subtle. So I think diffusion does have a role here. And this is a case of serous papillary adenocarcinoma. So you can see there is deep myometrial invasion. It's actually less than what one thinks on T2, but still was deep at pathology. If you look at the T2s, you really wouldn't think anything on the adenxa here on the left, but on diffusion-weighted images, it's hard to ignore this bright spot here, and you can fuse the images. That usually does help to actually promote modality, especially with the surgeons and the oncologists, because it's like nice color pictures, and that's what we're supposed to do as radiologists. And you can go back, I can see the adenxa here. You can see there is a really indistinct area. We called it because the serous papillary was very restricted diffusion, and the CA125 was high, and indeed it was an 8 millimeter deposit in the surface of the left ovary adenxa. So that's a very nice case given to me by my colleague and friend, Professor Togashi from Kyoto. A large endometrial cancer, obviously invading the cervical stroma here. There is a little tumor sort of nodule in the serosa there, so definitely a 3A. any vagina involvement, really hard to say on those T2 weighted images, but then you fuse them with diffusion weighted images, and it just, even retrospectively, I don't think, maybe with the eye of faith you can see that part here, but you know, this lower vagina here, I wouldn't have picked it up on a T2 weighted. So I think diffusion is excellent when it comes to really small lesions and like drop lesions in the adenxa, in the cervix. So I suggest using that because it's quick as well. So endometrial cancer aggressiveness, there's been a lot of literature on that, on diffusion-weighted images. There is some contradictory sort of evidence, but by and large, I think there is now sort of some consensus that there is a difference between grade 1 and grade 3, but there's no difference in grade 2 and grade 3 endometrial cancer. And actually, there is a nice talk in tomorrow morning's session at 8 o'clock on looking at different ways of looking at tumor aggressivity on endometrial cancer. There's also a relatively recent paper here, which is actually quite nice, again from Japan group, looking at DCE, and again there is indication here that you can actually predict the type of endometrial cancer, type 1 versus type 2, grade 3 serous papillary and clear cell, using the dynamic contrast analysis as well. And just to point out this very nice case given to me by my colleague, Professor Anwar Padani from Mount Vernon in London. And we actually see that not very infrequent now. This is, as you can see there, this is the diffusion B0, B500, and ADC, and the fused images. I just want you to appreciate that there is different shades of gray in this ADC. And although this patient had a grade 1 endometrial cancer at a biopsy prior to surgery, what the biopsy missed is the serous papillary cancer at the back here, which is actually the worst prognosis part of this tumor. So we do actually use this. We eyeball it, but you can also measure it. We actually use this in the report. And sometimes I do say on the report, like I do for prostate as well, the degree of restricted diffusion suggests presence of a type 2 or presence of a higher grade tumor. So they actually are extra careful for that when they treat the patient. Very quick on leiomyosarcomas. That's a whole holy grail. What do? You can distinguish very easily the garden variety leiomyomas from leiomyosarcomas. The problematic is the atypical leiomyomas or cellular leiomyomas from leiomyosarcomas. And there is some elegant work done by my colleague here, Dr. Lackman, in combining certain features as described here, the nodular tumor borders, T2 dark areas, hemorrhage on T1, as well as central necrosis. And if you combine, if you have 3 or more features present, that actually you have a very high sensitivity and specificity to actually diagnose it. So you really have to get all the information together in order to achieve that. Diffusion, there has been some recent work there. The problem is there is always overlap in the ADC values. So I think we need to do a little bit more work on diffusion in order to actually use it effectively for this purpose. Just moving to the last part on cervical cancer, what are the MRI indications? Well, origin of the tumor, we already covered that. Selection of fertility sparing, and I'm going to spend a minute on this. Evaluation of parametrial invasion, that's the key question. Oh, I'm sorry. Radiotherapy planning and follow-up, and of course, evaluation of tumor recurrence. And finally, the suitability for pelvic exenteration, or like we call it now, pelvic reconstruction. So what does the MRI report say? Again, tumor grade, cell type, FIGO stage, you got to state it, if it's available, tumor appearance, and tumor extent, parametrial invasion, hydronephrosis, vaginal, bladder, rectal invasion, of course, metastases and lymph nodes. So these are the criteria for trachelectomy, which means amputation of the cervix, a little bit of upper vagina, and the lower cervix and the lower uterine segment. And you have to accurately measure the distance. So, and again, this is some nice work done by Dr. Lackman here. If there is, you have to measure distance between the tumor and the internal cervical os. You can see here is very close to, definitely less than a centimeter. On the other case here is more than a centimeter. This case did not have trachelectomy, unsuitable. This case is suitable because the tumor is more than a centimeter from the os. Parametrial invasion, when it's subtle, it's more difficult. Obviously, when it's a big tumor, it's more difficult because it's adjacent stromal edema. And an intact low-intensity stromal ring will gives you a high negative predictive value for excluding parametrial invasion. This is a small tumor. You can see this lip of tumor here outside. Does the diffusion help? It does increase your confidence. You can see this sort of little bit of tumor going out into the parametria, and you can see there on the fused images, this patient had surgery because she had ulcerative colitis, so she couldn't have radiotherapy, and indeed she had parametrial invasion on the right. This is gross parametrial invasion. You can see there, there is speculated tumor to parametrial interface. Here there is tumor, frank tumor, or soft tissue extension into the parametria, and then encasement of the periuterine vessels. Then we got into the advanced disease, and with this case, I'm going to illustrate all stages of the disease. And again, when it comes to this stage, you really don't need probably diffusion or contrast. It's just so advanced, and luckily we don't see them that often. But you can see here 3A, stage 3A vagina, lower vagina. Hydronephrosis is a stage 3B, and you can see there bladder invasion is a stage 4A. And you can combine, of course, diffusion and fuse your images. And there's a small note here, which you can't say much on the ADC alone or the fused images, but you go back to the T2 and you can see this node is round, and it's on the side of the parametrial invasion, which makes it highly suspicious for metastasis, and indeed it was. So with 1 second left, this is my last slide. So take-home points. It's imperative to optimize the MR technique and beware of pearls and pitfalls. The use of pathology-specific report is crucial, and it's crucial you talk the same language with your clinicians. And MRI does play an important role and added value in all those indications that I discussed with you. And again, it's working with the clinicians is how we promote our modality and the value and the added value of modality. I just want to thank my super team here, Dr. Vargas, Nugara, and Dr. Lackman for just making my work fun. Thank you very much.
Thank you for the invitation. And I have no financial interest to declare. So I've been asked to talk about the adenxa. Adenxa is Latin for appendages, and here we're talking about the appendages of the uterus, which are basically the ovaries, the fallopian tubes, and their supporting structures. Mostly, the disease is diagnosed on frontline imaging modalities such as ultrasound or CT, so that we know when the patient comes for MRI that they already have the presence of an adnexal mass. So what is being asked of the MRI? The questions are, is it benign or malignant? If it's inflammatory, is it a surgical emergency? And if it's malignant, what stage is it? So the role of MRI for adnexal masses is really in the characterization of the mass and in the staging. So in the next 20 minutes or so, that's what I'm going to talk about, characterization and staging of adnexal masses. And under characterization, we're going to deal with some of the techniques that we can use, normal anatomy, inflammatory masses, the revised WHO classification, and the features of benign and malignant disease. So the techniques. Avis has dealt with some of them with regard to the uterus, and it's pretty similar with regard to the adenxa. So in addition to the standard morphological techniques of T1 and T2 weighted imaging, we have gadolinium enhanced imaging, in which we give an extrinsic contrast agent, which is uptaken by tissues which have high perfusion, and it alters the T1 relaxation of the water in that tissue. So it's really the water we're looking at, and it's important to remember that, not the gadolinium directly. And the tissue shows high or shortened T1 relaxation. So in comparison, a tissue such as an endometrial cancer, which is poorly perfused, might show as a negative contrast. In other cases, it might be that the pathology itself takes up the contrast and shows as a shortened T1 relaxation in compared to the background normal tissue. And we can model this by looking at the rate of uptake of that contrast agent into various compartments, such as the plasma or the extracellular compartment, and how quickly it washes from one compartment to another, and work out rate constants for that. And that gives us values that are numerical for things like permeability, wash-in, wash-out, and so on. A simpler way of contrast enhancement, as it were, is using the intrinsic property of the tissue, which is diffusion-weighted imaging. And again, we've heard a lot about this. It looks at the free motion of water within tissues, which is restricted in more cellularly dense tissues, which means that as we increase the diffusion weighting of our sequence, in a freely diffusing tissue, we get a diffusing away of the signal, whereas in a cellularly dense tissue, such as a tumor, the signal is retained. So at a high B value, as Avis has so elegantly shown you, a tumor shows a high signal intensity, but on the ADC map, the rate of change of that signal intensity or the slope of that line is much lower, so it appears as darker. But we can quantify that, and that's what's important. So, the normal anatomy of the appendages. The ovaries are the most important structure, and basically, the ovaries are a source of female gametes. The oocytes, which reside within the follicles, are at various stages of development, and they're surrounded by these granulosa cells. And as the follicles develop into secondary follicles, they get enclosed within thecal sacs. The oocyte is discharged monthly, as you know, and that leads to the formation of a corpus luteum under normal hormonal influences. Therefore, the ovaries on T2-weighted imaging can be seen as multicystic structures with these oocytes within their follicles. They're in a variable position in the pelvis, and they have low signal intensity stroma. There will be cyclical changes as the follicles develop into secondary follicles, and they are atrophic pre-puberty or after the menopause, or if the patient is taking the oral contraceptive pill. And here's just some normal ovaries and atrophic ovaries on the pill. So it's really important to note whether the patient is on any kind of hormonal manipulation during the time of the scan. Beware, I say, of calling polycystic ovaries. This is a condition that is well described. You've got normal-sized follicles in a ring, multiple normal-sized follicles in a ring around the ovaries, but actually it's quite a meaningless diagnosis out of the context of what is called polycystic ovary syndrome, because it has implications for the patient, and without knowing those clinical implications, it can be a devastating diagnosis. So it's good to be wary when producing a report saying polycystic ovaries. Corpus luteal cysts can have varying appearances, and if you're in doubt, scan the patient at a different time of her menstrual cycle to be sure. So, inflammatory masses. The most important thing about inflammatory masses is that the patient is acutely unwell. That is really the giveaway. The types of pathologies that we're dealing with are torsion, tubo-ovarian abscess, pelvic inflammatory disease and hydrosalpinx, ectopic pregnancy, which I won't talk about because it's a big topic in itself, and endometrioma. Ovarian torsion presents, as I said, with an acutely unwell patient. Usually, the patient has had an enlarged ovary because of a mass or other reasons, such as fertility induction or tubal ligation. Most patients are young. They get stromal edema and internal hemorrhage within the ovary. It's really important because the sequelae of these can be devastating. You can get ovarian infarction and lose the ovary. On MR, you see this classical kind of world appearance of the ovarian pedicle, and that is really pathognomonic of an ovarian torsion. A tubo-ovarian abscess similarly presents with fever, elevated white blood count, and vaginal discharge. Again, you see a heterogeneous enlarged edematous ovary, and the presence of air is pathognomonic. On the gadolinium enhanced scan, you get this inflammatory mass with enhancement and heterogeneous restricted diffusion on the ADC map. In pelvic inflammatory disease, in addition to this edematous ovary, you get a hydrosalpinx or dilation of the tube. Again, the patient is clinically unwell. They're usually febrile with pain. There is a history often of instrumentation of intrauterine contraceptive device, and the sequelae can be devastating if you don't diagnose this correctly, because it can lead to infertility or even malignancy if it's chronic. But you see here this dilated tube with the fluid levels in it, which are classical. In my neck of the woods, which is mainly in a cancer hospital, the diagnosis of an inflammatory mass is usually an infected lymphocyst. So you can see in this patient here, she'd had a lymphadenectomy, obviously that's the clue, and you've got a painful mass in the groin, enhancement with inflammation around. The one thing you've got to beware of in these patients is if they've had positive lymph nodes removed, then that can be a sign of recurrent tumor. Endometriosis is a very common reason for an inflammatory mass. Basically, patients get this irregular discoloration that's recognized at laparoscopy because you've got menstrual shedding with an inflammatory reaction that's spread throughout the peritoneal cavity. You've got entrapped debris that make it this blue-black appearance, and over time it becomes devascularized and scarred, leaving you with a white plaque. There are a couple of theories about why endometriosis occurs. One is the commonest is the retrograde menstruation theory, i.e. endometrium spills retrogradely into the peritoneal cavity, while other people believe that you get metaplasia that is multifocal within the peritoneum itself. Either way, what you get is these complex, cystic, and solid masses in the peritoneal cavity. Often they're associated with uterine adenomyosis, this irregular junctional zone thickening. But classically, the adnexal masses that occur with endometriomas have got these shaded heterogeneous masses that are high in signal on the T1 weighted image, low in signal on the T2 weighted image, as you see here. This is a stir image, so it's basically a fat-sad T2 weighted image. This shaded shadowing, which is very classical for hemorrhage because of the endometrioma from blood products. Moving to the revised WHO classification of ovarian tumors, if you remember nothing else from this talk, this is the bit to remember. There are really three categories: the epithelial tumors, the sex-scored stromal tumors, and the germ cell tumors. And of those three categories, the epithelial are by far the commonest. So they arise from the surface epithelium, and they come in a variety of serous, mucinous, endometrioid, clear cell, and Brenner varieties. You don't necessarily have to remember all this, but surface epithelial tumors is all you have to remember, and they can be benign or malignant. Those are mostly the cystic tumors. The other two, which I said are less common, the sex-scored stromal tumors are solid, and the germ cell tumors are solid. And they also come in benign and malignant varieties. You don't have to remember all these. You can look them up anytime, but just remember the three main categories: epithelial, sex-scored stromal, germ cell. And of course, you can get metastases to the ovary. So I'm going to deal with those three categories in the benign and malignant classes. And to start with the benign, the epithelial benign ovarian tumors are the commonest. They form 60% of serous ovarian tumors. They're basically large, simple cysts. They're in women of sort of middle years, unilocular or multilocular. The important thing is papillary projections are absent. That's a serous one. This is a mucinous one. It doesn't really make a difference. Basically, they look like cysts. They're hypointense on T1, hyperintense on T2, and you can get some enhancement of the cyst wall. Sometimes they're complex, and you can get them in conjunction with fibromas. This looks just like a fibroid. It's well-defined, very dark, homogeneous on a T2 weighted signal. This is a cystadenophibroma. And then the rarer type of epithelial tumor is the Brenner tumor. This is in older women. The reason it's an epithelial tumor is it basically contains urothelial-like elements within it and a fibrous stroma, and it is solid and sometimes bilateral. And this was a very good pickup from one of my colleagues, showing this sort of solid, bilateral, small masses in a postmenopausal woman with the restriction on the diffusion-weighted image. Okay, so that's the epithelial benign. Now, the sex-scored stromal benign are the fibromas. They look just like fibroids, well-defined, low signal intensity on T2 weighted image, and you can get heterogeneous enhancement with gadolinium. But it's their sort of low signal intensity, well-defined nature that really defines them. The second kind of benign sex-scored tumor is the thecoma. These, again, are well-defined, low signal intensity, but not quite as low as the fibromas. They're sort of a kind of intermediate shade of gray, and they often have these sort of cystic lakes within them. They often secrete estrogen, so the patient becomes estrogenized, and there's the classic Meigs syndrome when they're associated with pleural effusions. But the appearance is fairly classical, and you will be able to recognize them. Here's another case just to show you that on diffusion-weighted imaging, they're homogeneous and restricted on the ADC map, as you see there, and that they enhance evenly. And then the third type of benign sex-scored stromal tumor is the Sertoli-Leydig. Again, this is a rare tumor type, but it's in a young patient. Again, very well defined, intermediate signal intensity. The patient's age is a giveaway here, and the other thing is they produce testosterone, so the patient becomes progressively masculinized. So it is the hormonal thing about the patient that gives it away that it's a Sertoli-Leydig. And then the commonest benign tumors are really the germ cell tumors, and these are, you're all familiar with, the dermoid cysts and the mature cystic ovarian teratomas. There is a pathological difference between them in that the dermoids only contain dermal and epidermal elements, whereas the mature cystic teratomas contain mesodermal and endodermal elements, and people kind of use them interchangeably, but the pathologists recognize the difference. Again, here, fat is pathognomonic. If you see fat within a tumor, it is a germ cell tumor, it is a dermoid or a mature cystic teratoma. And the fat suppression techniques need to be done. So where are we with the benign ovarian tumors? Basically, cystic are epithelial, solid without fat are the sex-scored tumors, solid with fat are the germ cell tumors. T2-weighted imaging is mandatory. Diffusion-weighted imaging is pretty, but doesn't really help. And gadolinium is used just to exclude the presence of enhancing nodules within the cystic ones. So, malignant tumors, these are the ones, obviously, you don't want to miss, and the ones that you're unlikely to miss because they're so characteristic. They're often large masses, multiseptated, nodules and projections within them, diffusion restriction, as you see here. They're complex cystic masses that must be considered malignant, and they are basically in middle-aged women of 6th and 7th decade, and they have this appearance of high on T2 with low on T1 on the cystic components, together with the solid components, as I said. Here are just some pretty examples showing you the papillary form projections and the kind of complex, heterogeneous pattern of the solid components that characterize them. This one just shows an endometrioid cancer, and again, the only point here is that on diffusion-weighted imaging, the solid components are restricted, and they enhance on the gadolinium-enhanced images. An important category not to miss here is the borderline tumors, and the reason these are sort of slightly different is that they're probably less invasive and therefore require less aggressive treatment. And the only way to really recognize them is that they have less nodules, often smaller nodules, as in the stippled appearance in this benign, in this borderline tumor, but they can be spread all over the peritoneum, and they can be recurrent. So if in doubt, always call it a malignant tumor rather than a borderline tumor, unless you're sure or there's just very few nodules. Okay, so that's the malignant epithelial. So the second category is the malignant sex-scored stromal tumors, and here we have the granulosa cell tumors. Just like the thecomas, they're this intermediate, homogeneous signal intensity with these lakes of high signal cystic areas within them. So just think of a thecoma and a granulosa cell tumor kind of in the same spectrum, but the difference with the granulosa cell tumors, obviously, because they're malignant, they're multiple nodules, they're not just solitary as a thecoma, and they can be really quite aggressive. But they go on, some of these go on for years. You know, they have multiple chemotherapies, multiple surgeries to remove different nodules in different places, but they're highly symptomatic to the patient. So actually, giving the surgeons or the oncologists an idea of exactly the extent of these masses is very, very helpful with MRI. And then the malignant germ cell tumors are really tumors of young people, often even in a pediatric population. They're immature, and you can see here they've got multiple elements within them, often calcification, mucinous elements, fat, sebaceous material, and so you can see them as heterogeneous masses in the adnexy. If you get a malignant germ cell tumor in an older person, it's often a dermoid or a mature cystic teratoma gone bad. And it's the squamous elements of those tumors that go bad. And you see here, it's clearly a dermoid because there's a fat fluid level. But this solid component is irregular, it's nasty looking, it enhances, and these are really very aggressive tumors that metastasize early and the patients do badly, so it's quite useful to recognize them. And then finally, obviously, you can get metastases to the ovary. Again, they're often bilateral. There is often a history of other malignancy, often gastric or other GI malignancy or breast. And the clinical history is really definitive. And this just to show you on the diffusion-weighted image, these highly restricted, irregular masses in both ovaries. So summarizing the malignant ovarian tumors, again, the T2-weighted imaging is mandatory. The epithelial ones are cystic with no solid components. The other two, the sex-scored stromal and the germ cell, are often completely solid. And gadolinium enhancement, again, is mandatory because it shows the enhancement and the malignant extent of the tumor. So in the final few minutes, I'm going to talk about staging malignant tumors. Well, now that we've characterized our adnexal mass, we want to know exactly how advanced it is because the staging influences the management pathway. So for ovarian cancer, the management pathway is the patient often presents late, sadly, because there's no screening. CT is the imaging modality of choice, and the treatment is either by primary surgical debulking, i.e. surgery up front, or delayed debulking, which means giving neoadjuvant chemotherapy, followed by surgery after 3 cycles, and then some more chemotherapy. So where does MRI fit into that pathway if CT does this so effectively? And then obviously after they've had that treatment, there is an imaging follow-up because it recurs, it's late disease, and where does MRI fit in the follow-up? So to detect, as I said, CT, why use MRI? Basically, the contrast is better. You can not really see the tumor here, but you can see it very easily with MRI because of the higher contrast against the bowel wall. Again, we've talked about contrast enhancement and doing dynamic contrast enhancement to get quantification, and we can do this to look at the extent of masses, get values such as the K-trans and the extravascular extracellular space volume measurements that can tell us something about the aggressiveness of the tumor. On diffusion-weighted imaging, as we apply increasing diffusion weighting, we can see that the ascites, which accompanies this disease, and it's really pathognomonic of this disease, the signal from the ascites diffuses away, the signal from the extensive peritoneal disease is retained, and we get this beautiful contrast of the extent of this ovarian plaque throughout the abdomen and pelvis, and can quantify the tumor burden and its exact location. And we can also get numerical values from the ADC in the peritoneum. The staging accuracy is 91% compared to that of CT or even PET, so I would say that diffusion-weighted imaging is really quite a useful modality here because you can use it to actually locate disease against the bowel wall, because that is where the disease occurs, on the peritoneal surfaces of the bowel wall, and you can do these color-coded maps, as Avis has shown you before. So the skeptics among you, or the cost-conscious among you, can be saying, well, why do that? You can look at this and say, oh, well, there's advanced disease here. We can give the chemotherapy and then see how the patient has done. But in a case like this, for example, you might want to say, well, is this mass, cystic mass, a malignant mass in the first place? And if so, what stage is it? And so that's where the MRI really comes into play. The contrast enhanced imaging you can use, as I say, in a semi-quantitative way to look at, say, how quickly, how extensively the contrast is uptaken, the amplitude of the contrast enhancement, how quickly it's uptaken, so the time takes to reach half the maximum value, and the slope of the enhancement, how briskly it enhances, and all those are characteristic of malignancy compared to benign disease and can be used to differentiate the two. And here's some nice examples, some from Avis's work, looking at this contrast enhancement for the detection of the tumor and also for looking at the extent within the mesentery. The diffusion-weighted imaging also shows the extent of these plaques here, and the two important points I want to make here is not just about detection accuracy, but never use the diffusion-weighted imaging on its own, because on its own it is not that helpful. It is as helpful as T2-weighted imaging, but the power of the diffusion-weighted imaging is really when you use it in conjunction with the T2-weighted imaging. And the other point I want to make here is that there is also a site-specific variation in the accuracy of diffusion-weighted imaging, because just like CT, there are areas that are not so good, such as on the liver surface, high up on the liver surface. Unfortunately, this is an area that's actually very critical surgically, because at surgery, they try to get a complete resection, what they call an R0 resection, where there is no macroscopic visible disease. And it is up on this liver surface that we want to be most accurate to help our surgical colleagues. But in any event, it always does better than CT. So it's better to use diffusion-weighted imaging than CT if we want to precisely locate disease. And then finally, in treatment response monitoring, with ovarian cancer, we have a very good biochemical blood marker, the CA125. And our oncology colleagues will say to us, well, why do you want to use all these fancy and expensive imaging techniques? It's because, in fact, we can tell at an earlier time than the CA125 response that there is a response to chemotherapy with these patients. So you can see that the increase in the ADC occurs after one cycle, whereas in non-responders, there's no such increase. So we've got an early biomarker. But the important thing is also you can look at different disease sites and say one site is responding, whereas another is not. In treatment-naive disease, it's not so important, but often these patients come from multiple courses of chemotherapy because they recur. And in relapsed patients, being able to tell that one particular site is a non-responding site may be helpful if the surgeons can go in and do a secondary debulking. And because it is such a quantitative technique, you can draw a region of interest around the entire tumor burden or the particular lesion that you're interested in and get a distribution of ADC and follow that through chemotherapy. And you can see here that as the chemotherapy is working, in a responding patient, you will get a shift of the ADC to the right, whereas in a non-responding patient or a non-responding lesion, there is no change in the ADC. So with that, I just want to summarize. MRI is useful in the characterization of adnexal masses. When used in conjunction with the clinical presentation, it can distinguish inflammatory from tumor masses. The inflammatory masses, the patients are always sick. T2-weighted imaging alone is useful in describing benign masses. You don't necessarily need any fancy techniques, but if you're concerned about malignancy, gadolinium enhancement is mandatory. Complex masses should always be considered malignant, and surgery is the definitive treatment in all cases. Where malignancy is likely and you're doing staging, diffusion-weighted MRI is a very useful adjunct, but use it in conjunction with the T2-weighted imaging, and you can use it as a quantitative technique for response assessment to neoadjuvant chemotherapy. With that, I'd just like to thank my amazing teams that I work with and our funders, and thank you for your attention.
All right, thank you very much for the introduction. Thank you everyone for being here. I'm impressed to see so many people still here for the last session. I see a lot of familiar faces, so most of you are my friends just trying to be nice to me, I know, but let's get through MR in bladder cancer. I have no disclosures to make. Just to start by telling you a little bit about bladder cancer and why it's important. I'm delighted to have been invited to talk about this topic. Bladder cancer is usually forgotten about a little bit. Most emphasis is made on prostate cancer these days, and bladder cancer is just not something that features very prominently when it comes to talk and when it comes to research. However, it is relatively common. It's actually the 4th most common cancer in men and the 6th most common cancer in women. The prevalence depends on where you hail from. The most widely prevalent areas in the world are in the Middle East and Europe, where the mortality is twice as much as what it is in Europe and 4 times as much as what it is in the US. The typical bladder cancer patient, when you're thinking about epidemiology, is a man. There's a 4-to-1 male to female ratio who is 60 years or older. Most of these tumors from the histologic perspective are urothelial cancers or transitional cell carcinomas. And these are the ones that are associated with risk factors such as cigarette smoking and occupational exposure as seen in the painting, textile, and rubber tire industries. So you start to get a picture of how your typical bladder cancer patient is not exactly the fittest patient. They tend to be older men who are smokers and have occupational risks. A small but important proportion of bladder cancer, especially those seen in the Middle East and Egypt, have nothing to do with urothelial carcinoma. They're actually related to infection by a parasite, Schistosoma hematobium, and those are the ones that are related to squamous cell histologies and account for about 5% of bladder cancers in general. So having talked a little bit about the epidemiology and why it's important to study bladder cancer, in this talk I want to focus on 3 specific points to discuss and where I feel imaging has a great potential to make an impact in bladder cancer patients. The first one is regarding staging or local staging of bladder cancer, and there's a critical step or a critical change where we go from defining bladder cancers as superficial versus muscle invasive, and I'll dwell into that a little bit later on, but it will define basically how patients are going to be treated primarily. The second topic I'll touch upon briefly is going to be upper tract involvement and how we do that. We're in ISMRM, so we'll talk about MR urography, and I'll give you a few of the alternatives of how to deal with that. And the last part of the talk, I'll focus a little bit on the potential role of MRI for treatment response assessment. And in the context of bladder cancer, the key question is, can we use MR, can we use imaging to predict complete pathologic response to neoadjuvant chemotherapy in patients before they go on to have surgery? So I'll explain a little bit more about what I mean there. But let's start about talking about how you do the T staging. I said the local staging. T staging is one of the most important clinical and imaging factors that are going to help determine what happens to the patient. So in bladder cancer, it's all about how far into the bladder wall has the tumor invaded. So just to show you histologically here, the bladder wall has 4 layers from the inside out: the uroepithelium, the lamina propria, the muscularis propria, and the serosa. Basically, bladder tumors are going to start in the uroepithelium and they're going to grow from the inside out. And each of the T stages are going to represent involvement of each one of these different walls, so that a carcinoma in situ or a TA cancer is going to involve the uroepithelium only. Once you have extension into the lamina propria, you have a T1 tumor. Once you have extension into the muscularis propria, and notice the muscularis propria is actually the thickest layer in the bladder wall, then you're in the presence of a T2 tumor, and you'll see why T2 tumors are specifically important in a moment. And once you have extension to the serosa and beyond, you're in the presence of a T3 tumor. The reason why I say T2 tumors are extremely important, and again, T2 involves the thickest layer of the bladder wall, the muscularis propria, is because once that's involved, we're in the presence of a muscle invasive bladder cancer. These account for about 1/3 of all bladder tumors, and they are usually treated with definitive therapy, most often in the form of radical surgery, can also be done with radiation therapy. If you have a T1 cancer or below, these are the ones that we're going to categorize as superficial bladder cancers.
They're the vast majority of bladder tumors, 70 to 80% of them to be precise, and they're the ones that are usually treated with local therapies, most often transurethral resections, alone or in combination with instillation intravesically of BCG or other similar substances. So if we're saying that we're going to base the management on what the pathologic staging is going to be, then it would be a fair question to ask, why would we need imaging? Can't we just do a biopsy, determine what the T stage is, and decide how we're going to treat this patient? The answer is, in some cases, imaging is not needed, but cystoscopy and biopsy do have their limitations, and these are well known. The first one is that, as you can imagine, the bladder wall is a very thin structure. So when you're trying to biopsy a mass that comes right up against the bladder wall, a lot of times you want to be careful that you don't perforate right through it and perforate the bladder wall. What that means is that relatively often when a bladder mass biopsy is performed, when the pathology report comes back, it says the muscularis propria layer was not included in the biopsy specimen. In other words, you biopsied the bladder mass, you got the histology, you got the diagnosis of cancer, but in terms of staging, the needle didn't go deep enough to reach the muscularis propria, and therefore you can't make that key differentiation that we talked about between superficial and deep tumors. And this is just to show a real life sample. This is just a typical transurethral biopsy report from my institution. They tell us about what the tumor type is, what the histologic grade is, what the pattern of growth is. But when it comes to local invasion, see, this tumor is said to involve the lamina propria, so it's definitely at least a T1 tumor. But when we're trying to decide, is this a muscle invasive tumor, we see this section here saying muscularis propria not identified. So then how is this patient going to be treated? You're still having the same conundrum. You don't know if it's a superficial tumor or it's a muscle invasive tumor, and that's where imaging can have a big role. There's other limitations of the cystoscopy and biopsy approach. Neither of them, for obvious reasons, can tell us anything about extravesical spread, nodal spread, or metastatic disease. The cystoscopy is not perfect, so some tumors may be overlooked when it's performed. And a well-known fact is that perhaps for the same reason that usually urologists are careful not to perforate the bladder wall when performing a biopsy, pathologic upstaging from biopsy to cystectomy is common and occurs in up to 40% of cases. So how does this all look on imaging, on MRI? So the morphologic assessment is performed with T1 and T2 weighted images. This is a T1 weighted image here on your left. It's not very useful for assessment neither of the wall or bladder masses. Basically, the urine is dark and the bladder wall is dark, so you can't really differentiate between them. You have no contrast. When we have T2 weighted images, now the bright urine helps us see much more clearly what the bladder wall looks like. It's seen as a thin, dark T2 signal structure surrounding the entire urine. And basically, most of the signal that we're seeing in the bladder wall is going to come from the thickest layer that we talked about, the muscularis propria. Once we have a tumor, a bladder tumor, it's usually going to be of intermediate T2 signal intensity, and we enter into this concept of trying to decide, is this a superficial tumor or is this a muscle invasive tumor? The way to do it on morphologic T2 weighted images is to identify the low signal intensity of the muscularis propria in the bladder wall and try and see if you can actually follow it all the way around the area where the tumor is located. If you can convince yourself that you can see that uninterrupted low T2 signal intensity from the muscularis propria all the way around the tumor, then that means you're in the context of a superficial bladder tumor. The opposite is also true. If you have an intermediate T2 signal intensity from the tumor that seems to be encroaching or digitating into the muscularis propria and breaking that low T2 signal intensity ring, then you are in the presence of a muscle invasive tumor. Extravesical invasion is usually a little more straightforward to do. This is an anterior tumor, usually typical location for a urachal adenocarcinoma with obvious digitation of soft tissue into the anterior perivesical fat. So this is a T3 tumor. And once you have invasion of the adjacent organs, like in this case a man, so the prostate here is invaded, you're in the presence of a T4 tumor. Now, there are pitfalls for T-staging on MRI. It's not always straightforward. By far, the most common problem that we have when we're trying to stage bladder cancers is overstaging. And the overstaging comes from the fact that most of these patients, by the time they reach us, have already had some sort of manipulation done to their bladder, usually in the form of a transurethral resection, and that generates inflammation that is sometimes very difficult to differentiate from tumor on our images. This is just an example here. For all intensive purposes, you see the low signal intensity on T2 weighted images of the muscularis propria. You have intermediate T2 signal intensity here, which looks like tumor. It's even enhancing like tumor, but this patient had neoadjuvant chemotherapy and subsequently went for surgery, and the pathologies showed complete response, so there was no residual tumor. This was all just related to post-resection inflammatory changes. So by now, there's clear data and a lot of data in the literature showing that diffusion-weighted imaging improves our accuracy for T-staging on MR. This is just an example from one of the early papers. The principle is that, number one, the muscle-invasive tumors are going to have a higher extent of diffusion restriction, but perhaps more importantly, when evaluating these images qualitatively, is the fact that the non-muscle invasive or the superficial tumors tend to have a smooth outline, as we see on the image from the patient on the top here, whereas on this other patient at the bottom, the outline is more spiculated or irregular, and that's a very strong sign, an indicator that this is a muscle-invasive disease. As I said, one of the early papers, 2009, showing improvement in accuracy from 79 to 96% with implementing diffusion, and a modest further increase when using qualitative evaluation of contrast enhanced sequences in addition. Since then, there's been a number of publications. This table here is from a paper published in 2014. All the papers show more or less the same. Diffusion definitely helps and demonstrates incremental value compared to T2 weighted images alone. We are already seeing how these papers introduce the concept that quantification of the extent of diffusion restriction may also be relevant, and I'll talk to you a little bit more about that in just a moment. This other meta-analysis that I've cited here at the bottom looked at, I think, 28 papers or something like that, and overall a pooled sensitivity of 0.85, specificity of 0.90, and AUC of 0.92 was found for differentiating muscle versus non-muscle invasive bladder cancer. So as I mentioned earlier, quantitative diffusion has also been explored. Significant differences have been shown in ADCs between tumors of different stages and tumors of low grade versus high grade. Note that one of the main problems when it comes to trying to apply these concepts into practice is that even though there's statistically significant difference in the means of the ADCs between the different stages and grades, there's still a lot of overlap, so that it's at this stage impossible to establish a threshold above which or below which you can call it one stage or another. So significant trends, significant associations, but still quite some way to go before this can be used routinely for clinical purposes. Some hope that applying a diffusion kurtosis model for the diffusion data could help reduce a little bit of that overlap. This is a paper published last year, and basically it showed, as had been found before, that low ADC is seen in bladder cancer compared to the normal bladder. In addition, the two kurtosis parameters that were evaluated, the revisionary diffusion coefficient and the deviation from the Gaussian distribution, were significantly different as well between bladder cancer and normal bladder. However, the hope, and all of these parameters were also able to differentiate low versus high-grade tumors. However, the hope that the DKI was going to be better than the simple ADC metric didn't materialize. Unfortunately, as reported in this paper, they weren't significantly different, neither for differentiating cancer from normal bladder wall or for differentiating cancer from high-grade tumors. So we know diffusion helps, especially qualitative assessment. Is there a role for contrast? This is from the same review paper, 2014, summarizing most of the literature that has been out there about the use of contrast in bladder cancer. Some of the very early literature, 1996, was already talking about important issues such as the timing of the contrast enhancement of the bladder tumors compared to the bladder wall. And this paper, for example, showed that the bladder cancer enhances approximately, on average, 4 seconds earlier than post-biopsy tissue. So maybe some opportunity to exploit the concepts under dynamic contrast-enhanced MRI to our advantage. For the most part, if there is no inflammation, if there's been no transurethral resection, contrast is actually very good. It does improve the accuracy compared to T2. The jury is still out there with regards to does it actually improve the accuracy when you take into consideration the information from T2 and diffusion combined. There's very few papers that have actually tried to address or evaluate this issue. This paper by Gupta et al. Published last year did a stage-by-stage analysis and basically reported very similar accuracies and correlations between the imaging findings and the pathology for diffusion and DCE MRI. And in fact, 83% of patients had absolute agreement between the two sequences. So no hint here that one or the other is going to be best. This other paper by Zhu, published in 2014, looked at the ADC from the diffusion and the washout rate from the DCE MRI, found them both to be associated with bladder cancer aggressiveness. But again, if you focus on this and remember what I showed 2 slides ago, you have a similar problem. So there's a significant differences in the mean, but the box and whisker plots show that there is a lot of overlap between the parameters. So still at this stage, neither with diffusion or with DCE, you can actually establish a threshold for any of these parameters to try and decide about a stage or decide about a grade. I wanted to mention some other novel approaches that have been reported. For example, this paper published in PLOS ONE in 2014 found that ADC, and this is just the standard mono-exponential mean ADC value, was not only associated with T stage and with grade of aggressiveness, but also with markers of proliferation or proliferative activity, such as P53, P21, and Ki67. And actually, on multivariate analysis, only the ADC and the P53 were independent predictors of muscle-invasive disease. This other paper from the NYU group, published last year, took an approach of doing a whole lesion analysis. Up until now, every paper I've discussed here has focused on a single slice ROI measurement on a representative area of the tumor. This paper tried to analyze the entire lesion, so put a volume of interest and ROI over every slice where the tumor was seen. As in all the other papers, it found that ADC was lower in muscle-invasive tumors. The kurtosis, and this is not the kurtosis from DKI, it's the kurtosis derived from the histogram analysis, was lower in patients who had nodal metastasis, but was not in itself associated with the T stage. So the conclusion of that paper was that maybe you can use both. You can use the ADC value for its association with the T stage and use some of these more fancy histogram volume-derived parameters to establish extent of disease. So the second and third points I'm going to talk about will be quicker. The second one is regarding upper tract involvement in bladder cancer, very important concept. It happens in about 4 to 5% of patients with bladder cancer. The problem is it can happen at any time. It can happen at the time of diagnosis, at the time of presentation. It can happen during initial treatment, after initial treatment, any time during follow-up. So it's a big deal, first of all, to continuously have to evaluate this, and second of all, to deal with it if something is identified. So traditionally, the thought is that CTU and MR urography are equivalent somehow from the diagnostic perspective. Most times CTU is performed in clinical practice, but more and more MR urography is growing in popularity and is obviously also an alternative when there's allergies to iodine contrast from the CT. However, some recent papers, including this one published last year, found that actually MRU has better sensitivity than that CT urography, but still imaging cannot replace the approach of cystoscopy and biopsies, given that there were a number of tumors that were seen on cystoscopy that weren't seen neither with MR or CTU. So it still remains sort of staging mechanism rather than a primary diagnostic. With MRU, we take advantage of the different methods for evaluating the renal collecting systems and ureters that MR affords, such as evaluating through static fluid techniques that can be various forms of T2 weighted images, including this 3D respiratory triggered heavily T2 weighted FSC sequence that David showed quite elegantly in the talk this morning. It's akin to the MRCP-like sequences and very good for delineating the ureters without having to use intravenous contrast. The other obvious option is the use of contrast and excretory urography, deemed excretory urography because of the underlying principle of filling the pelvic calyceal systems in ureters and evaluating for the presence of filling defects indicative of tumor. But actually, once you give the contrast, you can take the opportunity to evaluate the kidneys in the parenchymal phase as well, about 80 seconds after administration, and that gives you a chance to see flat tumors that present themselves as urothelial wall enhancement or tiny nodules that have enhancement. And obviously the excretory phase, the literature reports variable timings for the excretory phase ranging from 5 to 12 minutes, but usually what we're looking for there are filling defects, and these are just two examples of essentially what we're looking at in the lower pole calyx in this patient and in the left upper pole calyx in this other patient. So MR urography has its limitations. Most of them are related to the difficulties with the technique and the experience that the group needs to have in order to get good quality images. There are well-known artifacts associated with MRU, most of which are associated with MR in the abdomen and pelvis in general, motion, the presence of calcification not dealt very well with, artifacts from surgical clips and flow-related artifacts, especially in those heavily T2-weighted 3D images that we see. Now, one of the things that has traditionally hampered a little bit the use of MRU has been that if you need to stage the bladder cancer and you need to image the upper tracts, it's been a little difficult to negotiate how you're going to do to evaluate the contrast enhancement of the bladder, and at the same time, how are you going to evaluate the upper tract? So the timing of the contrast and the type of the sequence doesn't quite work out most of the time, and usually that led to two separate examinations, and usually that was a bit of a problem. This paper was very interesting here, published very recently by, again, our group at NYU here. We have Hirsch in the audience, prior speaker. Simultaneous high temporal resolution quantitative perfusion imaging of the bladder together with conventional multi-phase urography. So this essentially solves that issue we just talked about. Essentially, they did a golden angle radial sparse parallel sequence, a GRASP sequence, where the raw K-space data is acquired continuously. So there's no need to have a predetermined temporal resolution, and then basically the data can be reconstructed retrospectively at variable temporal resolutions of interest to simultaneously evaluate the primary bladder tumor and the upper tracts. So this is an example taken from the paper. Very nice. I believe the temporal resolution was about 2 seconds or so, but you can get the picture of the time to signal intensity change curves between the bladder tumors and the blood pool. And you can make quantitative DCE measurements and get differences here, for example, the K-trans differences between the normal bladder and the bladder tumors. And you can get different post-contrast phases of the kidneys and the upper tract. You have an excretory phase here on the right-hand side and some earlier phases of enhancement before that. So final point, diffusion to predict pathologic response to chemoradiation. Why do I even think that that's important? Why did I include it as one of the 3 points that I had to choose about bladder cancer? Number one, in bladder cancer, it's a fact that neoadjuvant chemoradiation has been shown to have a survival advantage. So theoretically, you want as many patients to undergo neoadjuvant chemoradiation prior to surgery as possible. However, the chemotherapy is very intensive. It's debilitating. Remember our typical bladder cancer old, smoking man is not very fit to tolerate the chemo and the surgery. And the problem is, right now, every patient who has neoadjuvant chemo-RT will go on to have surgery, regardless of whether there's pathologic response in the bladder or not. And that's because we don't have accurate enough non-invasive techniques to define the response to chemotherapy. So if we were to develop something that's sufficiently accurate to be used, it is possible that in the near future, some of the patients who have neoadjuvant chemotherapy may not need subsequent surgery, as in the case in other tumors already, such as rectal cancer. So encouraging results published to date. This is a 2012 paper here showing significant differences in mean ADC values between chemoradiation sensitive patients and chemoradiation resistant patients. Not a lot of overlap in the box and whisker plots, so maybe something that could be used moving forward. This one is also very interesting, published JMRI last year. Instead of DWI, this paper used DCE. And basically, it used a clustering algorithm, a k-means clustering algorithm, to separate out within the tumors areas that had variable combinations of these two DCE parameters, the KEP and the signal intensity amplitude. So a cluster 1 with low both parameters, cluster 2, one parameter low, one parameter high, and cluster 3 vice versa. And essentially what this helps do is tap into the concept of tumor heterogeneity. It doesn't have to be that the whole tumor behaves in the same way, and there may be that there is a cluster that behaves in a particular way that's going to define how the tumor is going to change and evolve. In this particular case, all the 3 clusters that were determined were associated with chemo response. However, one of the clusters, cluster number 2, had the highest area of the curve, 0.96 for defining and predicting the presence of response. This is an example of how they did that. You can see the tumor with the variable colors representing different clusters. You can see the cluster representation on the graph here, and you can see the association between the clusters and the chemotherapy response here. So interesting concept. Maybe the answer lies here. Maybe when we try and make these metrics that are basically averaging the findings of DCE or diffusion throughout the whole tumor, we're losing out on this heterogeneity concept, which is a known feature both from the pathologic perspective, genomic perspective, from many other tumor biology related perspectives. So maybe that is the way that we should try and think about our imaging moving forward. So I finished with this slide, PET MR, simultaneous with this session. There's been another session all day that's been talking about this. Obviously, we're in ISMRM, and this is an MR bladder talk, so I've focused on the use of MR in bladder cancer. However, there is plenty of literature that talks about the usefulness of PET-CT in bladder cancer for exactly the same purposes that I focus my MR bladder talk here. Most of the literature is about the standard fluorodeoxyglucose or FDG PET, but there's also some literature on more novel tracers, choline and acetate. It may be that in the future, PET-MR can play a bigger role in bladder cancer as well. So far, the only paper I could find in the literature is a focus on the technical component of the PET-MR acquisition, something that is indeed very relevant, especially for bladder cancer, and is not only relevant to PET-MR, it's probably relevant to MR per se. This paper was trying to think about sequential versus simultaneous acquisition of the PET and the MR data. And if you think about bladder cancer, and if you think about the bladder lumen constantly filling as we're doing the exam, even if we're doing just MR, it means that what we're seeing when we're doing the beginning of the exam may vary slightly compared to what we do later in the exam. And especially for acquisitions that last a few minutes, it means that the tumors and the bladder wall and all the structures in the pelvis are going to be moving along the time. And that has to be dealt with because it causes specific difficulties when it comes time to try and quantify and make any specific measurements. This is an obvious example. You see the difference in the registration of the PET data on the background in the orange and the MR data when the images were acquired sequentially, first the PET and then the MR, and you see how they fit much nicer when the images are acquired simultaneously. So it makes sense, but something important to keep in mind. So with that, I thank you and open the floor for questions or comments. Thank you very much.